पहले चाबी के लिए दौड़ते थे हम लोग कि आउट रूम खोल दे कोई पासवर्ड के लिए पूछते हैं पासवर्ड मिलता है तो आप शुरू में विल टेक ओवर ना फर्स्ट हाँ तो कैसे निश
give a good morning to everyone sir and I'll speak about the societies and this year is this is the 25th year and the next 2 days is a hybrid conference with an academic feast of knowledge and inspiring stories and then I will progress to the society acknowledges the work and contribution of those who have dedicated their lives to the progress of knowledge and improvement in outcomes in patients through progress medals which is the most prestigious award.
आराम से बोलना धीरे धीरे
Yes, sir.
जो तुम बोल रही हो ना for decades it will be heard in the tube
Sir.
और इस समय
हाँ हो गया. हेलो हेलो. ऐसे नहीं रुकना चाहिए. तो जो महक कह रही है कि वेलकम टू द 21st बाइएनियल मीटिंग ऑफ द एशियन एंड इंडियन सोसाइटीज फॉर पीडियाट्रिक यूरोलॉजी. ये तो वेलकम नोट है. पहले तो she will come ना.
Yes sir. तभी मैं इधर एक चेयर पर.
Can I keep my papers here?
Yes, sir.
Take a seat. Look, after really relax. आगे वाली मीटिंग्स में ये जो क्लोजर टाइप का करना है तो बता दो, डिस्कस करते हैं. यस सर. ये है चिकन टाइप्स ओवर.
A very good morning to all the dignitaries and residents, and a very warm welcome from the All India Institute of Medical Sciences, New Delhi. We welcome you all to the Silver Jubilee year of the Asian and Indian Societies of Pediatric Urology. The Asian and Indian Societies of Pediatric Urology were established in 1998 and have had their biennial meetings since then. The educational manual of the society is the Progress in Pediatric Urology, which focuses on the recent advances and progress in the field of pediatric urology. This year's 21st Conference of Pediatric Urology Update by the Society is a hybrid conference and we look forward to having a 2-day academic feast of knowledge and inspiring stories from pioneers across the globe, and hope this stimulates bright future endeavors. The Society acknowledges the work and contribution of those who have dedicated their lives for the progress of knowledge and improvement in outcomes of our patients through Progress Medals, which is the most prestigious award and has been awarded to the pioneers in clinical research in the field of pediatric urology. Last year, the Progress Medal was awarded to Professor Ahmed Hadidi. We start the conference with a welcome note by Professor Meenu Bajpai, Professor and Head of Department of Pediatric Surgery, All India Institute of Medical Sciences, New Delhi. Professor Meenu Bajpai is Professor and Head, Department of Pediatric Surgery. He is the Executive Director of the National Board of Examination in Medical Sciences. Sir is also in charge of the Center for Advanced Research in Congenital Uropathies and Chronic Kidney Diseases. Sir is Professor in charge of International Cooperation and Domestic and Internal Affairs. He has been the past president of the Indian Association of Pediatric Surgeons and editor-in-chief of the Journal of Progress in Pediatric Urology. Sir was also past editor of the Journal of Indian Association of Pediatric Surgeons. He has over 150 publications with special interest in urology as well as research. He is very well known among the residents for his charismatic teaching skills. I would like to welcome Sir to the podium to announce the awardee for this year.
Thank you, Mehak. A very good morning to all of you across the globe, particularly Dr. Boyer and Dr. Martin Coyle, who have joined us for this occasion. Founded in February 1998, we are into the 25th year of these societies, as has been told. We hold biannual meetings, but we run round-the-year courses for all these years. This year's awardee for Progress Medal is Professor Martin Allen Coyle. I first came to know about Martin way back in the early 90s. And at that time, he was in Colorado. And he was there for many years. In fact, Colorado and Martin was synonymous for me for even now. He has held several very prestigious positions, and he still holds one of them. He was division chief at Colorado Children's Hospital, professor of surgery at University of Colorado, vice chair of the Division of Urology from 1989 to 2009. He was there for almost 20 years, as I said. He trained extensively before settling into academics. He pursued general surgical training at Los Angeles. He attended the Harvard program in urology. He went through fellowships in organ transplantation, pediatric urology at UCLA. He holds an MSc in quality improvement in patient safety, a master's in management at McGill University, an MBA certified from Tulane University Freeman School of Business. He has written extensively. I would recommend all of you to read what he has written, particularly his experience of 30 years on hypospadias. Well, one can go on and on, but today it is a privilege of our great friend, Professor Boyer, to offer tribute to Martin. A few words about Boyer before I hand over the mic to him. Professor Boyer is an astute academician, just like Denver and Martin were synonymous to each other. Harvard Medical School and Professor Boyer are synonymous. He has been there for 50 years, even more. He established the first urodynamic lab in Harvard. It still exists in its most finest form today, the best in the world. He has written extensively on every aspect of pediatric urology, be it hypospadias, be it congenital anomalies of the kidneys, be it even tumors. But his most notable contribution has been on neurourology and lower urinary tract dysfunction. He has indoctrinated a generation of pediatric urologists across the globe, decade after decade, including myself, my trainees, and so on. That has been the impact. That is how he has changed the lives of thousands and millions of people across the globe, patients who were sufferers and that quality has improved. I've seen his patient. He has visited at AIMS. I'm very proud to say he was the awardee for the Progress Medal way back in 2009. Whenever he came to India and to the institute, we discussed complex problems with him. I remember patients still tagging on to him and pursuing him. I would request Professor Boyer to pay his tributes. It's a day which belongs to Martin, and the privilege of offering tribute goes to Professor Boyer. Professor Boyer, please.
Can everybody hear me?
Very well.
Great. So, dear Marty, Professor Bajpai, honored members and guests of the association and attendees to this conference, it gives me great pleasure to introduce Dr. Marty Coyle as the winner of this year's Pediatric Urology Progress Medal at the IAPU and APU annual societies meetings. I met Marty many years ago when he was a urology resident at the Brigham and Women's Hospital in Boston. At that time, although initially not focused on pediatric urology as a career choice, he became interested in it when he rotated on our service at Boston Children's Hospital. After completing his urology residency at the Brigham, he accepted a fellowship in pediatric urology at UCLA under the tutelage of Drs. Richard Ehrlich and Jacob Rafer. After completing his specialty training, he remained at UCLA for 5 years, eventually becoming director of pediatric urology at LA County Hospital. In 1991, as Dr. Bajpai mentioned, he moved to Denver, where he assumed the chairmanship of pediatric urology at the Children's Hospital, remaining there for 17 fruitful and productive years. In 2008, he moved to Seattle to become the Michael E. Mitchell Endowed Chair in Pediatric Urology at Seattle Children's Hospital. In 2011, he returned home to Canada, where he first assumed the program directorship for urology at the Hospital for Sick Children in Toronto. And then in 2013, as his leadership skills were recognized, he was named chief of the Division of Pediatric Urology and Women's Auxiliary Chair at Sick Kids. 7 years later, in 2020, he retired. Given his restlessness, drive, and inquisitiveness, he didn't exactly retire. He accepted an academic position at the University of Minnesota in Minneapolis, where he now works part-time. Despite this peripatetic career, Marty has accomplished an impressive amount of impressive amount as an academician, advancing our field of pediatric urology to new heights of excellence. He was promoted to the rank of professor in Denver, Seattle, and Toronto, as each of these institutions acknowledged his academic prowess. Marty has received numerous honors that will take more time than I'm allotted for this introduction to note. One of his cherished moments occurred when he received the award for excellence in teaching from the trainees at Sick Kids Hospital. This was his mantra. He related to me one of his greatest thrills was being asked to present his work and write a review on the development of hypospadia surgery from its early beginnings up to its current form at the Third World Congress of Pediatric Surgery in Delhi in October 2010. Two additional honors that he has cherished were his election to the Royal College of Surgeons of England in 2009 and being awarded an honorary lifetime membership in the British Association of Pediatric Urologists based on merit in 2019. When one peruses his CV, it is impressive to see how many extracurricular activities he has been involved in during his long and illustrious career. He has served on the editorial boards of many prominent pediatric urology peer-reviewed journals. He's been an executive committee member and then president of several prominent pediatric urology societies, including the Society for Pediatric Urology, the American Association of Pediatric Urology, and the Rocky Mountain Urology Society, among others. He was part of several task forces for the American Urological Association to improve the management of children with urologic disease. Irrespective of his academic achievements, Marty has also been a consummate citizen, as he has served on a multitude of important committees during his tenure at each of these institutions he has been affiliated with and fostered the education of numerous trainees. Marty is a gregarious, thoughtful, inventive individual who can be both serious and funny at the same time. At the Wee Willie's dinner in Miami 2 months ago, Marty was honored by his peers, one of the highest levels of recognition one can receive for all that he has contributed to pediatric urology, both scientifically and socially during his long and illustrious career. During the ceremony, many laudatory words from people near and far were bestowed on him. As has been his wont, he did not let this swell his head, accepting the praise with humility and grace. This is a major reason why Marty and I have been great friends and why I cherish our relationship so much for all these years. At this time, I would like to share some pictures of Marty at work and at play before he actually receives this prestigious award. So I'm going to try to share my screen. Let's see. Yeah. Just a second. Share. Okay. Okay. Oh. Can everybody see that? Let's see why that didn't go. Just a second. I don't know why that's giving me. Okay. Everybody see that now? Okay. So Marty has been involved in a number of medical missions around the world, and he has been an ambassador for pediatric urology. Here you can see him in Calais, Colombia, Saudi Arabia, Turkey, and Brown University in Rhode Island. He's been to Gaza, Uganda, Rwanda, Guatemala, and the West Bank, teaching and spewing forth all his knowledge to help surgeons and physicians take care of children with urologic disease. In Egypt, you can see he relaxed a little bit, riding a camel, horses, smoking, but also working on important cases at the same time. As was mentioned, he became chairman of pediatric urology and named the Women's Auxiliary Endowed Chair in Urology at Sick Kids in 2013. And here he's receiving the award and the position from the Surgeon in Chief. And then below that is all the members of the department of the Division of Pediatric Urology at Sick Kids at the time. Marty has numerous interests. As you can see, he started playing hockey when he was a child, and he played for the Southern California Blazers in the late 1980s, and they won a championship one year. 10 years later, he played for this defenseman for the Colorado Scorpions. He enjoys skiing. He's a marathon runner, and here you can see him with Ellen, his wife, after he completed one of his many marathons. He likes to bake and has been a chef working at the Ritz for a while, producing these breads and donuts and other goodies with the pastry chef. He likes to paint. And you can see on the right-hand side his rendition of Van Gogh's Starry Night. I think it's worth almost as much as what the original is valued for. He likes to play golf. And I must say, you know, he's not a great golfer, and that's why they imprinted his face on golf balls so that when he hits it into the woods in the rough, it becomes easy to find. He likes to show off as a fashionista. You can see here as a clown, macho man, and you can see he just enjoys life. He's a food critic as well. He knows, you mention a city and he knows the best restaurants in those cities. In fact, I've asked him for recommendations when we've traveled around before COVID hit the world. Younger days, he was a musician. He played in a rock band and learned to play the piano. Here he is singing. He also enjoys listening to the Blues Brothers, and one of his favorite artists is Justin Bieber. His stage name was Marvin the Man. But despite all his moves and everything, he's been a true Canadian at heart. As Dr. Bajpai mentioned, he has received additional degrees from the University of Toronto, where he received a Master's in Science in Quality Improvement and Patient Safety. He has a Master's in Management from McGill University, and he did an online MBA from Tulane University. Currently, despite his being, quote, retired, unquote, he is a faculty for the University of Toronto for Quality Insurance and Patient Safety, and a Master's in Systems Leadership and Innovation in Learning, Health Systems and Wellness. He's on the faculty at McGill University in their International Master's Health Program, and at the University of Minnesota, where he's an adjunct professor mentoring the pediatric urology faculty and mentoring residents in quality and improvement projects. Besides all his professional work, Marty enjoys being with his family. Here he is, Ellen in the middle, and his 3 children, Alex, Charlie, and Claire. In later years, he celebrated milestones of Charlie and Claire's graduations and marriages. And of course, he loves being with his grandchildren. So before I close, I'd like to just mention 3 things. One, Marty, as I said earlier, Marty was named a fellow to the Royal College of Surgeons in England. He was given an honorary degree because of his merit to the British Association of Pediatric Urology. And 2 months ago was awarded, this was actually a delay of 2 years because of COVID and the cancellation of the event 2 years ago, but he was honored by his peers in the Wee Willie Society of American Urologists. So it's been a wonderful tribute to Marty. When I actually wasn't asked to do this, but I volunteered because I think Marty is a terrific guy and well deserving of this honor from the Indian Association of Pediatric Urology and Asian Pediatric Urology Societies. So with no further ado, I want to congratulate Marty Coyle on this achievement for a lifetime of giving. Thank you.
Thank you, sir. I would now request Professor Bajpai to present the medal to Professor Martin Coyle. Thank you, sir. I would now like to invite Professor Martin Coyle to speak a few words to inspire the young and upcoming pediatric urologists.
Thank you so much. And it's an extremely humbling experience to have the opportunity to speak to you tonight, especially after being introduced by Stu Bauer. And it's interesting how we look at life and how we evolve and how we grow with time. And this is a bittersweet evening for me. One, I look at the strife in the world, what's happening in the Ukraine and Russia right now. I think of COVID still impacting us so that we're not seeing one another face to face. And sadly, one of the previous recipients of this award, Dr. Bauer's mentor and my mentor, Alan Reddick, passed away this evening. So it's very bittersweet to hear that news. At the same time, I think it's funny how we grow. And this is what the message I want to give to the young people is Stu and I started off when he was Dr. Bauer to me. He was not Stu because he was my professor. He became a peer ultimately, and peers don't have to be friends and friends don't have to be peers, but ultimately with time, as Stu acknowledged, we became great friends. We were able to share opinions. We were able to share challenges. We were able to share happiness and sadness as well, because we did have personal sadness in both of our families. I think the one thing I say to all of you who are listening tonight is that what friends are trusted companions. We can share our joys and our frustrations with one another. We believe in one another. We have opportunities that are truly unique because based on our small community that we have in pediatric urology, we can start off at just a peer meeting. We become casual friends. Ultimately, this may develop so that we have more than a cup of coffee or tea with one another, and we become more superficially friendship and may have a dinner. And ultimately, we may be fortunate enough to develop friendships like the one I have with Dr. Bauer that become lasting and supportive and truthful. So we go from acquaintances to casual friends to close friends, and ultimately we are fortunate enough to develop some intimate friendships. We're able to disclose things with one another, provide empathy, trust, social interest, and we're listeners for one another. But I also want to talk about one of the negatives of peer pressure. We're competitive in our own environments. Yes, we may smile at one another, but we want to be successful. And peer pressure can be positive because it can stimulate us to grow and it can be beneficial, but it can also be negative because it can impact the way we behave to one another. It impacts the ability to make the decisions independently, and it impacts our individuality and our creativity if we have to jump on a bandwagon to look good. So I think it's very important that we understand one another and we don't fall to prey to the negatives of peer pressure. So to all of you, I want to just say that many of you are peers, many of you I've never met before, but there's also many in the audience who I know, and many of the speakers who have become more than peers to me. And with us, we've developed encouragement, safety, a sense of identity, curiosity, learning, discovery, and closeness. Next to our parents, our friends have the greatest influence on our behavior. And hence, choosing our friends is one of the most critical decisions that we'll ever make because they become our role models. They expand our community and they influence our culture as a whole. And I'm just going to finish by quoting a controversial figure, Eric Fischel, who's an American artist who's been compared to Degas, modern day Degas. And he said that connecting to one another is one of the most important things in the world. And you can keep expanding that connection. One person, a family, a community, a country, a society, and a culture. So to all of you, I think we're fortunate because we have the opportunity in our community to develop countless new friendships. And certainly it's a lot easier when we can do this in meeting. We can share wonderful experience with one another and broaden our perspectives, not only in medicine, but far beyond. And of course, importantly, especially for older people like me now, we can be supportive at times of need, both personally and professionally. So I think my final tips to all of you that I've learned through friendships and growth, and from Dr. Bauer, from Stu, listen to each other. Don't put each other down or hurt each other's feelings. Understand each other's feelings and moods and accept their differences. Help each other solve problems and invite questions. Challenge one another. Disagree without hurting each other. That is, respect each other. Be dependable and trustworthy, and give each other room for change. So finally, I'll quote from the great American author, Mark Twain. Keep away from people who try to belittle your ambitions. Small people always do that, but the really great make you feel that you can become great. When you are seeking to bring big plans to fruition, it is important with whom you regularly associate. Hang out with friends who are like-minded and who are also designing purpose-filled lives. Similarly, be that kind of friend for your friends. So again, I'm truly honored to receive this medal tonight, which I hope you can see. And it's got my name inscribed on it as well. And it's really a privilege to have had this opportunity to speak to you, and a great privilege to have the medal presented by my friend, Stu Bauer.
You're here.
At a late an hour, and obviously the world is under turmoil. I hope things settle down. But we begin, and I declare this conference open. This meeting would lead into the next full year with multiple courses to peak into the Silver Jubilee days, 3 days of meeting in 2023, 7th, 8th, and 9th of February. I hope that then all of you can join us in New Delhi, and we would have a live one-to-one meeting. So I declare it open, and I will ask Mahek to proceed further, please. Thank you.
Thank you, sir. I would now like to request Dr. Sachidanand to speak and share a few words about the society and the latest information. Thank you.
It is on February 17 in 1992, and eminent and scientists, including the likes of Professor John C. John and Professor Jayant Radhakrishnan. This is the 25th year of our society, and we have organized 21 meetings in India and abroad. We have also hosted 14 joint meetings, and all major topics of pediatric urology have been discussed and covered in these meetings. These milestones are meant to be celebrated and also to be surpassed. So, in this calendar year, we have planned 3 meetings in each quarter, and major topics like neurogenic bladder, differences of sex development, and minimally invasive urological surgeries in children will be discussed in these meetings. We will release the latest information on these meetings on our website. Lies the education in the field of pediatric urology, and the motto is let us all learn together. The year 2023 is the silver jubilee of our societies and marks the completion of 25 years of our societies. We are planning a global plenum on pediatric urology and
it is my privilege to represent these societies today. Our first meeting was held on February 7th and 8th in 1998, and eminent pediatric urologists and scientists, including the likes of Professor John P. Gerhardt and Professor Jayant Radhakrishnan, attended this meeting and made it a success. This is the 25th year of our societies, and we have organized 21 meetings in India and abroad. We have also hosted 14 joint meetings, and all major topics of pediatric urology have been discussed and covered in these meetings. These milestones are meant to be celebrated and also to be surpassed. So, in this calendar year, we have planned 3 meetings in each quarter, and major topics like neurogenic bladder, differences of sex development, and minimally invasive urological surgeries in children will be discussed in these meetings. We will release the latest information on these meetings on our website. Also, the World Federation of Societies for Pediatric Urology has inaugurated a global section which is known as Digital Pediatric Adolescent and Developmental Urology and has an abbreviation of DPAD Urology. The aim is to globalize the education in the field of pediatric urology, and the motto is let us all learn together. The year 2023 is the silver jubilee of our societies and marks the completion of 25 years of our societies. We are planning the global plenum on pediatric urology and expert consensus and position statements on A to Z of bladder exstrophy epispadias complex, posterior urethral valve, vesicoureteric reflux, pelviureteric junction obstruction, and neurogenic bladder will be discussed in the next year. Being a big hit this year, we will organize our annual lecture awards, and as in 2022, they will be known as Silver Lecture Series in the year 2023 as well. We will award one mid-career and one early career pediatric urologist. The applications for the Young Investigator Award for the year 2023 will open on September 1st of this year, and the latest information about this will be released on our website. The forthcoming issue of our journal, Journal of Progress in Pediatric Urology, will be on bladder exstrophy epispadias complex. Last but not the least, there is a special issue in MDPI Urology on bladder exstrophy epispadias complex, which is guest edited by none other than Professor Meenu Bajpai. The issue deadline is October 31st, and we invite bladder enthusiasts and our colleagues to submit their research papers in this issue. Thank you. A very warm welcome to all of you. A very warm welcome to all of you. I have no disclosures to make. In the present era, smart learning and e-learning have a special place. It actually complements the traditional didactic bedside teaching. In addition, the present COVID-19 pandemic has sped up digital transformation and has boosted this smart teaching. Although the principles of surgical teaching revolve around apprenticeship, newer concepts like globalization of training in pediatric urology have emerged out in the past decade. Thus, the World Federation of Societies for Pediatric Urology have inaugurated a global section which is known as Digital Pediatric Adolescent and Developmental Urology, with an abbreviation of DPAD Urology. Our motto is, let us all learn together. The objectives are to establish a global learning ecosystem, to engage in various educational events like conferences, meetings, seminars, workshops from remote areas, and to have a competency-based assessment of the trainees who are engaged with DPAD Urology. So, with this background, I would like to mention that at All India Institute of Medical Sciences, we have been successful in building an ecosystem of learning which is known as Surgerypedia. It aims to engage the learners in learning from one another. It provides a platform for interactive online case discussions on complex case scenarios, and residents acquire clinical reasoning and critical thinking skills. They learn by analysis and synthesis while negotiating through complexity and uncertainty. In addition, It also provides motivation for faculty development. The attendings are involved in intensive training. There is more support for the supervisors, and the faculty members can get involved in international networking. It is what we call as training the trainers. So essentially, Surgerypedia has replaced time-based traineeship programs with introspection and feedback-based programs. In addition, we have a blueprint for formative assessment of the trainees who are engaged with the activities of DPAD Urology. And this competency-based system has 6 domains of assessment, where 3 milestones are assessed and there are 5 performance levels. At present, the Surgerypedia is in a nascent stage, but it is a robust model and we will be able to connect globally soon. Our main motto is to have residency programs at physical campuses that connect to geographically distant virtual campuses. This will provide the medium for uniformity of training in pediatric urology across the globe. We are connected with 10 centers across the globe, and we intend to build a strong international network by the end of 2023. Thank you.
Thank you, sir. I would now like to invite Professor Bajpai to speak a few words on the DPAD urology.
Thank you, Mahek. Thank you, Sachit. So as we all realize that this is the times where we have a digital world, and to borrow from Martin's words, connecting and reaching out to everyone across the globe. So this would be one opportunity for all of us to connect together, get the best from the best people in the world who have been with us for the last 25 years or more, and who are still continuing hand-holding us. We will pass it on the torch to the youngsters. And therefore, I would now request, without further delay, Mahek, can you just start the proceedings, please? Thank you, all of you, once again. Thank you, Stu. Thank you, Martin.
Thank you, sir. Let us now start with the first session of the day on fetal urology. The chairpersons of the session are Professor Martin Coyle and Professor Louis Braga. Professor Louis Braga is currently the research director of the Urology Residency Program and the director of McMaster Pediatric Surgery Research Collaborative. Besides, he is a professor in the Department of Surgery and holds cross appointments in the Departments of Health Research Methods, Evidence and Impact, and Pediatrics. Dr. Braga is an editor for the Journal of Pediatric Urology and serves as a reviewer more than 150 articles and book chapters. To start the session, I would like to call upon Professor Ruben Quintero. He is a pioneer in the field of fetal surgery. He graduated from the Central University of Venezuela Louis Rezzetti School of Medicine. He did his residency in obstetrics and gynecology and maternal fetal medicine fellowship at the Yale University. He is internationally known for his pioneering work in fetal therapy. Dr. Quintero developed surgical techniques and disease classifications that guide the treatment of many fetal surgical conditions today. He is the editor of the first book on twin transfusion syndrome, as well as the book on diagnostic and operative fetoscopy, and has over 20 years of experience in the management of complicated pregnancies. Sir has performed more than 1,000 fetal surgeries and has hundreds of international presentations. Sir is here to share his knowledge on the in utero surgery for posterior urethral valve. Over to you, sir.
Good morning or good evening, I'm not sure. Thank you very much for your kind invitation and your kind presentation to share with you the experience that we have in the management of patients with posterior urethral valves. It's 11:15 here in Miami. I think it's 9:15 over there in New Delhi. Let me see how I can share the screen here. To bring this screen here. Share the screen. I think it's this screen here. Share the screen. Let's see if this runs here. Can you see my screen? Can you see the slides? Yes, can you see the slides? Okay. So for you, many of these introductory slides may be a little bit redundant. I apologize if that is the case, but I thought it was important to, again, revisit why this is an important issue in maternal fetal medicine and fetal therapy and fetal surgery. Lower urinary tract obstruction carries a significant degree of mortality if untreated because of the development of renal cystic dysplasia and pulmonary hypoplasia. And since the 90s, there has been an impetus to try to avoid the natural history of fetal lower urinary tract obstruction and to bring us up to date, the two issues that have remained controversial, or I would say rather the focus of the most intense research have been how to select patients that could be treated in utero to avoid the consequences of the lower urinary tract obstruction. And once those fetuses are appropriately selected, then what form of treatment should we offer? For the selection criteria, we use a functional assessment that includes the performance of ultrasound, the performance of invasive procedures such as vesicocentesis or chordocentesis. In ultrasound, we're looking for findings that would absolutely disqualify the patient from therapy, such as the presence of renal cysts. Hydronephrosis or hyperechogenicity don't necessarily disqualify the patients for treatment. When we try to assess the function of the fetal kidneys, remove this from here, the performance of a vesicocentesis has been used to try to assess the renal function. And in this slide, I'll give you an example of a patient that has had one vesicocentesis and the values are below the threshold for what are thought to be the values that are associated with cystic dysplasia. Whereas in this case, this other patient, the first vesicocentesis shows values that are above the threshold, and therefore a second tap is recommended within 48 hours, assuming that the first tap is not really representative of the actual function of the kidneys at the time, but more a concentrated urine from urine that has been sitting there for a long time. So if the second sample is then appropriate, then therapy can be offered. That has been the, let's say, the paradigm used. I'm trying to get this out of the way. So in our recommendation is that if the first sample is normal, no further taps are necessary. However, if the first tap is above the threshold, a second tap is recommended. And if the second tap is abnormal, we personally do not recommend performing a third tap. We stop there and we inform the patient that unfortunately damage to the kidneys may have already occurred. Let's see, why is this not going? Okay, so let's see, this went too fast. The other way of testing fetal renal function is to perform a chordocentesis, and this is looking for substances that don't necessarily cross the placenta or don't cross them very well, including beta-2 microglobulin or fetal cystatin. And the value that's been mostly recommended is greater than 5.6 milligrams per liter for the beta-2 microglobulin. Rarely do we have to perform a chordocentesis, but in some cases where access to the fetal bladder may be difficult, and the placenta may be anterior, that could be a different or an alternative approach. Now, the group of Professor Kilby conducted a systematic review of all of these different fetal urine analytes to try and predict the postnatal renal function. And this was published in 2007 as part of their effort to conduct the Pluto trial, the trial of shunting versus expectant management that was conducted in Europe. And they collected 23 studies in 572 pregnancies in this systematic review. And these are some of the results in that publication, where the different analytes, sodium, beta-2 microglobulin, calcium, etc., were assessed, and they had to include a negative likelihood ratio and a positive likelihood ratio. The ideal parameter would be one that would not cross the line in either of the two likelihood ratios. So this was done for sodium, for beta-2 microglobulin, for calcium, for chloride, for osmolality, etc., all of the other analytes. And in doing so, they also included values, or they analyzed the values based on percentiles in patients that had similar types of characteristics. So you can see here the sodium of 95th, greater than 95th percentile, or greater than 100 milligrams per liter, etc., pulled again into the positive likelihood ratio and negative likelihood ratio. And when you look at that study, in the case of sodium, for example, sodium greater than 95th percentile, in fact, didn't cross a line either for the positive or for the negative likelihood ratio. Neither did the calcium. You can see here how this is all in the positive and this is all in the negative. And calcium also greater than 0.95 millimoles per liter also didn't cross the line. Osmolality also fell in that category. Now, if you looked at patients with similar characteristics, then calcium stood out as the parameter that didn't cross the line, either in the positive or in the negative likelihood ratio. And neither did the beta-2 microglobulin when you excluded patients that had terminated the pregnancy. Now, what's interesting about that systematic analysis is that the conclusion of the authors was none of the analytes that they had investigated actually were able to show accuracy in predicting poor postnatal renal function. And that is at odds with what actually the study showed. For example, as I showed you there in that slide, sodium, calcium, osmolality, and beta-2 microglobulin were able to predict poor postnatal renal function, and the effect of shunting was not considered in that study. The study also didn't differentiate the outcomes based on the actual diagnosis, the actual condition that the fetuses have. And as you know, these entities have very different prognoses. And lastly, there was no differentiation between being able to successfully shunt or unsuccessfully shunt the fetuses in terms of the predictive value of the analytes. The other aspect of the research has been on the treatment of these patients, assuming that we know how to select them. And again, we are of the school that does believe in the analytes, and we do perform functional testing before offering treatment. Assuming that we can select them properly, then these are the different options that have been proposed in the literature, and we're going to discuss, obviously, the one that we have developed lately, which includes cystoscopy and the performance of a Q shunt. So traditionally, the complication rate of vesical amniotic shunting, whether it's the Rocket shunt or the Harrison shunt, is associated with approximately a 50% likelihood that the shunt will become dislodged or will malfunction. And when that happens, obviously, one needs to then consider whether a second intervention is warranted if delivery is far from the time of the assessment, or if delivery can be offered and delivery is offered. So here's an example of a properly placed and properly functioning fetal shunt in the fetal bladder. And these are different examples of dislocation and malfunction of the shunt. Here, the shunt pulled out of the bladder. Here, the shunt pulled out of the skin and is creating urinary ascites. And here's the shunt entirely floating in the amniotic cavity. So all of these examples are very, very familiar, very, very common to those performing this. So this Pluto trial that I mentioned to you randomized patients into expectant management versus shunting. It was a very difficult trial to conduct because accrual was very difficult. They managed to get 31 patients into the study. Of the 31 patients, about half of them were managed with shunt and half of them were managed expectantly. However, the assignment of these patients were switched in both groups. So some that were assigned to shunt were not shunted, and some that were assigned to expectant measure were actually shunted. So about a 16% rate of the population was treated differently than what they were actually randomized to. And the shunts that were used were the Harrison shunt or the Rocket shunt. And you can see here that depending on how you analyze the study, this is the as treated analysis. It was significantly different. The likelihood of being alive and well at 2 years of age, if the as treated group is included. However, if you analyze the study based on how they were intention to treat, with the intention to treat analysis, then you see that there was no significant difference in between the two groups. So in the randomized group, this was not significantly different, 7 out of 16 versus 3 out of 15. However, in the as treated group, which again does away with the whole intention of the randomized aspect of the trial, then you did reach statistical significance, 8 out of 15 versus 2 out of 16. Now, the Pluto trial had its complications that we would have expected. They had a 26% incidence of dislodge or block shunt, which is, again, what is characteristics of these shunts. But they also had some relatively high incidence of other complications, such as chorioamnionitis. They then developed a registry after the trial, and in that registry, they had reported 45 patients, 35 with expectant management, and 10 only with shunting. And of those that were shunted, only 40% of those survived. So what we have done over the years is look at this problem as an issue of not only the ability to select the patients properly, but also try to overcome the issues with the malfunctioning of the shunt. And in that sense, I came up with this concept of developing a shunt that doesn't fall out of the bladder. And this is a picture of the shunt sample in the operating room. And there's a little clip of how this can be seen in utero. So here we've already entered the fetal bladder. We're looking at the fetal urethra here. And this is the blockage. This is the urethra, the opening of the urethra here. this is all type 2 valve maybe. And we've entered this percutaneously under ultrasound guidance with our standard endoscopes that we use for the other surgical procedures that we performed. Anyway, so if we fast forward this a little bit, then we deploy the shunt. Here's the deployment of the shunt. This is pushing it through the trocar. And you can see here, this is the fetal skin. And this is the metal piece of the shunt attached to the skin. This is outside. This is, you can see the fetus here. This is the umbilical cord. Notice how close to the umbilical cord we are. So these are some of the images that we can obtain endoscopically with the placement of this type of shunt. Now, on ultrasound, you can see here what this looks like. Here is the fetal bladder with a B. Here is the distal end of the shunt inside the fetal bladder. This metal piece is sandwiching the bladder to the fetal skin, and then it's clamped by the more proximal disc over here. And then when you release it, this stays like this. Here's the fetal skin, here's the anchor and the outside, and here's the double pictorial catheter that allows the drainage of the urine into the amniotic cavity. If you do postnatally a radiological cystourethrogram, you can see why the previous shunts would have failed. You can see that the bladder, the place where we actually put the shunt, is way up here. It's not down here where you would, let's say, do it in a newborn or in a patient outside the uterus. But this is where the access to this patient in utero was able to be conducted. And you can see how this bladder is pulled and attached by the shunt over here to the fetal skin. So this explains why the previous shunts would fail so easily. And it also explains why this shunt doesn't allow the bladder to come back to its position and therefore produce dislodgement of the shunting. We published this experience, a preliminary experience, in 2010. At the time, we had about 4 cases. We have actually patented this idea so that we can produce this commercially and make it available to all the colleagues around the world. In our experience thus far with approximately 44 cases, placement at about 21 weeks, with delivery at about 34 weeks, almost 34 weeks. Most of these babies have been born alive. 5 of them did have, let's say, complications during the pregnancy. About 68% were alive at 28 days. The incidence of chronic renal failure, about 25%. The incidence of pulmonary hypoplasia, about 25%. And this fares very favorably with the experience of the Pluto trial. For example, the shunting of only 7% dislodgement versus 26% in the Pluto trial. And again, dialysis only in about 1/4 of the patient, and notably with no incidence of infection in any of these interventions, any of these patients. So basically, this topic in fetal therapy and fetal surgery has been a particularly challenging one because, again, both aspects, the selection and the treatment, have been a matter of discussion and intense research. The shunting of the bladder is aimed at preventing, obviously, the development of renal cystic dysplasia and pulmonary hypoplasia. But as you can see from the presentation, some authors are not very convinced about the value of antenatal testing in terms of prediction of postnatal renal function. But we do see that shunting, at least when the shunt does remain in place, improves the outcomes, including in the Pluto trial. Again, when you only include, or when you look at the study in the treated group. The standard shunting that is offered worldwide or in many places, at least with the Rocket and the Harrison shunt, is really very frustrating and leaves a lot to be desired because of the high failure rate. And because the unsuccessful nature of these procedures, then that increases the risk of pregnancy loss when you have to repeat the intervention. The risk of losing a pregnancy from any of these procedures is approximately 4%. So when you add 2 or 3 of these procedures, then obviously your mortality rate is exceedingly high. We believe that this new shunt that we have developed may circumvent many of the previous problems of the other shunts. We can't say it is perfect. We're still working on making it even more easy or easier to deploy. But I think that most importantly, because the shunt does not become dislodged and because we don't need to worry about it malfunctioning during the rest of the pregnancy, then this may allow us to understand really the natural history of lower urinary tract obstruction. Because in the past, if the baby was born and the renal function was inadequate, we could also, we could always think that it was due to the failure of the shunt to provide adequate treatment. Whereas now, when we treat these babies effectively, we know that if the renal function of the baby is good after birth, we did achieve the goal. If the renal function is not good after birth, then it isn't or is not the consequence of a failure of the treatment to achieve its goal. I hope I didn't go over time. And again, I want to thank you very much once again for your kind invitation. Not sure if we have time for questions, but this is the topic that I wanted to discuss with you. Thank you very much.
Thank you, sir. That was a wonderful talk, sir. I would like Professor Braga for his expert comments on the talks.
Thank you very much. This has been an honor to be here. First to witness firsthand this beautiful award that was given to Dr. Coyle, and nice words by Dr. Stuart Bauer. So thank you very much, Dr. Quintero. I think this was a wonderful presentation. I have watched your lectures before. I maybe this will, I have one question, and maybe we talk and do like a back and forth with Dr. Coyle as well in the audience if they have more questions. But for us as pediatric urologists, usually if a patient or we identify cystic dysplasia or cysts or hyperechogenicity, for us, both conditions would signify that this would be a bad candidate for in utero intervention or vesical meningitis shunting. And correct me if I'm wrong, from your presentation, I understood that the cystic dysplasia or the presence of cyst was actually indeed a contraindication, but not like an absolute contraindication, the presence of hyperechogenicity. So maybe with your experience, and I know that that's the most important thing, like you mentioned, is the selection of those patients in order to achieve great result. What is the main difference that you take into account to differentiate between the cysts versus the hyperechogenicity?
Well, thank you again very much for your question. The presence of renal cystic dysplasia already signifies or would already tell us that whatever we do in utero is not going to change the prognosis, at least for the kidneys. We have ways, in fact, to avoid pulmonary hypoplasia, even in circumstances where we already know that there is no renal function. Extreme cases, for example, where there is bilateral renal agenesis, we can somehow achieve the development of a fetal lung, even though we already know that there is no renal function, of course, in that extreme case. But those patients, if they present with renal cystic dysplasia already on ultrasound, we don't offer necessarily antenatal treatment. Now, if they present with hyperechogenicidity can be many times subjective. You know, if the referring doctors think they're hyperechogenic, we don't think they're so hyperechogenic. We still do the fetal renal testing. So we base more our decision on what we find in the urinary analytes rather than a subjective call on the appearance, the sonographic appearance of the brightness of the kidneys.
Thank you very much. Marty, Dr. Coyle, do you want to make any comment, or I don't see any questions in.
Yeah, so I just suggest that anybody in the audience who has questions, you might want to put them in the Q&A box, and then we can pose them to ourselves or to the speaker. But Dr. Quintero, again, great talk, always stimulating. And of course, this is a topic where we can go round and round and round, because I think Pluto did prove to us how difficult it is to do a randomized controlled study, and something with potentially a fatal outcome, and a lot of risk associated with it too. So it's a very challenging, I think, in medicine for us to get answers for some of the more complex problems. But one of the things, I mean, that I really appreciated the fact that you're using ingenuity to develop new stents or tubing, because that's clearly been an issue, as you showed from the San Francisco group. But the thing that I'm wondering about is, since you began doing this, because you're a little bit younger than me, but you've been doing this for a few years, is the evolution and the improvement in ultrasound. And hence our ability to time intervention as well. So, you know, we know nephrogenesis occurs in the first 6 weeks of gestation. And obviously, the sooner we're able to intervene, and maybe that's going to be genetically in the future, the more opportunities we're going to have. But currently, right now, the only thing we can do, especially with pulmonary preservation, is to consider interventions such as you're doing. So where has technology taken you with ultrasonography, not just to look at kidneys, as Luis brought up with cystic disease versus echogenicity, but also potential for looking at ultrasound as a tool that may predict some degree of renal function? Sorry for a long-winded question, but
no problem. Well, again, I think that ultrasound has allowed us to identify the extreme cases. So the cases where there's already, you know, renal cystic damage. But again, other than that, I think that ultrasound is not very accurate in predicting what the outcome of the postnatal renal function would be. So that's why we still believe in the performance of vesicocentesis and the analysis of these urinary analytes. Now, we are of the school like Professor Nicolini, late Professor Nicolini, where, you know, we don't want to do 3 and 4 and 5, you know, procedures. You know, we limit. If the first procedure is okay, then we stop there and we can offer the treatment. If the first procedure is not okay, then we do a second. And if the second is not okay, then we don't offer intervention. But I think ultrasound, the advancement of ultrasound has been, let's say, not so much in that sense, but the other sense is it allows us to do procedures today with this, let's say, relatively tricky way of getting in there and bypassing, you know, umbilical cords and other things that could result in loss of the case. I mean, the ultrasound appearance of these patients, as you know, is the total anhydramnios. So getting in there without causing damage and being able to do the procedure, it requires a high degree of ultrasound expertise and obviously the quality of the ultrasound itself.
So we have 2 questions from the audience. One from Professor Dave from Canada. Do you believe that being rigid with antenatal intervention, we lose those who may benefit? In other words, should we have wider indications from whom we accept as potential patients?
I'm sorry, I didn't understand the question.
So right now we have fairly rigid indications, and you're using electrolytes plus ultrasound appearance.
Right.
Should we broaden the indications?
Well, actually, the question is how do you move that pendulum? How do you move the spectrum in the management of these cases? So as I mentioned before, I mean, you would today, or before, you would not even consider helping a patient with bilateral renal genesis. You already know that there is no renal function. And these patients are now coming to us for help. And yes, we know that we have techniques that can help them. So those patients, even though we already know there's no renal function, which be the extreme in the case of the lower urinary tract obstruction, the patient with already cystic changes, those patients may still want, some form of intervention. Now, if we already know that there's no renal function, we will not necessarily shunt the bladder. We will probably do the treatment that we do for bilateral renal genesis. In fact, we recently had a patient with polycystic kidney disease. And so polycystic kidney disease, she does have kidneys, but there's no bladder to shunt. I mean, the bladder is, non-visible or, very minimal. There's nothing to shunt there. So we still manage to allow the lungs to develop, and we save that baby and bilateral renal genesis baby. But again, it's trying to move like you say, the indication to patients that otherwise in the past you would have absolutely not even offered, treatment. But I don't know. It's a dilemma. It's an ethical dilemma. It's a controversial, area.
Do we still have time for one more question, or to the organizers? Because there is one from the audience asking if the position of the bladder is not the traditional and standard position, do you have any techniques, or with your new device, doesn't matter?
Well, usually the bladder in these cases, as you know, is very distended. So getting into the bladder should not be an issue. If getting into the bladder is an issue, maybe that's not a patient that you needed to shunt in the first place. But for the most part, one should be able to access the fetal bladder. So even if the baby is not in a great position, entering the bladder should not be a problem.
Thank you, Dr. Quintero. I think we need to move on to Dr. Coyle, and now leave the stage to, yes.
Moderators, can I ask one question, please, from here in New Delhi?
Yeah, absolutely.
I have a question to Professor Quintero. Can you hear me, Professor Quintero?
Yes.
Thank you for a wonderful talk. I just go back to the question before the one which was asked, the last one, Dr. Dave's question from Canada, broadening the indications. From your talk, Dr. Quintero, you did mention that kidneys, when they have dysplasia with cyst formation, they could be the extreme cases which might not recover, and that's why you don't take them as an indication for intervention. I'm just sharing, it's more philosophical, but I think with the kind of experience which together we have today, we can definitely try to find answers. We have seen postnatally cases with cortical cyst. We have intervened upon them, like posturethral valve or a uretrostomy. They have grown up. They definitely have below par glomerular filtration rates, but they have fared better than what we anticipated. That is the potential of the kidney to grow. They may go into eventually requirement of renal replacement therapy, but there would be some who may delay this. And we buy time, and renal replacement and transplants have their own issues, and availability of kidney, etc., are issues. Now, taking it to the left, to your scenario of fetal intervention, I'm sure there are grades of dysplasia, so there will be few who may do well, others may not do well. Would you consider this? And coming back to Dr. Dave's question about broadening the indication, because these will be the cases which are likely to benefit immensely from your interventions. So what's your thought on it? And Marty and who can also talk about the dysplastic kidneys, their grades, and the cystic dysplasia, some of these do rather well than we anticipated. Thank you.
Well, as I said before, I think that the pendulum, can be moved depending on how we, begin to change our views on what the patients may actually be able to or be willing to accept. So again, the extreme case is no kidneys, bilateral renal genesis, and those patients, may still want some form of antenatal intervention to be performed to avoid pulmonary hypoplasia, and that can be done. So, but if the case is fetal bladder outlet obstruction, and we already know that the kidney aspect on ultrasound is unfavorable, then maybe shunting is not the way, but we still can help the patient with development of pulmonary with pulmonary development, so that baby can survive and then be treated by the colleagues after birth.
If there are no other questions, we'll move on to the thank you to the moderators. Now, coming to the next talk, I would like to invite Professor Thomas Coyle. Professor Coyle is the chief of the German Center for Fetal Surgery and Minimally Invasive Therapy at the University Hospital Mannheim, Germany. He has pioneered minimally invasive surgery for fetal spina bifida, co-developed fetoscopic tracheal balloon occlusion for fetal diaphragmatic hernia, and many other techniques. His most important approach is chronic intermittent materno-fetal hyperoxygenation of fetuses with hypoplastic cardiovascular structures, which is known as the Coyle procedure. I now invite Professor Thomas Coyle to deliver his lecture on vesicoamniotic shunt insertion in PUB, indications, techniques, and outcomes.
Good morning, everyone from Germany. Thank you very much for your kind invitation. Good morning, Ruben. Also, unfortunately I missed your call because my link didn't work, and so without having known now your talk, I just try to get my points across. And so we need to start probably only a few years ago with the Pluto trial that was published by the group of Mark Kilby, and essentially it was a prospective randomized trial started with the best intentions, but unfortunately the study in the end closed because of poor recruitment, and essentially it was published in the Lancet, and afterwards people really refrained from shunting because they thought the procedure doesn't make any sense anymore. And the reason was because the overall outlook was very, very poor, that shunting could improve survival of the babies, but if one looked at the fetuses that were not treated, the degree of renal impairment essentially was the same in both groups. Many fetuses died as a result of pulmonary hyperplasia, and therefore in the United States, in England, it was also recommended that the procedure is not likely to be cost effective in the management of these patients, and therefore essentially treatment was withheld from further cases. And so that has been a very difficult base essentially to work on, also after close to 40 years of shunting, where essentially no big step forward has been made for these patients. And I think the problem with the shunt, also with the trial, was that the trial was made with a device that is far less from perfect, and that hasn't changed much since its introduction in the 80s, and that is this double pigtail design where you have a needle that you advance into the fetal bladder, then you have to insert an inner pigtail end, and then you have to insert an outer pigtail end. And the problem is that the design or the use of the design results or can result in a lot of complications, like preterm rupture of membranes, particularly during maneuvers to place the outer part of that pigtail catheter. Dislodgement can be facilitated if the outer part gets trapped within the uterine wall. Essentially, if you do not have sufficient space between the fetus and the interior wall of the uterus or the placental surface, you need to infuse fluids. There was no fixation device, and also the device can trap ball and result in eventuation. So when I started working on Luto patients, then I really thought that the true potential of the prenatal treatment remains unknown, even I guess until today, after I think we made some advances in therapy. And the problem is, in my country, the ambiguity now of offering treatment at all, given the previous results. Termination is an option. Then I guess a major problem also this losing time and wait and see approach. So you encounter a fetus at 14 weeks with a bladder that is probably 2.5 to 3 centimeters in diameter. And then people say, come back in 1 week or 2 weeks, and we see maybe it becomes smaller. Then the problem is, of course, losing time by early bladder taps, for example, for obtaining genetic information, but also for serial urine analysis. And then, of course, there's a problem that many people have, the lack of technical experience by doing only a few cases, but doing procedures anyway, and that is very widespread in Germany. The question then is, if we come to late diagnosis beyond 18 weeks, does the treatment still make sense? Because the late data essentially are reflected by most outcome data that's been written and presented in the literature. And if one really sees that only maybe 20-25% of fetuses essentially benefit from the procedure, that after delivery they have sufficient renal function, which is not much better than in not treating the fetus at all, does it still make sense? And I think a major ethical, moralic problem is also if one should really leave all the girls behind, which has previously been recommended, and also how to deal with additional anomalies. And so the question is, how is there a way to improve upon this? So between the years of 2020, even up to date, we developed different management. And that is that essentially we try to insert the shunts as early as possible, preferably before 16 weeks of gestation. We do not perform previous karyotyping or serial urine sampling because we simply take tissue or amniotic fluid, or urine at the procedure for karyotyping, so there is no delay. Then the treated fetus get into a program for weekly follow-up studies. So as soon as we can see that there is urinary obstruction at any level, the fetuses come in for re-intervention. And this is an example, for example, of a fetus early at the 14th week of gestation. You see a keyhole sign, and you really see that we speak about severe cases. You see, this is the distended abdomen, there is the heart. You can compare the size of the head with the size of the bladder. So these are really extreme cases. By defining the cases as severe luto, we've departed from previous recommendations by essentially measuring the maximum diameter of the bladder and then staging it to various weeks of gestation. And it starts with 2.5 centimeters, it goes up to 4 centimeters in 4 groups. And that is the diameters that we've used essentially are at least twice as much as had been previously been given as indication of the presence of more severe lower urinary tract obstruction. So as I said, the double pigtail design didn't seem to work for me, and therefore I had to be somewhat inventive. And I said, okay, we do not need the outer pigtail because the bladder is fixed in position. And so essentially there is no fear that if you have a longer straight external part, that the bladder can, the catheter can dislodge into the bladder. It can only dislodge out of the bladder. So we have the internal part, the pigtail, but the other part is straight. And that has enormous advantages because it's easier to place. You do not require fluid augmentation. It does not require needle maneuvering in order to position an external pigtail part. Therefore, you have smaller risks of membrane rupture. And the long distal part permits long-term drainage. The lumen is larger, and the question of improvement would be that it would require a fixation device that we don't have. This is how this looks. Here we have some kind of fixation device, but we don't use that anymore. It's called a T-fastener. But here you see how the catheter looks and how it looks after placement, and it's placed via an 8 French sheath that's inserted into the bladder by a Seldinger technique. This is how it looks during insertion. And here I can show you a short clip. And so I started using this from 2012 onwards. Now we're inside the bladder. We advance a guide wire. And then over the wire, the sheath goes into the bladder. Then we can remove the trocar of that sheath. Simply insert that prepared catheter. Now you see that the loop of the pigtail comes in. And since the lumen of the sheath is somewhat larger than the lumen of the catheter, I can simply withdraw the sheath. And upon withdrawing the sheath, you often see that the distal part of the catheter still sits within the wound. So it really extends through the uterus, sometimes even into the maternal abdominal wall. But that doesn't matter because the fetus, after the procedure, begins moving again. So we do this in a short anesthesia. The fetus moves again, and then it pulls this distal part into the bladder. And so if you see here, these are centimeters. You have now a straight catheter of 4 centimeters. Look at the lumen. And this really, you can really achieve a long-term drainage with this novel technique. So since 2016, in Germany, the Sommertex company provided this nitinol stent covered with Teflon, and that also has changed the options of performing procedures early. Unfortunately, because you still have this design that you have two little umbrellas at either end of this device, you have to perform amnio infusions in case that the fetus lies too close to the placenta or to the anterior uterine wall in order to prevent essentially entrapment of the device within these structures, which also could result in complications like PROM. So you can do amnio infusions prior to this procedure, looks like this. And that's also very successfully, as Ruben pointed out, in treatment of pulmonary hyperplasia. This is how the intervention then looks from the outside. You have your needle under ultrasound. And then this is how it looks on ultrasound. You still see this is 1 centimeter. So you still come very close to the wall. So this the placement can still be difficult. But once upon it's placed, you can see that this bladder is really under pressure and how the urine shoots out here. And then, of course, if you do this very, very early in gestation, you see the size of the device compared to the tiny baby that's been treated. So yeah, they're really huge. We've seen, of course, fetal demise in a few cases before the procedure even. And we think the reason is that the bladder simply grows too quickly and that the umbilical vessels that run around the bladder cannot adapt and that they're pulled any longer and their lumen narrows and then the fetus dies. And I think the opposite can become true after shunting. When you shunt a huge bladder, it becomes smaller. I would suggest that there might be some kinking of the umbilical vessels that can result in demise of some of the babies. Then there's also, of course, the problem that the short shunt device then can dislodge, essentially. So you have here the small contracted bladder, the proximal part of the catheter or the stents still sitting in the bladder, but it now drains into the abdomen. You have this severe degree of ascites. And when I started this about 10 years ago, it was also said, and I just heard it last week again, urinary ascites, it's not a problem because they do peritoneal dialysis after delivery. So if the urine flows into the fetal abdomen, there is some kind of natural absorption and it must not be treated. And I think the contrary is true. It's definitely no fetal peritoneal dialysis. Huge amounts of urine can accumulate. You postpone therapy if you don't treat it. It kills and it maims because it destroys the abdominal wall, contributing to a prune belly. And therefore, we also immediately, when we see this problem within days, shunt and provide further outflow of urine. And then, of course, is the question, if one then encounters cases where kidney function is gone, whether treatment for pulmonary hyperplasia from anhydramnios should be provided. And that treatment can very successfully be performed with amniotic fluid, serial infusions, and in cases that you see very late with the so-called Fetal technique, fetoscopic tracheal balloon insertion. And here just another example of a serial amnio infusion, which we then perform in cases, for example, I've also just one with renal agenesis bilateral from 20 weeks onward, every 2 weeks essentially. So by the end, usually the fetuses reach 32, 34 weeks of gestation at an age where they can treat it well by peritoneal dialysis. And then the mothers sometimes have 8 procedures behind them, but lung function is not a problem anymore. So we did a series of cases, just one after the other in retrospect, analyzed them, and we could publish this paper after a long review process in the Journal of Pediatric Urology. And I'm very grateful that despite its novelty and the controversy in the review process, it became accepted, it was accepted, and now provides food for thought, I think. So we had a group of 36 fetuses. The mean gestation at treatment was, at first treatment, 17.5 weeks of gestation. The range was 12 plus 5 to 30 plus 3. The inclusion criteria were essentially that no other major anomalies of other organs were seen than anal-urogenital organs, in essence luto. The definition of sex was not required because we didn't want to postpone the procedure. And of course, with NIPT testing, you know, things also become a little bit faster now, so that this point can be changed even already. But urinary analysis, and particularly serial punctures, are not required. On one hand, because particularly in the early cases, poor results essentially do not indicate bad outcomes. It's simply a matter of treating early enough. On the other hand, if you do the punctures, you may also end up with a ruptured bladder, then urinary ascites, and that also may change the management options that you have. And therefore, we also wanted to study or included the fetuses where we started treatment at our center. These are the definitions of the bladder sizes that we used for defining severe cases. So larger than 25 millimeters between 12 and 14 weeks, then 30 millimeters between 50 to 20, and beyond 21 weeks, 40 millimeters. So these are quite remarkable sizes. You can see here the fetus, where essentially if you compare the head with the bladder, so it's essentially the bladder is somewhat larger. There is another case that would be also considered severe luto, but if you compare the two cases, it already looks milder. But here you see it's later in gestation, you can see already hydronephosis. So the question, of course, is how to define normal renal function, and we didn't find much in the literature about it. So there were always the Schwartz formula, the creatine clearance, the creatine levels, but not much. But on the other hand, the kidneys function in pairs, and you can't really say how well an individual kidney essentially functions, but you can assess essentially the laboratory values. You can look at the electrolytes and the blood gas analysis. And so if those values were normal after delivery, and also with regard to the child's age or the infant's age, we said, okay, that is normal function. On the other hand, and that was also, I guess, just part of the discussion with Ruben at the end, you can still see, not in all, but in many fetuses, marked structural changes of the kidneys, hyperechoic regions, cysts, and so on and so forth. But since they work in pairs, there is redundancy provided by that design, and that redundancy essentially can then result in normal renal function if assessed by those laboratory tests. So we treated the 36 cases. We had 59 males, so that's the majority for females. Survival overall, 75%. And survivors overall with normal renal function, half of the cohort. With renal insufficiency, 21%, and terminal renal failure, 28%. So with regard to complications, more severe essentially if you have an infection within the first week, because that's the end of the pregnancy. We had that in 2 cases. Membrane rupture and leakage is also a severe complication. Sometimes the rupture closes again and pregnancy continues. So we still saw it by using these minimally invasive devices compared to the previous double pigtail design in 10% of the cases. And then there was also demise of termination of pregnancy because PROM and the leakage did not disappear, or when pregnancy continued and there was a development of anhydramnios, and then given the poor perspective with normal renal function after delivery, those mothers then opted for termination of pregnancy. So that's 14% in our cohort, which is also remarkably low compared to other cohorts. So if we look at group 1, there is oligohydramnios before the intervention only in 25% of cases. And we did see pulmonary hyperplasia in 3 cases only, with 2 survivors. And that was the group of 29 fetuses. We saw in the second group first shunt between 16 to 24 weeks of gestation, oligohydramnios prior to intervention already in half of the cases. In more cases with pulmonary hyperplasia, 8. And in the group shunted after 24 weeks of gestation, oligohydramnios in more than half of them, in 1 case with pulmonary hyperplasia. And the reason already for these low numbers of pulmonary hyperplasia is because we treat those cases if the mothers or the parents opt for postnatal treatment and dialysis, and in the end, renal transplantation. So if we then analyzed the groups that were shunted before 16 weeks of gestation, we see essentially that we had a survival of close to 70%. So 3 of 10 will die in this group, but we have close to 80% of normal renal function as given by the definition I just showed you. And then if one shunts later and now enters the window where the shunts usually have been observed, so it's mostly after 18 weeks of gestation, you have somewhat higher survival, but normal renal function survivors already dropped smartly to 35%. And if you shunt even later, we see that there's only, the group of course is smaller, that we had 1 or 5 cases with normal renal function. During the review process, some reviewers said that the treatment was very aggressive because we might have overtreated cases, and I need to say and repeatedly say and write that the mean number of shunts in the entire group were less than 2. In many procedures, we just came out with a single shunt with a long tail, for example, that lasted throughout the remainder of gestation. And the mean delivery age was 35 weeks of gestation. And even with a short somatex stent, if you are able to place it below the umbilicus, 1 shunt may suffice for the rest of gestation. And even if it's placed at 13 or 14 weeks of gestation. And then if we did only 1 statistical analysis, and that was that we compared the treatment prior to the completion of 16 weeks of gestation, that group with the one treated later, and there was a highly statistical significance for better renal function in surviving fetuses of the early group. Of course, clearly further follow-up studies are required now in order to analyze how long this advantage of being born with normal renal function really lasts into the lifetime of those affected babies. And therefore, in summary, I still believe, because the devices still need to be improved, that there is even more potential with early treatment for the babies, that we recommend to start it as early as possible and not postpone it by karyotyping or serial analysis, that pulmonary hyperplasia can be treated if the parents want this, the treatment, despite the availability of new shunt systems that it can be placed far more easily. The treatment, because it's experimental, still should be centralized and analyzed. Thank you for your attention.
Thank you, Dr. Coyle, especially in the middle of the night in Germany. And now for Ruben, it's well after midnight. So the first question that maybe the two of you can fight over first is, Ruben posed, at least in their center, utilizing electrolytes. You're an anti-electrolyte person. And how many ultrasounds do you base your initial intervention at 16 weeks on? Is it a single, or do you like to have a straight line with more than 1 point? So again, 16 weeks, and Dr. Quintero for later.
So if we get a fetus with 16 weeks that presents with a bladder that is 3.5 diameters in diameter, essentially we go ahead, and then also you usually see at 16 weeks already a decreased amount of amniotic fluid. We would go straight ahead and shunt the baby.
So single ultrasound then?
Yeah.
Okay. Dr. Quintero, would you like to comment on that?
I think it's fascinating, the experience that Thomas has shared here. In our group, we don't intervene before 16 weeks. I think there will be a difference there, because obviously the issue with the membrane, we were trying to prevent rupture of the membrane, so the membrane may not be fused by then. But I think that the experience that they're having with this particular catheter, is very interesting. I think it's fascinating that they can offer these procedures so early. We don't intervene this early. We start at 16 weeks. That's the earliest. In fact, I was looking at the data that we have here. The earliest that we have is 16 weeks, and that's pushing it.
Yeah, that was my experience that I had also with the fetoscopy. Of course, we also try to address this the problem in some cases by fetoscopy. At least in my hands, I thought it was not safe for many of them. I couldn't perform it so safely and reproducibly as I usually want to perform my fetoscopies, and therefore I stayed away from the procedure. But the new shunt designs, that if one changes, for example, in centers that do not have the Somatex stents available to a single pigtail design, then one can really start earlier. And if somebody would be interested in how to do this, they can write me emails or send me, because there's some more information to it. And this special technique has not been published, but I think it could be very interesting to provide this knowledge. It's easy.
Dr. Coyle, Luis Braga here from Canada. So first of all, I think it's a privilege and it was a pleasure to listen to your talk. I'm very happy that, as you probably know, I was one of the editors of that paper. So I think, and I congratulate you on getting this paper accepted. I think it's a groundbreaking treatment, and I think it has to be made available and publishable for others to at least judge and then try to mimic your results. So my question to you is this, because obviously you and Dr. Quintero obviously have a vast experience with this kind of procedures. But if I go back to my center and try to discuss with my OB/GYN about these interventions, and sometimes we know that in medicine, sometimes the indication for a successful, or the key for a successful outcome, is the selection of the patients. So I think your presentation was wonderfully put, because you have clear indications about the size of the bladder, and then you're actually negating what we know from the textbooks, classic textbooks about dysplasia, about hyperechogenicity, about electrolyte values through amniocentesis, about karyotype and etc. Like, so my question, to make it a long story short, is there, just as a final message to other obstetricians or us, because we don't deal with that, we are pediatric urologists. So what cases would you say that you wouldn't do it? So not the ones that you do it, but again, I would like to know if there is such a case under 16 weeks that you would not recommend shutting. Because I think maybe starting from those, and for those who want to build an experience, they need to know first when not to do it before knowing when to do it.
Let's say we see some cases prior to 16 weeks of gestation where you see a largely distended non-global bladder, and where you also see mega ureters already, and severe distension of the pelvises of the kidney. And this is at such an early stage, that's very remarkable, because essentially most fetus that we treat don't present with mega ureters prior to 16 weeks of gestation, and most of them do not present with severe distension of the kidneys. And since there is always the problem that there is some abnormal muscle development, and that you do not have a luto that essentially where the problem is obstruction and high pressure, but non-obstructive dilation, because, for example, a myocardial cofactor defect, which results then in muscle abnormal muscle development. These are the cases where we stand back and would not treat them.
There's one question from the audience. Do either of you utilize MRI, and where do you think the role is for MRI? Does it help you with understanding function or impact your decision making?
MRI for us, at least in the early group, does not help. We use MRI later in gestation in order to determine the lung volume, the observed to expected lung volume, and in order to control the efficacy of our lung rescue treatment by tracheal balloon or by serial amnio infusions. But we usually do not use it for renal assessment.
And we have used MRI only in very selected cases. For example, if we want to differentiate a mega urethra from anterior urethral valves, because the prognosis for these two conditions is so vastly different. But we don't use it for assessment of renal function or lung development or anything like that. It's only for these very, very specific cases. And in most cases, the radiologist has not been willing to commit himself or herself to the diagnosis. We may still have to try to make the differential diagnosis endoscopically, because it's very difficult to make with ultrasound.
I have another question to both of you. I think you both showed excellent experience. Dr. Quintero showed better results from the Pluto studies and even other series. Dr. Coyle, amazing results. So my question is, how much can we place or the confidence or the achievement of those great results are dependent on the experience of both of you, or would be related to the gadget, like Dr. Quintero's shunt versus Dr. Coyle, it's a single lumen or a single J catheter, or Dr. Coyle mentioned something that I really think
I think that the availability of the Somatex stent, for example, in Germany has somehow democratized treatment. Okay, so that even people with less experience can do the procedure and can do the procedure early. Nevertheless, since amnio infusion very often is required, then still one needs to be careful. The problem I see in my obstetric colleagues is that they do not have to pay the patients for doing procedures, and many times not the setup that they use. So procedures are done in an unsterile environment. No prophylactic antibiotics. Sometimes the interventional devices are just built together without, really adhering to proper hygienic principles. And I've seen a lot of problems, particular infections, rupture of membranes, resulting from this management. So it is possible. So it's not a miracle, definitely not. Experience helps. And clearly, even with experience, every once in a while you encounter a case where even with a lot of experience, you make a mistake, in managing the cases. But this is definitely not a treatment that only a few persons in the world can perform. And I think particularly if one uses the single pigtail design, that it essentially can be even more widespread to countries that cannot afford the fancy stent device, which costs now, I think, 1,300 euros for each one to use. And the single pigtail design that I've used probably is somewhat more than 100 euros.
Yeah. We often get asked that very specific question, is it because of your hands, doctor? You're so, fantastic, or, what is it that, what's the difference here? And the answer is no. Yes, like Thomas is saying, you need experience. You need to know how to do ultrasound-guided procedures. You need to have experience with endoscopy. You need to have all of these things. But in our case, what we know is that once you have the technique pat down, as we have, for example, with this Q shunt, you can teach a skilled operator how to place this, and they will have the same results. In our experience with this Q shunt, this has changed completely our outlook on the topic of fetal bladder outlet obstruction. For example, we used to do a shunt, and we used to have the patient have to come back every week because we never knew if the shunt was still going to be there or not. We put the shunt down, we say goodbye, and the patient goes back to New York or to Chicago or to Los Angeles, wherever she comes from. We're not worried anymore about the shunt. The shunt is going to be in place, so much that the shunt has to be removed in the operating room after the baby is born by the pediatric urologist. You can't even pull it out. That's how fantastic, the shunting procedure is. So, yes, it requires, like Thomas is saying, it requires experience. You can't just, try to begin to do this, the next day. You need to have experience. But the device itself and the technique itself is what has us made change, or has changed our view in this particular, entity.
So we have two more questions from the audience. One, Professor Coyle, in your 3 groups of patients, were you able to look or assess short-term and longer-term bladder function, how they do in longer term?
Let's say we are just in the process of collecting these data. So hopefully, if we can join this meeting in a year or 2 again, we can present information about this. The first question was about the the renal function, and that we've seen that in many of the babies, the function extends into early life. But clearly, bladder function is also a different aspect. So we did also not, so most males had posterior urethral valves, for example, but there were also infants now that were born with urethral atresia, requiring different management. And we do not know essentially yet the morbidity and the number of procedures and the prospect essentially for these babies. So the first aspect essentially of this work was to improve the baby's condition with regard to renal function and lung function after delivery. And this, I think, also particularly the fetuses of group 1 have not or have only rarely been seen by pediatric urologists, because I guess previously most of them were terminated or because they've lost kidney function over the course, then oligodumnous, and then when pregnancy was continued, they died without lung rescue treatment from pulmonary hyperplasia or were terminated. So we have Raimund Stein, a very experienced urologist at our center, and he sees different patients. He sees patients where the urethra also is very, very tiny in the beginning, and urine doesn't trickle out in the beginning, and he can't get in there. And then after a few months, he can do procedures. And we really need to wait what this data will mean, and whether rescue of the babies is one thing. The question in the end is quality of life and what can be achieved by postnatal pediatric urologist surgeons.
And the last question from the attendees, I know it's hard to look at costs of something like this because NICE, when they looked at the Pluto results, didn't feel it was cost effective long-term. Can you ballpark the costs of, especially now that you don't have to replace the tubes as often, and as Dr. Quintero said, you don't have to follow them as closely as you did before when the shunts were misplaced or malfunctioned?
Yeah, so the procedure itself, the early shunt insertion in Luto case at our center costs below 5,000 euros. So you get it for 4,000. And then we suggest serial monitoring weekly. So, but on the other hand, as Ruben says, and which is our experience also, most devices last for weeks. Some, as I said, even throughout the entire gestation. So if for some people imaging would be too costly, one could do, in cases where one is sure that the shunt really sits very well, you could just monitor less often. And then I think really, because renal function will be better in a lot of cases, that also impacts on the costs in a positive way. So I definitely think that cost efficacy should not be a point for discussion, not in our country, you know. So that, of course, there may be countries who cannot afford this and where no dialysis is available or transplantation and things like that. So definitely we must not talk about this. But even in those countries, I think babies could be saved by early intervention. But here in our country, it shouldn't be a point anymore, not at all.
I think we have actually cut down on the cost of this, because if we do one procedure and the baby is already treated, you know, she can be followed up monthly at her referring site. The question will be, did we save a baby that was supposed to die and therefore we increase the cost? Well, you know, that's what we're here. That's what we're here to do. We can't decide. You know, of course, terminating the baby would cost much less. But if we're looking at, you know, what is the cost of the treatment and how that treatment behaves, and by having a single procedure that is effective, we've, you know, cut the cost down dramatically.
Luis, any closing comments?
No, Martin, I think based on the timing that I have here, I think those were two wonderful presentations. I think, I just wanted to congratulate the Indian Society, because this is like two high-level speakers presenting groundbreaking research, and I think this was very fun. And then I'm glad I was able to participate and learn with the experts.
Thank you so much, sir, for the enlightening talk, and thank you to all the moderators, to Professor Martin Coyle, Professor Luis Braga, Professor Ruben Quintero, and Professor Thomas Coyle. We now move on to the much-awaited Silver Lecture Series. The Silver Lecture Series is the prestigious award lecture series by the Society. This series will include lectures by the early and mid-career pediatric urologist. The moderator of the session is Professor Minu Bajpai, and the panelists are Professor Sandeep Agarwala, Professor Martin Coyle, Professor Luis Braga, and Professor Luke Harper. Professor Sandeep Agarwala has completed his graduation in MCH from AIIMS, New Delhi, and has been a faculty here since 1994. His research interests include pediatric surgical oncology, thoracic surgery, and neonatal surgery. He has been a member of the executive board of the International Society of Pediatric Surgical Oncology and is currently the co-chair of the Resource Challenged Nations Committee of the SIOPEL. He is the section editor for the Indian Journal of Pediatrics and has been the editorial secretary of the Journal of Indian Association of Pediatric Surgeons. He has been the organizing secretary for multiple workshops, CMEs, and conferences, and has presented and chaired at multiple international and national conferences, and has over 300 publications and more than 90 chapters in books. Professor Luke Harper is currently working as a consultant at the Central Hospital and University of the Reunion at St. Paul, France. He has published a number of papers and research articles in various peer-reviewed journals. He has previously worked at the Victor Sergan University at Bordeaux. Sir is skilled in pediatric urology, minimally invasive surgery, and surgical oncology. This year's award to the mid-career pediatric urologist is awarded to Professor Sumit Dave. Professor Sumit Dave completed his medical undergraduation at the Jawaharlal Institute of Postgraduate Medical Education and Research, Pondicherry in India. He completed his pediatric surgery residency from the All India Institute of Medical Sciences, New Delhi, and pediatric urology fellowship at the Hospital of Sick Kids in Toronto. He is currently an associate professor in the Department of Surgery and Pediatrics and the program director for the Urology Residency Program at the Western University. Dr. Dave has published numerous articles, and his primary areas of interest include neurogenic bladder, vesico-ureteral reflux, and robot-assisted reconstructed pediatric urology. He was instrumental in establishing the first pediatric robotic program in Canada at the London Health Sciences Centre in 2014. Sir would be presenting on the top-down versus the bottom-up approach in children with UTI. Over to you, sir.
Thank you so much. I'm just going to try to start sharing my screen here. Is that good? Can you see it?
Yes, sir.
Okay. All right. Good afternoon to everyone in India, and maybe good morning or good night to others across the world. It is wonderful to be here, and I'm pretty excited. Thank you for your kind introduction here. And I would really like to thank the Indian and Asian Society of Pediatric Urology for this honor and acknowledgement. I accept it with great humility and gratitude, and it's pretty inspirational. We all stand on shoulders of giants. We always hear this phrase, but for me, actually, it means our teachers. And I can't really see all my teachers here, but I think they are there on this call. So thank you to them. I would like to specifically thank my teachers in AIMS who instilled this love of pediatric urology in me, and to my special mentors at Sick Kids, Dr. Corey and Dr. Pipi Saleh. I think the other thing, which is a bit off topic, but just to kind of quickly bring up here is, I would like to acknowledge the amazing work our healthcare workers and physicians, and including all of you guys here on this call, have done to keep India, relatively safe from COVID. I appreciate it. I thank you. Dr. Bajpai has tasked me with a tough topic, the top-down versus bottom-up approach for UTI in children. I have no disclosures. Why is this important? We know that pediatric UTI prevalence is high. So under 2 years of age, as a febrile illness, UTI is the commonest cause, and it's the second commonest cause in all children. In infants with fever, it's about 7%, and it kind of goes up to about 7.8% in 2 to 19 years old. The highest risk group is really uncircumcised males under 3 months of age. And there are several risk factors for recurrence of UTI, which we kind of know. So the role here, or our topic today, is to discuss top-down versus bottom-up approach. It's great that Dr. Coyle is here. He's kind of an expert, and he's published several papers on this. But we kind of are some ways on this side or that side of that yellow line, and sometimes in the middle. And I don't think that I'll have a clear answer at the end of this talk, but my goal is to give you guys a good sense of the topic here. So what is the bottom-up approach? That's our gold standard. So you have a febrile UTI, you do a VCUG and a ultrasound. If you have reflux, you may do a DMSA. If you have no reflux, but you have hydronephrosis and it's significant, you may do a MAC3 Lasix renogram to rule out an obstruction. The top-down approach, which was kind of initially proposed by Hansen in 2004, even though I think Great Ormond Street was kind of using the same approach earlier, but kind of formalized by the ESPR guideline in 2007, is that if you have a febrile UTI, you do a DMSA scan plus or minus ultrasound within 4 weeks of UTI. If you have a cortical defect or signs of urethral dilatation, you do a VCUG, and you may or may not do a DMSA scan later at 6 to 12 months. If it's normal, you don't do a VCUG. There was a modified top-down approach, which was proposed by Dr. Snodgrass and Nicole Bush, which was published in 2015, where they kind of said, well, we won't do an acute DMSA scan, but we could do a DMSA scan 6 to 12 months later following a febrile UTI. We would still do a VCUG if the ultrasound was abnormal, following the AAP guidelines. And then if the DMSA was abnormal at 6 to 12 months, then we would do a VCUG. So what do the guidelines recommend? I just picked up 3 guidelines. Dr. Coyle actually has a great paper with Michael Chua from Sick Kids, which looks at several guidelines. In fact, maybe more than 6 or 7 of them, which and kind of discusses, what do they recommend. So just as a summary, AAP is simple. So it applies to 2 to 24 months. You do an ultrasound and all after a UTI. You do not do a VCUG unless the ultrasound is abnormal or if you have recurrent UTIs, and they don't really talk about a DMSA. The EUA ESPU guideline, which actually had an update in 2021, again suggests mostly the same thing, except that they are a bit more selective about the VCUG. So they would do a VCUG if you have infants, you have a non-E. coli UTI, or if the ultrasound is abnormal. And again, they don't comment on DMSAs. The NICE is a bit more complicated. So it kind of divides patients under 6 months, 6 months to 3 years, beyond 3 years. And they would recommend an ultrasound in most under 6 months, and beyond 6 months only if it's an atypical or a recurrent UTI. The VCUG indications are a bit more restricted there. So only under 6 months and for atypical or recurrent UTIs. So I think the first thing before we kind of begin this discussion is what is the goal of investigating UTIs in children? And I think we need to kind of agree and think about this because that is what would define the rest of this presentation, right? So our primary goal is really to prevent renal damage. So we want to prevent acquired scarring. We want to decrease the risk of hypertension or loss of renal function, and hopefully not ESRD for sure. And our secondary goal is really to prevent recurrent UTI. And we can't ignore that because that has a significant morbidity associated with it besides healthcare costs. And then we want to optimize the benefits of the benefit to cost ratio. And so what is the cost here? The cost is financial, which is easy to estimate, but there are other costs which we need to think about. What about radiation exposure? What about catheter-related trauma and other issues secondary to that? So I thought we could kind of start with this slide, and maybe people may not even agree on this, but I thought this is what we can agree on. And please correct me if I'm wrong later when you ask questions. But I think treating VUR is not a primary goal. And I think we have learned that, especially under grade 3, right? VUR is not necessary or sufficient to cause scarring. And I think we kind of clearly know that. So you can have scarring without VUR, and I think that's an important statement to make. VUR, especially more than grade 3, may be a risk factor for renal damage due to renal scarring following UTI, or due to even congenital dysplasia. And I think that's an important factor, maybe more than acquired scarring. BBD, or bladder bowel dysfunction, has a prominent role in predicting the risk of recurrent UTI. And I think that's something which has changed the management of VUR significantly. And congenital dysplasia probably contributes significantly to loss of renal function or over time or at baseline than actually acquired scarring. So here are a few cases I picked up from my kind of list here, just to reinforce the point that peds urology really is a spectrum, and we kind of do this for several things: hydronephrosis, megaureters, etc. Can one solution work? Can one approach work all the time? So here's a case. This is a 7-year-old girl. When I saw her, she had first VCG at 5 years of age for recurrent UTI. They diagnosed grade 4 left VUR, grade 1 right VUR. They actually did bilateral deflux injections on her. She kept getting UTIs and presented to us. When she presented to us, we did an ultrasound. We also did a VMSA, and we also did a VCUG. So the ultrasound looks pretty good, right? The kidney looks, has good parenchymal thickness. I don't see any obvious scars unless any one of you do, but the DMSA was bad. So it showed bilateral scarring here in the right and left kidneys, especially in the upper poles of both kidneys. And the function was pretty equal on both sides. There was a bit of poor uptake on this left kidney here. And then she had a VCUG which showed this. So the VCUG showed that she had bilateral VUR, which is kind of grade 3 now on both sides. You can kind of see her deflux implants on second or the right picture there. But they were not emptying very well as well. And so, you know, going back to kind of thinking about this case, if we did a top-down approach, maybe the VUR on the right would have been a higher grade because it was labeled as a grade 1, but I think it was higher. And we don't know because, you know, was this scar acquired after this intervention or was it always there? So we don't know that clearly. Also, the fact that she had so early reflux on the left, it's a poor UBJ mechanism there, right? And that's why the deflux failed. And also because of the fact that her PBD was not managed adequately. She eventually underwent a bilateral extravesical robot-assisted reimplant and is doing fine after we kind of treated her BBD. So here's another one. So this is a 4-year-old girl who came to us. We did a top-down approach, recurrent UTI. This DMSA scan clearly shows that the right kidney has significant hyperplasia / scarring on the lower pole. She had no BBD and her uroflow was perfect. She had no post-void residue. So I said, okay, well, let's try to see if we can manage her without doing a reimplant or without going to a VCUG. Well, that didn't work. She kept getting UTIs. So we did a VCUG and this is what the VCUG shows. And again, here, you know, the second picture is something which Louis and I have talked about quite a bit, but, you know, the bladder is empty, the ureter and the kidney is not draining. We almost are worried about a UPJ obstruction, but it's not diluted contrast up in the kidney. So I'm not so worried about it, but I think there's grounds for stasis here, right? So no BBD with significant scarring. We should have probably done a VCUG right away and gone on to a reimplant. She did very well after a reimplant. And I think the VUR was an issue here. So here's another one. This is a girl who had 3 UTIs in the first 4 months of life. And interestingly, we followed, or not we, but she was from Windsor, which is about 2 hours away from us. Nobody did anything besides an ultrasound for her 3 UTIs. And then after her 4th UTI, she did get a VCUG. They did a VCUG with a catheter. And for learners here, you shouldn't do that because that looks like a urethrocoel or whatever. But you should just do it with a feeding tube. So anyway, she had bilateral high-grade VUR, had a DMSA scan, and the DMSA scan actually, very interestingly, at least on static images, only showed me this small area of possible scarring. It didn't look too bad, actually, given the fact that she had 4 febrile UTIs. But when we did a SPECT scan, and that's part of our DMSA protocol, we actually found multiple scarring on both sides. So the reason I put this up is just the fact that static images on DMSA may not show us all that we want to see. She underwent a bilateral open Coyle ureteric reimplant. She actually still had UTIs after, so we had to do a VCUG post-reimplant. The bladder looks a bit funny. It looks a bit tall, not neurogenic, but I was a bit worried about her voiding dysfunction or BBD. She does empty well, as you see in the next image. So again, if you went by TDA, we may not have predicted the grade of VUR if you only look at static images. So coming to the key questions for our talk here today. So is there more value in identifying the marker, which is VUR for scarring, or the outcome, which is actually a scar or congenital dysplasia? I think that's the key question we have to kind of keep in the back of our head. And then when we discuss TDA, does an abnormal DMSA predict risk of hypertension or loss of renal function and risk of recurrent UTI? That's our primary outcome, if you remember from the goals slide. Does abnormal DMSA predict high-grade VUR? Can we quantify DMSA scans better and improve the specificity of identifying high-grade VUR? And does early abnormal DMSA translate to an abnormal DMSA later? When we discuss BUA, do those same things apply? Does abnormal VCUG or VUR predict the same? Is it more important to identify high-grade VUR or scarring? And then the other issues, which are pretty important, is radiation exposure. Is radiation exposure higher with a TDA versus a BUA? Can treatment of BBD make most of these questions redundant? And do we actually believe in the Big Bang theory of renal damage? You know, that's one of those pediatric urology grand thoughts, which I kind of, believe just because it involves such great people who proposed it. But does one or two bad UTIs cause significant damage? So does abnormal DMSA predict loss of renal function? So that's our first question. And there are a couple of studies which looked at, long-term follow-up. The one with Venestrom compared 57 children with scarring with 51 who did not. And they had a pretty long follow-up, 16 to 26 years post-pediatric UTI. What they found is that unilateral scarring is not associated with loss of GFR, but there is a significant loss in individual renal GFR. In this series, only 7 had bilateral scarring, so that wasn't helpful. But compared with unilateral scarring, these patients did have a significant loss in GFR. And both acquired and congenital dysplasia lost equal amount of GFR over time. So we do know that unilateral scarring promotes compensatory hypertrophy of the other kidney, and that may allow normal GFR overall. The risk of hypertension is harder to classify. In the literature, it kind of ranges between 15 to 30%, but it's hard to really quantify because most of these studies have been based on previous IVPs and I wouldn't say improper, but different management of UTIs and VUR. So this is another one which is a bit more recent and looks at a short-term outcome. So this is a study by Yi, which looked at creatinine clearance 3.2 months post-DMSA. And they graded the DMSA as per the RIVER protocol, essentially depending on how many of the 12 segments of the kidney which are affected. So the key findings was that bilateral scarring was again associated with lower creatinine clearance, but the grade of scarring actually did not predict creatinine clearance. So I think in general, the risk of loss of GFR or loss of renal function and hypertension is a bit over advertised, I would say. I think unilateral scarring is well handled by compensatory hypertrophy. The risk of hypertension is low, especially if we don't have bilateral or significant scarring. And when we look at transplant lists, VUR or VUR nephropathy has been pretty static. So, the big study by Craig, which looked at VUR lists between 1971 and 98, it was pretty much the same at 14%. And if you look at North American studies, which was more recent, that number is about 8.2%. And I think Dr. Coyle kind of emphasized this point that congenital dysplasia actually may be a bigger factor and a more contributory factor in loss of renal function than acquired scarring. And I think that's more true as we kind of move on to be more proactive and treat UTIs more proactively. So does abnormal DMSA predict high-grade VUR? I think this is kind of the key question. And Hansen et al., who kind of defined the TDA, and PEDA, who kind of did a subsequent prospective study, and Dr. Maguire and Dan Hurst did another study, which was published in 2010, are kind of the key ones. There are several, and I won't kind of discuss all of them. So the first one really was a retrospective study, a DMSA done within 3 months of a UTI. Abnormal DMSA was highly correlated with high-grade VUR, and only 7 with a normal DMSA had dilating VUR. So we really didn't miss significant VUR. The same group did a prospective study, which was then published in 2007. Again, here, 51% had a positive DMSA, 85% had VUR, and they identified 96% of VUR, which was more than grade 3. More importantly, 44% did have positive scans, but no VUR, and we'll talk more about this later. Dan Hurst, in their prospective study, again showed that 50% of those with abnormal initial DMSA scans had dilating VUR, so a high odds ratio of predicting high-grade VUR. Here's another study, or actually a Cochrane review, which is more recent. There was a meta-analysis in 2011, but I chose to kind of exclude that and just include this. And so this includes 42 studies, 0 to 19 years, DMSA within 1 month of a UTI. So this is acute phase DMSA scans. And for all VUR grades, there's sensitivity and specificity were 0.75 and 0.48. And looking specifically at high-grade VUR, 3 to 5, the sensitivity was 93%, and the specificity fell down to 44%. So the likelihood of missing high-grade VUR is low, under 1% probability. On the other hand, high risk of overdiagnosis here, right? So if you look at this study, you could, if you were going to do a VCUG for everyone who has an abnormal DMSA scan, if you are following the top-down approach, you would do 4 out of 5 VCUGs, which will not show high-grade VUR or VUR beyond or equal to grade 3. So that's an important point to kind of remember. On the contrary, does normal DMSA miss high-grade VUR? So the answer there is unlikely, though Hurst and Hansen both showed some patients where they did have VUR, which they missed, VUR, which was at least grade 3. In general, most studies show that the risk of missing high-grade VUR, or at least dilating VUR, is less than 10%. The question then also becomes, are we talking about acute phase DMSA or late DMSAs? And obviously, late DMSAs will be at a higher risk of missing high-grade VUR than acute phase scans. The other question is, does an early abnormal DMSA translate to an abnormal DMSA later? Because we are actually looking at permanent scarring, right? So we don't really care for, or we don't, I wouldn't say we don't care, but if you have an acute DMSA which shows some abnormalities, does that persist? And if they don't persist, then, well, we are okay. So it is not true always, right? Only 9.5 to 11.9% of those who actually show an acute DMSA change will have a scar on follow-up 6 to 12 months later. So follow-up DMSA scans are almost mandatory if you follow the TDA, because if you don't really know whether that was really a scar or not. The other question is really that not all abnormal DMSA scans are equal. You know, we are, as surgeons, very simplistic. We like black and white. We want yes or no, abnormal versus normal. But I think we all recognize that we need to be a bit more selective. So what is an abnormal DMSA? Is the scar unilateral versus bilateral? Is it congenital versus acquired? Is it small versus big, or multiple scars? And I think those are important questions. So here are a couple of slides just to kind of, think about those. So here is two scans on the same patient. So the one on the left is the first one, and the second one is about 2 years later. So the first scan shows that the right kidney has about 40, I'm just trying to see here, about 40% function. And it kind of seems to have kind of global poor uptake or poor dysplasia. And then this kid got recurrent UTIs. And the second scan actually shows that the right kidney has better function now. But that, as we obviously know, is a fallacy. It just means that the left kidney is losing function. And so when you look at the static images, now that the left kidney has a scar on the lower pole, as you can see in the lower image there, right? So this is like congenital dysplasia plus, and interestingly, and very interestingly, actually, that's why I put this here. This girl only had VUR on the right side. There was no VUR on the left. So she still lost function because of recurrent UTIs on the left side. And here's another one, again, showing that congenital dysplasia can exist with acquired scarring. So here, as you can see, the right kidney again has poor uptake. It looks kind of small, has really poor uptake, but it has only two small scars on the SPECT scanning there. And it has 36% differential function. So that differential function is not because of those two small scars, it's because of congenital renal dysplasia. And I think, that is always kind of under-recognized. So the next question then is, does abnormal DMSA predict the risk of recurrent UTI? Because that's our goal, right? So this is a good study by Kim, and they kind of graded DMSAs from 0 to 3. You can see those pictures below. And they developed a VSS, or a visual scoring system, for DMSA scans. And they did a multivariable regression analysis adjusting for VUR. And they found that the only predictive factor for recurrent UTIs was an abnormal DMSA with a score above 2, with a hazard ratio of 7.5. So 55% with VSS more than 2 had recurrent UTIs compared to 7.2% with VSS under 2. This was also shown in the HERS study, where they said that in patients with recurrent UTI, almost 85% had abnormal DMSA. The other factor which we need to consider is the fact that the TDA can lead to more VCUGs than if we just followed the AAP guidelines of just doing a renal bladder ultrasound, right? So this is a study which looked at 75 children who had a TDA versus a modified AAP guideline. And the number of VCGs performed was higher in the TDA group. And you could potentially reduce the number of VCGs by about 10% if you didn't follow the TDA. Dr. Khoury and Abdul Halim actually did a pretty good review. And if you're performing VCGs for all abnormal DMSA scans, if you're following the TDA, we could end up actually with negative VCGs in up to 64% of patients. The last thing to kind of highlight really is radiation exposure and costs. We all do pulsed fluoroscopy for VCG now, at least in North America. And I think that's pretty much the standard. And when we compare it with DMSA, DMSA has a much higher exposure to radiation. So almost 2 to 3 times. So DMSA 0.7 to 1 millisievert, VCUG 0.06 to 0.3 millisievert. Other things to consider is that there is a bit more of a diffuse radiation exposure with DMSA versus VCUG, but kidneys are more radio-resistant versus gonads. Hopefully, most of our radiologists protect the gonads when they do a VCUG. In addition, if the TDA is followed, there'll be an additional radiation exposure from the next VCUG we order following an abnormal DMSA. Jonathan Routh actually did a pretty good study where they kind of created a cohort of 100,000 children. And when they followed TDAA, the cost, at least in the US, is almost 23 million more than a BUA. So that's, again, a significant thing to consider. Does abnormal VCUG or VUR predict the same? So that's the opposite question about the BUA. I think the risk of pyelonephritis and scarring decreases with age, and also VUR resolves with age. So therefore, this question is more age dependent. We all know that VUR is not homogeneous. It's a spectrum disease. And we have learned better over time to kind of manage this better. The question is, does VUR actually cause UTI? It definitely facilitates bacteriuria and pyelonephritis. And maybe there is stasis with high-grade VUR. Maybe there is some partial UVJ obstruction, like you saw in those images earlier. But it's hard to kind of quantify or grade VUR as to where does it predispose to UTI. The other factor which I wanted to bring up is that not all UTIs are the same, right? And I think all of these studies are kind of labeling them all as the same. So obviously febrile or not, how do you collect the urine? What were the markers, CRP and procalcitonin? How early was the treatment? What was the response to treatment? Was this a pyelonephritis? What was compliance? So when we look at risk factors for VUR in children with UTI, we know that, if you have an abnormal ultrasound, you have an abnormal DMSA, you have siblings with VUR, you have antenatal hydronephrosis, you have a higher likelihood of identifying VUR, right? Also in boys under 1 year, especially circumcised boys or atypical UTIs or recurrent UTIs. And then again, comes down to those biomarkers, which we don't use very well as pediatric urologists, but maybe we should. In fact, I kind of learned this mainly through preparing for this talk. What is the risk factors for scarring after a first UTI? Again, that is important. So the risk factors are really high-grade VUR, abnormal ultrasound, elevated CRP and white cell count, temperature above 39, UTI, non-E. coli, BBD, delayed treatment, and younger age. So just concluding here and kind of reviewing TDA. So what are the pros with TDA? So it does rule out high-grade VOR. It does decrease the detection of low-grade VOR, which we would if we did be a bottom-up approach. There's no catheter, so no trauma, no UTIs. And it actually reassures the parents and physicians that the primary goal we are focusing on is intact. There are several cons though, right? So it has low specificity for high-grade VOR. So if you have an abnormal DMSA scan, you would go for a VCUG and then find, no VOR or low-grade VOR. It is costly. There are questions about access and availability of DMSA. So for example, in Canada right now, we actually have to get a Health Canada approval for every DMSA scan we order. You may need some sedation because these kids need to be kind of still for some time. There's certainly higher radiation exposure, more than a VCUG, requires an IV, which can be traumatic. And, on the contrary to a VCUG, we can identify small and insignificant scars. The BUA, there are some pros. We identify high-grade VOR, which may require surgery. We may even find other things which TDA will not allow, say a non-neurogenic neurogenic bladder, or even a spinning top urethra or whatever. But there are some advantages of seeing that as a surgeon, especially. It does identify other potential anomalies, which I just listed. It appeals to our instinct of being in control, and we can kind of treat it because we have a good operation to treat it actually, but that's debatable, and can allow better selection for DMSA studies based on the grade of VOR. The cons obviously are the catheter, which is actually pretty traumatic. And, I just listed trauma and UTI, but I can tell you at least 50 stories of bad catheter issues with a VCUG in my 10 years of practice. So, and I think we all know that. The radiation exposure is minimal, so it's not really a con. It does not address the primary goal of renal function and scarring. And we do identify insignificant low-grade VOR. So in concluding, TDA is a reasonable approach, but it does have caveats and it is not applicable to all. I think we need to be in the middle of that road I was showing earlier. The severity of the UTI, maybe using some biomarkers, age, risk factors for scarring, and high-grade VOR should be factored in. Like a VCUG, diagnosing low-grade VOR, which we consider unimportant, the TDA can diagnose unimportant scarring. It's almost like the same thing. I think we should be selective in performing a VCUG following the TDA, and maybe grading DMSAs and looking for bilateral scarring would be factors which could lower our threshold for a VCUG. We should include costs, radiation exposure, and our access to DMSA in our decision-making. I don't think that one rule fits all, and we should all just take time to kind of think about it. And I think lastly, and most importantly, this is the world of EBM and evidence-based medicine. But I think we should trust our clinical judgment, and I don't know how to put this, but I think involve the family, trust your clinical judgment, and keep the goals in focus, and I think you'll be fine. And, if you just stick to EBM all the time, that is great and good, but we can't find evidence for many, many things we do, and we still do it. And maybe that's not a message for our younger colleagues here who are in this meeting, but I think overall it is. And if somebody like Dr. Coyle or even Dr. Braga and Dr. Agarwala here, they use their clinical judgment to make a decision, I think that's okay. We don't have to stick to one approach. So that's my key message. Thank you. I hope I didn't run too much over.
Thank you, Sumit. Meenu Bajpai here. As always, your talks bring to the table the available literature. The challenge is we have to find solutions also. And as you very rightly said, whether DMSA is apt enough and top down is good enough. And you have certainly bring to the table a lot of literature. Now, we are in the business of treating VUR. So obviously, we are a little biased as to, are we losing out on something? So let us put one of the observations. It's a Pandora's box. You are very right that that opinions vary. And this particular condition has been treated by personal opinions more than evidence. So you said there was an observation that you made very honestly. Treating VUR is not the primary goal. And if I just throw up a few questions, and we have solvers here who would pour in their experience, I'll just cite 3 studies, nice guidance. It found that surveillance of no use, surveillance was the way to go because prophylactic antibiotics do not prevent UTIs. So they said, you treat UTIs as they come. And we are talking about very young babies who may not actually scream they have UTI, rather vague symptoms and treated by GPs. Then the second study is RIVUR trial, which very clearly proved that prophylaxis is better than surveillance. And then we have Swedish trial, which had all the 3 arms equally powered. And they said that stopping reflux has incremental advantages, especially with endoscopic injection, where obviously the stakes are less high than open interventions of the conventional types. So we often ask, are we intending to treat or intending to cure reflux? Reflux is a pathology. There is an abnormality at the VU junction. This is not normal. Does it cause a consequence of events which are detrimental to kidney function? And so with these questions haunting us, we have to fish out from the literature when we see a child with VUR as to how do we address them. With whatever knowledge we have, and we definitely get more enhanced knowledge with these interactions. Therefore, I think I leave it to the panelists. Dr. Agarwala, do you have any points to make so that we can discuss it?
Thank you, Sumit, for this wonderful talk. So there are a few issues that I mean, being in India is very important. One is, as you know, that DMSA may not be available everywhere. So what is the alternative? I mean, if we have DMSA in a prominent way in the investigative armamentarium, VCUG is more easily available, but obviously with a lot of problems. So that is one of the questions that Secondly, you mentioned about GFR. So GFR, you're talking about an eGFR, or you're talking about a GFR, which is the way that we do it with DTPA and 2-sample method, the actual GFR which is coming out. So that is again something which always kind of puzzles. And also an important question is, how early should the DMSA be done? I mean, there are papers doing DMSA during the time of UTI, within 3 months, or beyond 3 months. And you have tried to address those questions by showing different literature and different outcomes. And we know that DMSA, which is done during the time of acute UTI, may actually pick up a pyelonephritic scar, which is not there later on because it resolves. So that is not a scar which we are worried about in this. So these are the few things, and I'm sure the other experts are going to also pour in their experience and tell us. So can we ask Dr. Martin Coyle now for his observations? Then Sumit can, in the end, take them all up together, right?
Sumit, I thought it was a brilliant talk, and you echoed so many questions that go through my mind, and probably being the oldest one in this conference, I'd like to echo, maybe Luke can correct me on this, but Montaigne said, there are no answers, only questions. And I think that's so true when it comes to reflux, because reflux is what stimulated the growth of pediatric urology. It wasn't hypospadias, it wasn't undescended testes. It was, we thought every single reflux, whether it was grade 1 or grade 5, led to end-stage renal disease, preeclampsia, or hypertension at a minimum. So Arnold Kolodny used to say, everyone needs an operation. Our job is to find out which one. And I can tell you, we were doing 15, 20 reimplants a week at Boston Children's Hospital when I was there. When I left sick kids, we weren't doing, excluding our transplant patients, we weren't doing 10 a year. So yeah, we were defluxing, but I think, Sumit, you made the absolute perfect point with your last slide, the last statement. It really is a joint decision making, and so much depends, I think, on choosing the right family, really getting a good history, because I think bowel bladder dysfunction, in particular in females, is something that can lead to severe renal damage. So I worry more about 3-year-old girls with pyelonephritis than I do about the little boys, because they have dysplasia in all likelihood. They have high-grade reflux and dysplasia. So a lot depends on, is it an educated family? Are they going to come for follow-up? Are they going to be compliant? So my job is to protect the child and not to treat a funny-looking X-ray. So just like you, Sumit, I think you basically decide on the treatment based on consultation and understanding with the family. And because we really don't know if reflux really causes any of the problems that we've historically thought they were responsible for. So Luc, bonjour.
Bonjour. Yeah, that was a fantastic talk, really. That was very good. And all the points you made were absolutely spot on. As you were saying, actually, what is it we are hoping to do? And the problem is we have absolutely no answers to the true question, which is, as you were saying, maybe avoiding recurrent UTIs, but it's not actually clear that by diagnosing VUR, we are avoiding these recurrent UTIs. One of the cases you showed, you'd actually corrected the VUR, but the child was still having UTIs. So in the literature, we have found the answer to the question, does DMSA identify high-grade VUR? But the actual question is, does DMSA identify recurrence? And you showed some papers. We also did a study on that and showed that there was a higher OR if the DMSA was abnormal, but in reality, very few children actually do present a recurrent UTI. And are we protecting renal function? Again, that we do not have the answer that we are actually protecting anybody of anything. And as Marty just said, it also depends on the age of the child, what availability of healthcare. I mean, are parents going to be able to go to a hospital quickly and have treatment, as you were showing in your presentation? I mean, if you're going to be able to treat the UTI within 24 hours, it might be better just to wait for the UTI to appear, and then you can identify at least those who have recurrent UTIs. And if you use the top down or bottom up for recurrent UTIs, then you're actually much more relevant than doing it for a first episode. And then there's also the effect of having prenatal information. If you have information from prenatal scans and you know that the prenatal scans were normal, then that's also a different patient. So the thing is, if it's, as everybody was saying previously, if it's a boy, if it's a girl, if he's young, if he's old, if he's circumcised, if he's not, if the parents have a good availability to healthcare system, if they are reliable. Actually, there are so many different scenarios that, again, I agree that the last sentence of your presentation said it all. That we just need time to gain all that experience. That fantastic presentation, well done.
Thank you, Louis. Can we ask Professor Braga?
Yes, thank you very much. I think, Sumit, I'm very proud of you. I'm just saying that because we started together at Sick Kids as fellowship colleagues there, and it's very nice to see you flourish with your career. And by the way, for those who do not know, I think Sumit needs to update his slide because he is not associate professor but full professor. So congratulations. Welcome to the club. I think my 2 cents on this are the following. First of all, I think I'm also going to say that because Luc, and I have the highest regard for him, coming from France, and I've done training in France, and I know that France sometimes, especially the big professeurs, they will follow, and they tend to be a bit dogmatic. But I'm saying that because Luc is one of the, I would say, 5 or 6 French pediatric urologists that is very evidence-based, and we can see that from not only when he speaks publicly, but from his publications and doing randomized controlled trials and being at the head of ESPU with the Research and Education Committee. So based on what Dr. Dave mentioned, I'm a bottom-up approach type of guy, and the reason for that are twofold. First of all, a lot of the proponents of the top-down approach, they say that there is no need for catheter. And I think this is misleading because, as Dr. Dave showed well, if you have a positive scan, an abnormal DSA, which will happen in 60% or 65% of the case, then in those cases, you're going to have to do a VCUG. So actually, you're doing a VCUG and putting a catheter in at least half of those patients with a top-down approach. So, if you could just stop it on the DMSA, it would be great. The second thing that I think Dr. Coyle nailed on the head is that, especially in Canada, we have to have this shared decision-making. And I talked to the families, to quote Colin Powell, I think knowledge is power. And the power for what? Not the power for the surgeon, but the power to allow us or the families to be able to make a concrete decision on what we want to do. So I do like to have the diagnosis of VUR, because based on that, I have something concrete to discuss with the families. And based on that, based on the studies done by Chris Cooper and Dr. Tony Curry, we are ready, and then Andrew Kirsch, we know the prognostic factors and the risk factors for recurrent UTIs. You can put on a eye reflex calculator, like Luke Harper mentioned. You can use, like, if the patient is circumcised, female, age, BBD, the grade of reflux, etc., etc. So this gives us, some criteria, or at least base for discussion in order to decide what's best for that particular patient. And finally, I think once we have the diagnosis, which is VUR, you know the risk factors, then I tend to stratify the patients, because it's very important that not everybody, like Dr. Coyle mentioned, needs an operation. But I do find that nowadays, I think if you select the patients based on this risk stratification, you're able to choose some not to do nothing. Some you're going to give antibiotic prophylaxis, and maybe some you can even operate or be more aggressive up front. The final, not to take too long, one more reason why I like the VCUG is because it also allows me to look at the ureter. And I think based on the studies done by Chris Cooper about the urethral diameter ratio, I think new studies are coming that this may predict what Luke is saying, that the DMSCA doesn't allow us to predict which ones. Not only the urethral diameter ratio predicts a resolution of VUR, which is not important, but I think now it's coming data about predicting who are going to get recurrent UTI. So therefore, because of all these 3 factors, I think I prefer to have the VCUG. And as Sumit mentioned, the radiation, if done properly in a setting, and especially in young children, it is not as portrayed in a bad way, like some of the we've seen in the literature or some discussions. Sorry if I took too long.
Thank you, Dr. Braga. So Sumit, back to you for your.
Yeah, so I think I agree with all these comments, and it's great to have three, excellent people here. Dr. Coyle, who I kind of, recognize as one of my mentors, and so, yeah, I think the basic point really is that, I think one approach for this complex issue, like everything in pediatric urology, and I think that's why, at least for me, that's why I love pediatric urology, and I think for all of us, is the fact that it's always a spectrum, and we have to kind of think of, various factors, and we're trying to make risk calculators, as Lewis mentioned. But I think that the fact is that we have to be selective. We cannot just go with one approach. Yes, guidelines are good. Guidelines are good for maybe people outside of pediatric urology. I don't know, like people who look at people or patients with recurrent UTIs or UTIs in general. But I always do not like guidelines in general, because they are just so prescriptive and sometimes, do not work, right? So my main thought really is the fact that I agree with Lewis in the sense that I feel, at least in my view, that the AAP guideline is pretty good. We do need some VCUGs. Yes, a catheter is bad, and we recognize that, but I think it shows us lots. And, it comes back to, I remember a very old, Dr. Coyle will probably remember this, old urology clinics of North America publication, which talked about hydronephrosis, and this is more about UPJO. And it said, what is conservative management of UPJO? And they said, oh, well, yeah, we just follow them versus doing surgery. And actually, the person who was arguing about surgery said the conservative management is actually to do surgery, because we have a great operation to do this, right? So I think in some ways, as surgeons, we have to keep in the back of our head that we do know how to fix reflux, right? But does that mean we should do it for everyone? No. But I think we still should have that thought in our head, which means like we can do a reimplant, which will work. I'm not so sure about reflux, but that's another discussion. But we do know how to fix reflux, right? So where we do need to fix it, we should, right? And we should recognize that. And I think that's what Lewis was kind of heading to, in the sense that, if we do a bottom-up approach, we can identify people who we think we need to fix, and we can, right? So I think it gives us as surgeons a bit more control and a bit more sense of, doing something. But I think, to Dr. Coyle's point, as surgeons, we don't need to do surgery to be surgeons all the time, right? Is that okay?
Well,
I'm semi-retired, so I could say that with a straight face.
thank you, Sumit. And think, as always, for more than 50 years, BUR has been like this, only a lot of wobbling in terms of opinions. And literature has come up over a period of time, but it is not leading much, except that the availability of biomarkers now and more realistic trials. IRS was the trial which was indoctrinating a generation of nephrologists for so many years. Gene Smalley study done in 2 continents. But now we have RIVR study trial reports, and we have some wonderful reports. Hopefully, the next 25 years would settle down, if not early. Thank you very much. We are going to, under the societies this year, we are going to have a full symposium on VUR. We would love to have you guys there so that we can actually come little forward than we are. Thank you so much, all of you, Martin and Dr. Braga. You will all be here because the next talk you are the moderator, the panelists again. And Mehat, please.
Thank you, sir, for your elucidative presentation. This year's Early Career Pediatric Urologist Award is awarded to Dr. Alisha Gupta. Dr. Alisha Gupta is an AIMS alumnus. She has completed her MCH degree in pediatric surgery at AIMS New Delhi, following which she has joined as Senior Research Associate at Chacha Nehru Hospital, New Delhi. She did 1 year of fellowship at Great Ormond Street Hospital, UK, and has worked as a fellow at Perth Children's Hospital in Australia for 2 years. She is currently working as a fellow in pediatric urology at Monash Children's Hospital, Melbourne. With special interest in urology, she has published 19 articles in national and international index journals, along with 4 book chapters. I now invite Dr. Alisha Gupta for her talk on fetal urology, the present stance and future perspectives. Over to you, ma'am.
Thank you, Mahek. Good afternoon to everyone, or rather I should say good day to all the attendees and panelists attending across the globe. It is indeed an honor to be nominated for this silver lecture and an honor to be presenting on fetal urology in the presence of stalwarts in the field. I think we already had an extensive discussion on the topic a few minutes ago by Professor Coyle's talk, but this would be mostly a review of the practice of fetal urology, where we have reached so far, and the potential upcoming innovations in the field. With that, I will just share my screen 1 second. Can you see my screen now? So the topic for today is fetal urology, present stance and future perspectives. It all started many, many centuries ago with cadaveric dissections, actually, when the surgeons first learned about the insides of the body and then practiced it and then eventually succeeded in the field. And this has come so way forward that now we have actually conquered life before life. The whole fetal urological assessment or fetal sonographic assessment started in 1958 with the pioneer paper by Dr. Ian Donald on investigation of abdominal masses by pulse ultrasound. And this was the first time fetal sonography was done. And this was subsequently used for diagnosing many congenital conditions. And the first urological anomaly that was detected on prenatal scan was a fetal polycystic kidney disease in 1970. Ever since then, many fetal urological conditions such as hydronephrosis, polycystic kidneys, posterior urethral valves, etc., have been diagnosed and intervened on based upon fetal urological intervention. To start with the embryology, as we all know, the fetal renal development starts in the fifth week of gestation when the ureteric bud meets the metanephric blastema, and which subsequently gets induced to form a normal kidney. This can be seen as early as on the 12-week antenatal scan, with proper echogenic texture being visualized in the kidneys at 20 weeks. The kidney formation is complete by 36 to 40 weeks of gestation. Depending upon the timing of the insult, we have underlying pathophysiologies leading to various renal anomalies. If there is a defect in the fusion of the ureteric bud to the metanephric blastema, this leads to renal agenesis. An abnormal fusion leads to renal dysplasia. And as the kidneys go up from the pelvis to the abdomen, an abnormal migration can lead to the presence of ectopic or horseshoe kidneys. And an abnormal fusion of the mesonephric duct in the midline can lead to the presence of the psychoureteric reflux because of abnormal detrusor, or the development of posterior urethral valves because of abnormal formation of the posterior urethra. And another important aspect of fetal urology is the amniotic fluid. The amniotic fluid, as we all know, principally depends upon urine production from around the 16th week of gestation and ranges from up to 380 cc at the 20th week to 800 cc at the 28th to the 40th week of gestation, with fetal urine production being 5 cc per hour at 20 weeks, which increases massively to 50 cc per hour by 40 weeks of gestation. And an objective index of measurement of amniotic fluid is the amniotic fluid index that calculates or adds the distance of amniotic fluid windows in all 4 quadrants. And an amniotic fluid index less than 6 is labeled as oligohydramnios, and more than 17 labeled as polyhydramnios. So why is oligohydramnios important? So as we know, if there is a problem in urine production in the kidneys, leading to a decrease in the fetal urine production, leading to a decrease in the amniotic fluid, this decreases the pressure of fluid in the lungs and decreases the mechanical stimulation that the lung needs for growth. And this can subsequently lead to lung hypoplasia and agenesis. This is the cornerstone after which the fetal urological interventions have started to curtail. So prenatal imaging can consist of either ultrasound, MRI, or fetal cystoscopy. Ultrasound has been the cornerstone of fetal prenatal imaging and subsequent intervention. And this will be mostly our discussion topic today. I will briefly touch upon MRI and fetal cystoscopy in the subsequent slides. So prenatal ultrasound can be used for screening, for defining the significance of the screen findings, for prognostication, and also to guide intervention. Screening can be done for lethal kidney diseases such as bilateral dysplastic or absent kidneys or severe polycystic kidney disease that can help guide the families towards termination of pregnancy. And in most commonly seen are the non-lethal conditions such as hydronephrosis or hydroureteronephrosis and bladder outlet obstruction or unilateral multicystic dysplastic kidneys or duplex systems that can either just be monitored in utero or at least can be referred as early to a pediatric urologist as possible for further follow-up and management. The incidence of fetal anomalies overall, diagnosed and routine antenatal scans have been up to 1 to 2% of all pregnancies. And of this, 20% are urological anomalies. Antenatal hydronephrosis itself contributes 1 to 5% of all fetal anomaly scans, with an incidence of lower urinary tract obstruction being 2.2 per 10,000 live births, out of which 62% have been diagnosed prenatally. So what all needs to be seen on an antenatal scan? So starting from outside going inwards, we have to look at the renal parenchyma, its echogenicity, and the presence of cortical changes. Going inside, we look at the calyces and the pelvis and its dilatation. Then going downwards, we look at the ureter, then the bladder wall thickness, diameter, and bladder cycling, and posterior urethra if possible. We also have to look at the other kidney and see if there are any other abnormalities, such as suspected pelvic-ureteric or uretrovesical junction based upon the presence of hydronephrosis or hydroureteronephrosis. As a whole, the fetus also needs to be evaluated for the presence of other congenital anomalies, the presence of oligohydramnios, and the status of lung hypoplasia, if any. Once an anomaly or a finding is noted, we need to define whether this is pathological or not. And for this, the Society for Fetal Urology had published a consensus statement in 2010 for evaluation and management of antenatal hydronephrosis. And as we said earlier, out of 1 to 5% of all pregnancies that are noted to have antenatal hydronephrosis, not all findings represent pathology. Many can be transient and resolve spontaneously, either in fetal-like or postnatally. The postnatally antenatal hydronephrosis persists in up to 30 to 40% of pregnancies, out of which 30% of these resolve postnatally and the others persist and need further investigation/management. The risk of pathology in persistent hydronephrosis is dependent upon the severity of hydronephrosis, with just being 10% risk of pathology in mild hydronephrosis going up to 88% in children who have severe hydronephrosis. The anterior posterior diameter of the pelvis is the standard measurement parameter used across the globe to compare outcomes between various studies. This is a surrogate marker of potential disease because it cannot specifically identify pathology. And factors affecting the diameter can include the gestational age, the hydration status of the mother, and the degree of bladder distension. So what value of the AP diameter is concerning? No consensus has been reached so far, but an arbitrary value of 15 millimeter was set as a cutoff by Coyle et al. And they said a sensitivity of 73% with a specificity of 82% was given to this value for determining obstruction. Similarly, another group by Lee et al. Said more than 10 millimeters in later gestation signifies 88% of pathology, and more than 15 millimeter overall can denote 60% of pathology. The Society for Fetal Urology gave a standard grading system back in 2010, based upon the splitting of the sinus, starting with mild grade 1, barely splitting to as much as grade 4, in which parenchymal compromise starts. Another more objective criteria were also defined based upon the value of the anterior posterior diameter, and then converted to mild, moderate, and severe varieties as well. And then these values being different in the second and third trimesters. Ultrasound parameters have not been standardized again, as I said so far. So to compare the discrepancy between, or to propose a bridge to the discrepancy between the AP diameters and the SFU subjective grading systems, a urinary tract dilatation parameter was also proposed, because it was noted in a study by Professor Braga and by Professor Jung et al. That the overall rate of hydronephrosis resolution differed significantly when compared with regards to SFU grading vis-a-vis the AP diameter grading. There are additional indices to define pathology as well, such as the hydronephrosis index, which actually compares the surface area of the renal cortical region and divided by the whole renal area. And this correlates with SFU grades 3 and 4 hydronephrosis. They predicted that this was more sensitive in detecting a change in the degree of hydronephrosis rather than an absolute value. Also, because we know that especially in the third trimester, the hydronephrosis can vary with the distension of the fetal bladder. And to account for this, another hydronephrosis index, comparing the AP diameters and dividing it with urinary bladder volume, was established. And normative values from 20 to 38 weeks of gestation were established to compare with abnormal fetal values. So the etiology of hydronephrosis is manifold, the most common being transient hydronephrosis with an incidence of up to 70 to 80%, and in decreasing order followed by a UPJ obstruction, vesico-ureteric reflux, megaureters, multicystic kidneys, bladder outlet obstruction, and then duplex systems with associated uretrices or ectopic ureters. So now what next? So now that we know that an ultrasound is done, now that we know that we have an abnormal finding, and we have defined this as pathological, and we know that these are the potential provisional diagnoses that can be contributing to the same, we need to do prenatal counseling. So that means sitting with the parents, because they have too much anxiety once an ultrasound is done and they see not a smile on the face of the ultrasonographer. So we need to explain the problem to the family, the provisional diagnosis, what the prognosis will be, and if there was any role of fetal intervention. Antenatal and postnatal follow-up plans need to be told to them with the mode and place of delivery and the long-term outcomes, so that they can make an informed, thoughtful decision on what to go do next and where to go from there. And the basic underlying tenet of that counseling meeting is empathy. So we have to be very, very careful. And then going forward, once we know that there is an issue, and antenatal surveillance and follow-up becomes really important. And certain recommendations have again been laid down by the Society of Fetal Urology that says for the second trimester diagnosed cases, mild or moderate hydronephrosis kids can have another ultrasound in the third trimester to compare the trend. And severe ones need to have a repeat ultrasound in 4 weeks for follow-up. And in the third trimester, again, postnatal evaluation can be done for mild to moderate cases, with a more close ultrasound surveillance every 2 weekly for severe cases. With unclear anatomy, and MRI of the fetus can be helpful. For oligohydramnios or suspected bladder outlet obstruction, further investigations in terms of fetal urine sampling vesicocentesis needs to be done and fetal intervention considered, unless the family or clinical grounds advise for termination or for an early delivery. So why bother? So what is the point of knowing that yes, there is hydronephrosis, or yes, this can be the problem? The reason being, we can save a life and we can potentially give them a better quality of life. So saving a life will depend upon taking care of the oligohydramnios, because that is the most important cause of morbidity and mortality by causing lung hypoplasia. Complications such as UTI, stones, and renal failure could be potentially averted by early diagnosis and referral to a pediatric urologist. And then, as we know, obstructive uropathy is the second commonest cause of end-stage renal disease. And if there was a way to prevent this, or at least decrease its occurrence, this would be great success for the family and for the child. So when we talk about intervention, bladder outlet obstruction is the key. And this is the field in which extensive work has been done, and we have come a very long way in the last 4 decades in where we are now. So the most common causes, as we know, for bladder outlet obstruction is posterior urethral valve. We also sometimes encounter cases of urethral atresia and Eagle-Barrett syndrome. And in females, cloacal plate anomalies, including megacystis microcolon, can lead to bladder outlet obstruction. This can be picked up as early as on a 20-week scan with a 95% sensitivity and an 80% specificity. Fortenella et al. Proposed a clinical score for antenatal diagnosis of lower urinary tract obstruction, in which a point-based system was used, including parameters such as severe megacystis with a bladder volume more than 35 cubic centimeters, with dilated ureters, presence of oligohydramnios in a male fetus, and referral before the 28th week, increased the risk of LUTO by 96% with a score more than 9.5, with a sensitivity of 78%. So when to intervene? So the intervention needs to focus on 2 things: lung development and kidney development. So the lung development normally relies on amniotic fluid, causing a mechanical stenting force and a source of growth factors. And this is important, especially during the canalicular phase of lung development from the 17th to the 26th week of gestation. And hence, improvement of oligohydramnios before this can lead to a better prognosis in terms of mortality and morbidity. Therefore, intervention is recommended to be done before 26 weeks to prevent or improve the potential of lung preservation. For renal development, unfortunately, not much is known and whether these changes could be reversed or not, or could be stopped. There is only some animal model studies, especially this one from Samnake et al. In Perth, that looked at renal histology at different stages post artificially created urethral obstruction in the fetal lamb model, in which they noticed that by day 2, early cystic changes had already started, and by day 10, architectural disorganization had already set in. Whether this was reversible on undoing the obstruction is still not known. Similarly, what instigated us to start fetal intervention were these pioneer animal studies by Harrison et al. In the early 1980s, in which they first created a bladder outlet obstruction and said that yes, this causes hydronephrosis and pulmonary hypoplasia in the fetal lamb. And a subsequent study that said that by reversing this obstruction, most of the conditions can be reversed and at least pulmonary hypoplasia can be improved. And hence what started the era of fetal intervention for bladder outlet obstruction. Again, it has been seen time and again that it improves lung hypoplasia, but not many studies or almost no studies have shown any improvement in renal dysplasia. So the proposed criteria for intervention include ultrasonographic evidence of urinary tract obstruction, a singleton pregnancy, no other major congenital or chromosomal anomaly, presence of oligohydramnios, and a male karyotype. There are certain stages that have been proposed that help us decide whether to intervene or not. So basically, these are based upon the three most important parameters that are important for these kids with bladder outlet obstruction: the amniotic fluid volume, the status of the fetal kidneys and the echogenicity of the parenchyma, and fetal urine biochemistry. If these are all good, which is stage 1, then we don't need to intervene or unnecessarily poke the fetus. If these are really bad and the kidneys are already hyperechogenic with renal dysplasia and cortical cysts, then there is no point intervening, because whatever we do, we cannot improve the renal function and there will be no life or no quality of life for these kids. So stage 2, the middle road, is the one that we need to salvage, which already have started to have oligohydramnios and some hyperechogenicity of the kidneys, but they still don't have full-blown renal dysplasia, and they still have fetal urine biochemical markers that are favorable. And these biomarkers need to be checked at 3 different vesicosynthesis procedures to confirm that, yes, they are healthy and favorable and that the kidney is still working. And most important out of all of these are 2, urinary sodium being less than 100 and a beta-2 microglobulin being less than 4 as favorable markers. So what interventions can be done? So the first ever intervention was done at the University of California in 1955, where a fetal ureterostomy was done. And then followed by that, after a 30-year gap, open fetal surgery was done by Harrison and his team in 1982. Unfortunately, because of open fetal approach, there were lots of high chances of mortality of the fetus and maternal morbidity. And with the era of upcoming of the psychoamniotic shunt, the whole paradigm has shifted. And then more recently, with fetal cystoscopy, both diagnostic and therapeutic, it has even opened up a new gate with a better renal and bladder outcome for these kids. So for the psychoamniotic shunting, briefly going through the procedure for the interest of all attendees. So we, most of the time, because there is oligohydramnios, and artificial amniotic fluid or amniocentesis is done to create some extra space. And then with the cannula going through the maternal abdominal wall, maternal uterine wall, and then through the bladder of the fetus, the shunt is deployed with the inner end inside the bladder and the outer end in the amniotic fluid. There are complications reported many a times with these procedures, and as much as up to 40%. The most common being shunt complications, including shunt extrusion, retraction, or occlusion, and especially if the outer end falls into the abdominal wall, this can result in the fetal ascites. Other complications such as chorioamnionitis, abdominal wall hernias at the shunt entry site, rupture of the bladder, premature rupture of membranes in preterm labor, and sometimes fetal demise have also been reported. Fetal cystoscopy has also now brought a new paradigm in this field. First of all, the major advantage of fetal cystoscopy is the confirmation of diagnosis by actually visualizing the posterior urethral valve, because if there is urethral atresia that you can see, you just stop and not go further. The other advantage being, because now we have opened up the urethra, the bladder cycling continues, as opposed to a psychoamniotic shunt in which we have just diverted the bladder urine and the bladder always remains empty. Although no studies have been proposed so far showing the effects on bladder cycling, but we hope that that is the case. Outcomes following fetal cystoscopy have been reported by Sananas et al. In 50 children, in which a valve fulguration using an ND YAG laser was done using a fetal cystoscopy. And in terms of outcomes, it was really good in that only 20% of them had a recurrence of the bladder outlet obstruction, out of which half of them could be lasered a second time. The premature rupture of membranes was only to the tune of 22%, with a mean survival of 35%, out of which majority had normal renal function at 2 years. So coming to the outcomes of the psychoamniotic shunt, outcomes have been said in studies over the last 4 decades, as I said, starting with 1986, in which the survival was quoted as 41% by a series. And then as time has passed, the survival has become better, most likely because of more experience by the operating fetal urologists, with decrease in the chances of complications. With 10 years later, in 1997, an overall survival of 47% was said. But however, the percentage of end-stage renal disease still remains very high, up to the tune of 40%. This was the Pluto trial, just briefly tabulated in this table, in which a comparison was made, randomized controlled trial between percutaneous amniotic shunting versus conservative management for children with fetal lower urinary tract obstruction. The study was supposed to include more than 100 participants, but had to be stopped after 31 because of difficulty in recruitment. So 16 patients were included in the shunt group versus 16 conservatively managed. And the primary outcome, which was survival to 28 days and to 2 years, was significantly higher in the shunt group as compared to the conservative group. However, once again, the renal impairment was not different. Another outcome study in 2013, once again showed a chronic renal failure rate, which was very high. And a meta-analysis and systematic review in 2017 that also included the Pluto trial cases, again showed the presence of a higher survival rate in children who had the shunt placement, 57% versus 39% in the conservatively managed group. However, they said that it did not affect survival at 12 months or at 2 years of age. And then again, did not improve postnatal kidney function, with renal dysfunction reported in as much as half of the cases. And another meta-analysis in 2020 that included 100 more patients showed an overall higher survival in the shunt group. However, this particular one showed good postnatal renal function, higher in the shunt group. They also included studies with fetal cystoscopy now, with 45 cases included, and in which a perinatal survival was higher, with a good renal function noted in the fetal cystoscopically treated cases as compared to the conservative group. And they also mentioned that there appeared to be an improved bladder drainage in cases treated antenatally. However, there were no definite data to confirm that. As we said just then, so for bladder outcomes, there are no definite data stating the outcome of the bladder postnatally. However, one study by Abo et al. Compared the outcome of 38 prenatally diagnosed boys with a postnatally diagnosed with PUV, and they did not reveal any significant difference in the incidence of voiding dysfunction. And there are some ovine models that suggest that defunctionalized bladders do show fibrosis with distorted muscle layers, but again, no human bladder histology data are available. Neurodevelopmental outcomes have also been studied in 20 children in a study that said that that classified prenatally these cases into stages 1 to 3 and assessed them in 5 different developmental domains, and said that 75% of them had no neurodevelopmental delays. And out of the 5 who did, 4 received dialysis. And they said that there were no difference in the outcomes between infants with lower urinary tract obstruction in stage 1 versus those with stages 2 and 3. Recently, a European reference network for rare kidney diseases have established a work group in Europe with 8 pediatric nephrologists, 4 urologists, 2 fetal surgeons, 1 kidney biochemical researcher, a radiologist, and a nuclear medicine physicist that have given certain recommendations for the index topics. The first of them being a prenatal ultrasound parameter to define urinary tract obstruction. And they have recommended that the most reliable parameter being the anterior-posterior diameter of the pelvis, more than 7 in the second trimester being significant, and more than 10 in the third being significant. And again, they've said for suspicion of lower urinary tract obstruction, an enlarged bladder more than 7 millimeter in the first trimester, or an enlarged bladder failing to void within 40 minutes of ultrasonography in the second trimester has suspicion for lower urinary tract obstruction. And survival and kidney outcome can be predicted based upon the presence of oligohydramnion, which is a strong predictor of pulmonary hypoplasia. Briefly about the role of fetal MRI. So with the new sequences, including a single shot fast spin echo, fetal MRI has been useful, especially for complex anatomical definitions, and especially in children who have severe oligohydramnion, where there is not enough fluid window for ultrasonic fields to penetrate properly. A virtual cystoscopy can also be made because of three-dimensional reconstructive images in certain MRI sequences, and that will help us a long way in diagnosing what the cause for the lower urinary tract obstruction is and its subsequent management. It has also been used to diagnose complex anatomical issues such as bladder exstrophy. So what is the way forward? There are certain innovations that have been done by different pioneers worldwide, which still are in the experimental phase, but they look very encouraging for improving postnatal renal outcomes. So the first one of them was Buffin-Meyers et al. That conducted a study studying the fetal urinary peptide signature called 12PUV, and they confirmed the validity in 14 out of 25 fetuses, and they said that the peptide signature predicted the postnatal renal outcome with an accuracy of as high as 90% when the urinary metabolite levels were checked and a score-based prediction of postnatal renal outcome was done. Certain innovations in the type of stents have also been proposed, such as this one that was a Somatex intrauterine shunt that has been designed in Germany, in which they have a nitinol wire mesh with a silicone-free self-deploying parasols at the end that help this to remain more self-reliant. And the other advantage of this is that it can be introduced through just an 18-gauge cannula into the fetus, thereby decreasing the risks of complications. Another stent, which is a dumbbell-shaped stent, has been designed by Kurtz et al., in which there is a saddle-shaped thin flank in the middle, followed by self-expanding edges that make it reduce the risk of dislodgement and clogging. Another innovation that has been attempted in these children who have bladder outlet obstruction is for the very severe ones. So if you remember the stage 3 cases that have severe renal dysplasia, and you know that without renal transplant, there is no survival, we do not advocate doing psychoamniotic shunting or any other procedures for them. However, these clever group of people, what they have done is to think about the concept of induced immunotolerance to preemptively plan the renal transplant and the subsequent immunosuppression. So what they are trying to do is to develop, do hematopoietic stem cell transplant from a pre-planned donor, which is most likely the parent, and instill them into the fetus before their special fetal T cells are developed, so that they consider these stem cells as self, which will lead to tolerance of the donor antigen without need for immunosuppression and the subsequent complications. Other innovations such as diffusion-weighted imaging and blood oxygen level dependent MRIs are helpful, which can allow examination of neonatal renal function for better prognostic information and guiding neonatal intervention in the future. Having said all of that, what still needs to be really standardized is the ultrasound parameters, so that they are universal across the globe, to validate the exact indications for prenatal intervention, to identify children with a good long-term quality of life, and potential options such as genetic modifications to prevent or reverse pathology could be are underway and could lead to paradigm shifts in the future. Modifications in technical instruments such as in the shunts and the cystoscope can also help improve outcomes for these fetal interventions. And examples such as valve shunts allowing bladder cycling at the same time as improving the oligohydramnios are being tried. All of this leads to ethical dilemmas to us, and that basically raises several questions as fetal surgery develops, including deviation from our Hippocratic oath of patient's autonomy and duty of competence, because as we do more experimental surgery, we go away and away from what the standard procedures and standard care mean. So we have to weigh and explain to the family and explain to ourselves that there are two ways that we can adopt. We either want a life or we want a good quality of life. So what do we want? So right now, I think most of our experimental research is about learning how to save the life by improving oligohydramnios and improving fetal survival. But whether they're going to have a good quality of life in the future needs to be thought about a little more. So whether the fetal surgery is futile or is fruitful in the future, again, needs to be thought. This is a quote that I would like to read out. I have borrowed it from the Hall Schneider's preface. And it says that no matter how enthused we may be by the practice of surgery, and no matter how dedicated we might be in our endeavor to help our patients to the best of our ability, none of us can feel this to the same extent the depth of the burden suffered by some parents and some children struggling with the practicalities of daily living when results are suboptimal. And we should always remember that we are always and only the servants and never the masters of our patients. Thank you.
Thank you, Alisha. Wonderful talk as always. You have covered the subject from history to what is happening currently, especially the bright idea of immune induction, which probably excites us as to, yes, probably that's cutting edge and that people are using technology and information. Maybe we can expect a better lot later on. You know that there were two previous talks on the subject by stalwarts, Dr. Contiro and Dr. Coyle. And we had the chairpersons, Dr. Coyle was there, Louis Braga was there. We had Dr. Harper also. So let's begin with Dr. Harper, and then we go in the reverse direction. And Dr. Harper, what are your views on fetal surgery?
Thank you. First, Dr. Gupta, that was a fantastic talk. I enjoyed it very much.
Thank you.
I think the last slide was, for me, the most important slide, because all we are doing is creating a lot of work for pediatric urologists, that's for sure. But for the moment, it's not clear that we are improving the quality of life, not only of the children, but also the experience of the parents, because it's a family experience. And we certainly need to develop more tools to understand what it means for the parents to go through the whole process of the prenatal intervention and the postnatal management. And we need more information on that. And also, I thought what was very interesting in your talk is that there's the difficulty also is when you were showing, for instance, the statistics of, for instance, antenatal hydronephrosis and the importance of the possibility that there's something which will need surgical intervention. For a parent, when I see them and for their child, I always say that their child is going to be 100% in one direction or the other. You can have a very large antenatal hydronephrosis and have spontaneous resolution. And it's also important to know what the numbers are actually telling us. They are saying what for a population might be true, but it never actually says the story of an individual child. So I think it's important to identify whether we are doing fetal intervention in an experimental situation where we want to improve our knowledge, and it has to be very clearly explained that this is something which is going to give us data so that we can make more clear decisions later, but we have to also explain to the parents what the limitations are of all these interventions. But I thought your presentation was very balanced in that way and very interesting. Where I work, we do very little fetal intervention because for the moment we are unsure that we're actually going to improve the postnatal outcome for the whole family and for the child. Thank you.
Thank you.
Yeah, I guess it's me, like going backwards or reverse order.
Yes, Dr. Braga, please.
Yes, so thank you again. I really enjoy your presentation. And Dr. Gupta was, like Dr. Harper said, well balanced. I think you covered the whole topic. So in terms of what I don't do anything because I'm a pediatric urologist, but in terms of the obstetricians in our center, the majority of them, they are not doing, even though we have a high risk fetal medicine center in Hamilton, which is very close to Toronto, the largest center there at Mount Sinai in the Hospital for Sick Children. I think because what has been mentioned, or at least what we thought we knew about prenatal intervention, this was not benefiting the patients, and even in terms of sometimes it is interesting because when you talk about quality of life, if you can extend the life of a child with a dialysis, peritoneal dialysis in a newborn or in the young infant is challenging. Sometimes the hemodialysis until they are older to be able to get a transplant. Dr. Coyle, as a transplanter, knows that well. It's challenging to get it done, or the results are not very good under 10 kilograms. So it is feasible. We're not talking about feasibility, but I think we need to take into account what is the burden for the family, especially and the suffering, or sometimes all the procedures that these babies or children have to endure. So bottom line, that's what we have been doing traditionally. By today's lecture, and because I was very heavily involved on the review of the paper by Dr. Thomas Coyle, there is light at the end of the tunnel. It seems that from his data, obviously, there are limitations with the paper and the selection of the patients that we said it's the most important thing. But if you're going to be able to successfully shunt those babies or those fetus before 16 weeks, it seems that he was able to achieve not only a lower complication rate from the procedure itself for the mothers and the children, but also a better outcome in terms of lung maturation and hyperplasia, etc., and also what we has never been able to achieve so far, which is the renal outcome that it seems to be improved. But again, the follow-up was short, and I think time will tell us. So I would stop there.
Thank you, Dr. Braga. So, Professor Coyle. Martin.
I'm going to echo mostly what Luke said about your last two slides, Alicia. I thought that sort of summarized everything. And what worries me most about intervention is when intervention is done by cowboys occasionally. And when I use that, I mean, it's somebody who can do a procedure, but doesn't necessarily take care of the long-term consequences or really know what the true pathophysiology is. So we've watched in our lifetimes interventional radiologists grow from people who just put needles into things into a real specialty. And you don't get better unless you pioneer, you ask questions, and you take risks. And that's the reality. But I think this is a real different ballgame because of the quality of life issue. And we don't look at things. I'd love to see some studies on decisional regret of the mothers who have lost their kids or the parents, their outcomes, because we know kids, at least in North America and probably in other Western countries, that the divorce rate ultimately for kids with severe congenital disease or kids who die is very, very, very high. So I'd love to look at the studies long term as to what happens, not just with the kids, but what happens with the parents. And I think you hit the nail on the head. All the two speakers this morning, and Luke and Luis, have hit the nail on the head. We haven't progressed all that far. We haven't really changed things dramatically, but there's some provocative new work, as Professor Coyle showed us. And again, the selection criteria, I think obviously you must have had a real hard time accepting that paper. I can understand the trials and tribulations of trying to review a paper like that.
Yeah, thank you, Dr. Coyle. Again, Alicia, I think very well presented and very balanced presentation. And as everybody feels, there's a lot of ethical issues in that. And with all these questions coming up about abortion and the right to life, I mean, there are societies where anyway the life has to be preserved in any way. It doesn't matter the quality of life, but the life has to be preserved. But then also there's a question of support systems. So there are societies like in the US, there is a lot of support. But in a country like India, where the parents are alone, there's no support, no financial support. I think it is a very difficult question. And when we put this question to the parents, I mean, invariably in our setup, their answer is that they would go for another baby, than to try to, drag on with something which is not sure. So the ethical issues now even more, which is being thrown up by the issue of abortion being allowed or not allowed, is going to play a major role in this decision making. And if abortions are not going to be allowed in a lot of societies, then in that situation, I think more and more interventions will be done. And if we are of the belief that the life has to be preserved anyhow, I mean, it is for us to decide. And I think there's a lot of questions and a lot of new research is coming, and I hope it will definitely improve the quality of life, not only of the child, of the parents, as Dr. Coyle mentioned, but also of the other siblings. Imagine the life of the other siblings where the parents are going in and out of hospital for one child. That's it, Dr. Bajpai.
Thank you very much, all of you. And you have been a long day for Martin and others who have been around since morning. And thank you, Alicia, for joining us, Sumit, and all the speakers, all people who assisted us here. So we are taking a break here. Is there anything, an announcement to make, please? Thank you.
Thank you, ma'am, for the elucidative presentation. And I would also like to thank all the moderators, Professor Bajpai, Professor Sandeep Agarwala, Professor Martin Coyle, Professor Louis Braga, and Professor Luke Harper. Thank you, one and all. We are now halting for a short break, and we would be resuming again at 4 p.m. Indian Standard Time. In the break, there will be streaming of series of announcements by the societies. Thank you.
Thank you, everyone.
Thank you.
I quit my 9 to 5 and I started selling Chinese pickles online. I thought I would have to learn tech.
Hey, I have a question for you. If I were to present you my data in the form of this boring Excel spreadsheets and in the form of this highly interactive, visually appealing dashboards, which one would you prefer?
Good evening, Professor Piccoli. This is Sachitanand from AIMS New Delhi.
Great. I hear you well because I had to change the PC. Do you hear me well?
Yes, yes, we can hear you well. We'll be
great.
starting the session in a few minutes.
Very well. Here I am.
Thank you. Good morning, Professor Bagli. It must be 5:30 in Toronto, I guess.
It is. Good morning. You can hear me okay?
Yeah, we can hear you.
Very good. Thank
Can we start the session? Professor Bajpai will be joining in a few minutes, so we can start the session.
Very good. Thank you.
Thank you.
Welcome back, everyone. Let us now move on to the much awaited Basic Research and Young Investigator Award. For chairing the session, I would like to call upon Professor Darius Bagli, Professor Georgina Piccoli, and Professor Meenu Bajpai. Professor Bagli is currently working as Professor, Department of Surgery at the University of Toronto, Canada. He is a founding member of European Society of Pediatric Urology Research Council and has a keen interest in research. He directs a laboratory in the cell and molecular biology and epigenetics in the Hospital Research Institute with prime focus on benign neurological diseases and maldevelopment. Dr. Bagli is also conducting studies on artificial intelligence and deep learning in children's urology. His research academia boasts over 350 publications with about 7,700 citations. Professor Georgina Piccoli is a professor in the Department of Nephrology, Centre Hospitalier, France. She also works in the Department of Clinical and Biological Sciences, University of Torino, Italy. She is actively involved in research with over 400 publications, and her main interests include hemodialysis, chronic kidney diseases, pre-dialysis care, nutrition and CKD, ethical issues in chronic kidney diseases, and green dialysis and sustainable nephrology. Before starting with the presentations, I would like to remind the presenters that the time allotted for each presentation is 10 minutes, followed by a 5-minute discussion. The first presentation for the session is by Dr. Mehak Sehgal, titled Long-Term Effects on Therapy of Renal Functions in Survivors of Pediatric Solid Tumors. Over to you, Dr. Mehak.
Yeah. ठीक है
Am I audible and is my screen visible?
Can hear you, but it's not full screen at my end.
It's not full screen. Is it visible now, sir?
Yes, yes. Thank you.
Very good afternoon from the All India Institute of Medical Sciences, New Delhi. I would be sharing our research on the long-term effects of therapy on the renal function in survivors of pediatric solid tumors. I have no disclosures. Childhood solid tumors account for less than 5% of all cancers in India. And with the improvement in therapy, there has been an increase in survivorship. This is due to the multimodality therapy that has come into. Some of the long-term effects of these therapies may be fixed and non-progressive, which may lead to a long-term morbidity in the survivors of these solid tumors. It was noted in an article in the New England Journal of Medicine in 2006 that at least 45 to 63% of all adult survivors had at least one chronic health-related condition. However, there are a very limited number of studies, and this aspect needs to be looked into to improve the quality of life. The aim of our study was to evaluate the long-term renal effects of therapy in the survivors of hepatoblastoma, malignant germ cell tumors, and Wilms tumor. It's a descriptive cohort study in the Department of Pediatric Surgery, All India Institute of Medical Sciences, New Delhi, where we reviewed the medical records of children registered at the Pediatric Solid Tumor Clinic between January 1994 to June 2016. A patient was deemed as a survivor if he was found to be alive 5 years after diagnosis, and these patients were included in the study. The nephrotoxic effects of cisplatin and renal function post-nephrectomy for Wilms tumor were evaluated by estimating the glomerular filtration rate. Patients with standard risk hepatoblastoma as well as high risk received cisplatin as a part of their treatment protocol. Patients with Wilms tumor had surgery done in all patients, along with receiving chemotherapy and radiation depending on the stage. Patients with malignant germ cell tumor also received cisplatin as a part of the PEB chemo protocol. The glomerular filtration rate was estimated using the technetium-99 diethylene triamine pentaacetate using a double compartment 2-plasma sampling method. The kit was prepared in-house and procured from the Board of Radiation and Isotope Technology in Mumbai, India. The height and weight of the patient were recorded, and the dose was calculated using the basis the body surface area. The isotope was injected intravenously, and the venous samples were collected at 60 and 180 minutes. The plasma was separated from the whole blood sample, and 1 ml plasma from each sample and an equal volume of standard were counted in an automatic gamma counter. The Russell two sample slope intercept method was then used to estimate the GFR. We had a total of 317 survivors that were included in the study. The median age at diagnosis of these survivors was 24.5 months. And we had a range of minimum 5 years to a maximum 19.5 years of follow-up. Majority of our patients belonged to the Wilms tumor group. We evaluated 79 patients who received cisplatin as a part of their chemotherapy protocols with available GFR report, and a cutoff of 90 ml per minute per 1.73 meter square was considered as low GFR. We found 41.7% of patients to have a low GFR. There was no statistically significant difference between the dose of cisplatin and the reduction in the GFR. On a subgroup analysis, however, we found that the diagnosis of malignant germ cell tumor had a statistically lower GFR when compared to those with hepatoblastoma. We evaluated the effect of age at diagnosis with the follow-up GFR, but we found that there was no effect of the age at diagnosis on the GFR attained. Evaluating the effect of surgery, the mean and median GFR of the 48 survivors of Wilms tumor post-nephrectomy are as given in the table below. We can see that the mean GFR progressively was reduced as the stage progressed. On applying the Bonferroni test, the mean GFR was statistically significantly different for stage 1, 2, and 3 when compared with stage 5. Although the GFR in stage 4 survivors was higher than stage 5, but this did not reach any statistical significance. We also looked at the effect of radiotherapy on the glomerular filtration rate, and we compared patient receiving whole abdomen RT with those who received only flank radiotherapy. There was no statistically significant difference in the GFR. However, this could be attributed to a small sample size. The nephrotoxicity in the long-term survivors can be due to the effects of cisplatin and the other nephrotoxic drugs, or it can be post-nephrectomy. Among these patients who received cisplatin, 42% had a GFR less than 90 at follow-up, and 2.5% had a GFR less than 60, which is in concordance with the literature reports as well. There was no relation of a low GFR with the increasing dose of cisplatin. However, we did find that the children with a diagnosis of malignant germ cell tumor had a lower mean GFR compared to those with his hepatoblastoma. It could probably mean that these patients of malignant germ cell tumor had a higher mean dose of cisplatin due to their older age at diagnosis. In the Wilms tumor subgroup, 62% had a low GFR and 8.3% had a GFR less than 60. The mean GFR was expectedly lowest for those with stage 5 Wilms tumor and was significantly lower than those with stage 1 to 3. We did not find any difference in the GFR between children receiving abdominal RT versus flank radiotherapy, possibly due to the small sample size. Thus, the overall prevalence of CKD in the entire cohort was 4.7%. 6 children who were detected to have chronic kidney disease stage 3 to 5 belong to the subgroup of malignant germ cell tumors and Wilms tumor, and none of the patients had a diagnosis of hepatoblastoma. Thus, there is a potential of the GFR to fall during puberty as these children grow up. So this highlights the importance of having a baseline estimation and serial follow-up. The radionucleotide method is more reliable than the estimated method. And thus, this close and reliable method allows for a more close, effective follow-up in the apparently at-risk group. The limitation of our study was there was a lack of data on the renal function test, the serial electrolytes, blood pressure, and urine analysis, which may be key to picking up nephrotoxicity. The sample size was small. It is a single time point analysis, and there was variability in the follow-up. In conclusion, with improvement in outcomes of childhood cancer, there is an increasing number of cancer survivors. Survivorship needs to be carefully monitored to evaluate the long-term effects of treatment as they have received this treatment in their early growing years. We noted a CKD grade of 2 and more in 41.7% of our cohort. This study highlights the need to be in continued follow-up with focused serial assessment of the expected side effects of therapy, as the end of cancer treatment is not the end. Thank you.
Thank you, Dr. Mehak. You finished just in time. So can we have comments or questions from Professor Bagli first?
Thank you very much. It was a very interesting study. When I was looking at the abstract, I was wondering what was the chemotherapy regimen for the Wilms tumor patients? Because the only thing that I believe he discussed, unless I missed it, was cisplatin. Could you comment on what therapy the Wilms tumor patients received?
Yes, sir. Thank you for your question, sir. The Wilms tumor patients in our cohort received DD4A and EE4A regime. This did not include cisplatin, and none of the drugs in this protocol are nephrotoxic. Cisplatin is known to be nephrotoxic, and that was a part of the chemotherapy regime in the cohort in the subgroup of hepatoblastoma as well as the malignant germ cell tumors. So,
okay.
Per se, it was more of the chemotherapy long-term effect of the chemotherapy and in patients with hepatoblastoma and malignant germ cell tumor, and the effect of surgery in patients with Wilms tumor.
Okay, because that wasn't clear from the way it was presented, because I was then going to ask you, how did you account for the fact that in Wilms tumor you're removing nephrons surgically, And then you're asking about the effects of chemotherapy on the remaining nephrons. So how do you actually figure that out in the analysis? I didn't understand that. Could you elaborate a little on? Is it possible to elaborate a little on that? Because there are two things happening in the Wilms group. There's chemotherapy effects, and you're removing nephrons, which is going to affect your final GFR as well. So how do you correct for that?
So in the Wilms tumor subgroup, there is not much effect of vincristine and doxorubicin, although there are few case reports, very scant, that suggest that anthracyclines could have a very long-term effect on the renal function, but it's nothing absolute. It is more to do with the fact that these children have had nephroureterectomy done, and that even in the previous studies has served as an independent risk factor for a long-term CKD.
Okay, thank you.
Can we have Professor Piccoli's comments or questions?
So thank you for this nice study that actually underlines the need for follow-up of these patients, and not just to think that they are saved and this is it. So I just want to ask you a very practical question. What would you suggest to be the ideal follow-up of these young patients? Just seeing them once a year, more often, according to the kidney function. And I probably missed the role of proteinuria. So if you could comment also on the level of proteinuria in these patients. Thank you.
Thank you, ma'am, for your question. So in our department, we traditionally follow up these, although the follow-up protocol varies depending on the tumor type, but we follow up these patients once every 3 months for the first year, then once every 6 months for the next 2 years, and then subsequently yearly till 5 years, and then the follow-up becomes less frequent. We have traditionally been following up these patients by just the normal evaluation of ultrasound, X-rays, and CTs for the primary disease. We had also started getting a GFR done. However, even in the COG protocol, there is no the role of GFR is not very clear. GFR has not been included in the COG protocol, and we have got it done just once during the follow-up, and that too at a little variable period, not constant for all patients. Most of them were done after 5 years of diagnosis. Although COG recommends that all these patients should be screened for the nephrotoxicity yearly, with the help of electrolytes, urea creatinine, blood pressure, and urine analysis for proteinuria. Cisplatin is known to be, it has a tubular interstitial damage, and then that progresses to glomerular damage as well. So these patients may have microalbuminuria followed by frank proteinuria subsequently. Hence, the role of proteinuria is definitely there. But we could not evaluate that in our study. Also, regarding whether it should be a single time point or a multiple time point analysis, what we have read in literature is that some of the studies have said that the effect is reversible. There are very limited studies to that, but there are some studies that say that the effect is progressive and it is permanent. So other thing is that as these children grow older during puberty, there can be a subsequent fall in GFR due to the increase in size and the growth of the child. So we recommend that the glomerular filtration rate should be measured more frequently, and especially during the time the child attains puberty, so as to pick up the nephrotoxic effect and adequately guide the child regarding therapy and change in management.
Okay, if I can comment, maybe it's not just to to discover the nephrotoxic effect, because the nephrotoxic effect was the start of the story, is probably to try to follow up if there is a progression of kidney disease that is expected to happen once a critical nephron mass has been destroyed.
Yes.
So it's not just the nephrotoxicity, is also the fact that chronic kidney disease progresses without the initial noxa once an important, probably something more than half of a nephron patrimoine is lost.
Yes, ma'am.
Thank you.
Thank you, ma'am.
Thank you. Can we have a comment from Dr. Devendra Yadav, who has a decade of experience in the management of solid tumors and is representing Professor Bajpai, because he'll be coming in just few minutes.
Mehak, wonderful presentation. Did you notice any difference between GFR calculation from DTPA method and E method?
Sir, thank you for your comment, sir. In this study, we looked at the GFR estimated only from the DTPA method. We did not estimate the GFR using the eGFR method, which is done using the serum creatinine level, primarily because the eGFR method is less reliable. It has a tendency to under or overestimate the GFR by almost 30%. And the DTPA method is a more reliable method of estimation, and hence that is what we used for our study. Although most of the studies that we have reviewed in the literature have used the eGFR method, ours is one of the few studies that have used the DTPA method for an accurate estimation of GFR.
Thank you, Mehak. Chairpersons, can we move on to the next presentation?
Thank you, sir.
Thank you, Dr. Mehak. Next presentation is on early evidence on genetic polymorphisms and their influence on renal injury in Asian Indian children by Dr. Suramya Anand.
Good evening. Is my screen visible?
Yes, you are visible, Suramya.
Okay.
You're audible as well.
Yeah. Good evening, respected chairpersons, teachers, seniors, and colleagues. My study is on early evidence on genetic polymorphisms and their influence on renal injury in Asian Indian children. So, as we all know, the congenital anomalies for kidney and urinary tract are a major burden in terms of both morbidity as well as end-stage renal disease in the children. And therefore, the purpose of our study was to identify the effect of polymorphisms in 4 genes: paired homeobox X2 gene, bone morphogenetic protein 4 or BMP4, angiotensin converting enzyme ACE gene, and angiotensinogen 2 receptor type 2 nephrogenic genes in the phenotypic expression of the 3 major categories of CACUT: posterior urethral valve, uretropelvic junction obstruction, and vesico-ureteric reflux in Asian Indian children. So this was a prospective cohort study where we compared 86 cases with 72 controls. The 86 cases were children who presented to us in the pediatric urology clinic with congenital uropathy and were less than 12 years old. Those who refused consent or syndromic children with other malformations were excluded from the study. These 86 cases were compared to 72 age and sex matched controls. The medical records of these 86 children with congenital uropathies were reviewed after receiving the approval from the Institute Ethics Committee. Their history and investigations were recorded. Peripheral blood samples of both the cases and controls were taken, and DNA was extracted from these using the Kaizen DNA extraction kit. And this DNA was then subjected to polymerase chain reaction in thermal cyclers and using the previously published primers and PCR conditions. And the results were analyzed under 2% agarose gel under ultraviolet illumination. So the 4 genes that were studied were BMP4, PAX2, AT2R, and ACE. The BMP4, the SNP code that was studied is mentioned here, and the BMP4 gene is located on chromosome 14q22. It is mainly involved in bone and cartilage development and establishing the dorsoventral axis in the embryo, but it has also been associated with kidney malformations like hypoplastic and dysplastic kidneys and formation of duplex kidneys. The paired box gene 2 is located on chromosome 10q24, and it is mainly responsible for development and organization of the central nervous system, although it has been also implicated in renal coloboma syndrome with ocular development and renal anomalies. The AT2R gene located on X chromosome in various studies has been implicated in formation of megaureter and uretropelvic junction obstructions. The ACE angiotensin converting enzyme I and D polymorphism most recently has been shown to increase the susceptibility of thromboembolism in COVID-19 patients, but it has also historically been associated with renal tubular dysgenesis. So we analyzed these 4 genes and the specific nucleotide polymorphisms, as has been mentioned previously, in 86 cases. The demographic data is represented in this graph and the pie chart. So out of these 86 cases, we found that the majority of congenital malformations were posterior urethral valves in 35%, and all of these were obviously males. The rest important numbers were in UPJO, 31%, and vesico-ureteric reflux, 28%. These also had males as the majority. Extrophy bladder, 3 patients with extrophy bladder and 2 with MCDK were also part of our study. So on overall analysis of the overall Kakut abnormality, there was an equitable distribution of these polymorphisms in all the 4 genes when the cases were compared with controls. So overall, in the overall Kakut population, we could not find any significant difference in the genetic distribution in cases and controls. But then when we did a group analysis of the AT2R gene and the development of specifically uretropelvic junction obstruction and vesico-ureteric reflux, we found that the presence of the A allele, either as a homozygous AA or heterozygous AT, was more prevalent in the cases, whereas the TT homozygous patients were found to have a protective mechanism and preventing them from developing both UPJO and VUR. So this same thing is depicted in the graph over here, where the red shading represents the cases and the orange shading represents the controls. So as we can see over here, both the presence of the A allele either as AA or AT is present more in the cases, whereas those patients who have TT are overrepresented in the control group. Thus, the presence of the A allele of the AT2R is contributing to more incidence of cases of the uretropelvic junction obstruction and vesico-ureteric reflux. Further on, we did a DMSA scan in these 86 cases to detect scarring. When we compared the presence of these genetic polymorphisms with scarring, in cases of BMP4, AT2R, or PAX2, no significant difference was found. But the presence of the D polymorphism, that is the DD allele or the ID allele of the ACE gene, was seen to be associated with a significantly increased incidence of renal parenchymal damage as assessed by renal scarring in these children. A further subgroup analysis was done. Here, the patients were substratified to those patients who had already the presence of the A allele of the AT2R. That is, these patients were already more likely to develop either uretropelvic junction obstruction or VUR, as we have seen previously. So this is the chart representing all those patients who already had the presence of the A allele. Then we analyzed whether these patients also had a D allele present. And we found that those who had a D allele also present were more likely to develop scars as well, 90% as compared to 11%. So this was a significant finding in our study. So as has been shown by Wolf et al. Previously, there are multiple complex mechanisms. So development of a CACUT is a complex process involving not just mutations, which can again be inherited, or monogenic mutations or polygenic mutations, but also a lot of other factors like maternal diet, excess or deficient vitamins and proteins, chemical and pharmaceutical teratogens. But as far as the genes are concerned, our study correlates with that of Rigoli et al., who studied a total of 102 Italian children, in whom they also found that the 82R gene polymorphism was more in CACUT cases. Although this is slightly different from Hohenfeller et al., who showed that the 82R receptor gene was found to be associated with primary obstructive megaureter and PUJO, but they could not find any significant correlation with VUR, which we found in our study. Our study is contrary to that of Hiraoka et al., who reported that there is no evidence for this 82R gene derangement in human urinary tract anomalies in Japanese patients. So this might be because of racial and ethnic differences. This similar finding is also emphasized in the Brazilian population, wherein they found that BMP4 gene was associated with development of UPJO, and PAX2 polymorphisms were associated with development of vesico-ureteral reflux in their cohort, whereas we did not find any such similarities. Thus, to conclude, in our study, male children had a significantly higher incidence of CACUT as compared to females. Although the diseased alleles of BMP4, PAX2, and ACE were overrepresented in the CACUT population, we could find an association only with the A allele of the 82R gene with the development of UPJO and VUR. Also, we found that those who already had a presence of an A allele, that is, they were more likely to develop CACUT. If they had the D allele as well, they were more likely to develop renal scarring in these patients also. So this information could help us in risk stratification and genetic counseling. And although these are preliminary data, they pave the way for further studies on this correlation. Thank you.
Thank you, Suramya. You have finished in time. Can we have the comments from Professor Piccoli?
So thank you for this very nice study. And I think you will probably need to gather especially some more controls because as you showed very elegantly, there is a very important racial, genetic, and context association. So I just wanted to ask you, how were the controls selected? Were they unaffected children in the same families, or how did you select them?
Yes, ma'am. The controls were the patient, the patients who came to our hospital with other problems which were not related to the urinary tract. So there were quite a few patients who came with foreign body aspiration and or a coin ingestion who did not have any urinary tract anomalies. We did a renal function study for them. The creatinine was normal, so they did not have any other urinary tract anomalies, and those were the patients that we selected as controls.
Did you also consider the possibility of studying the unaffected siblings of the affected children?
Yes, ma'am, we considered the possibility because that would help us a lot in the study, as well as the study of the parents and whether they are having any anomalies as well. But unfortunately for this particular study, we had a limited amount of resources and time to continue with that.
How are you going to continue the study?
Ma'am, we could continue increasing the numbers and taking up more of the polymorphisms in the same genes, or there are other genes also which have been implicated, which we can include in our study and make a more elaborate undertaking.
Thank you.
Thank you, ma'am.
Thank you, Suramya. Can we have the comments from Professor Bagli?
Thank you. Very interesting study. Full disclosure, I'm not a geneticist, but I did find this very interesting. One of the things I wanted to sort of focus in on was your discussion about the renal scarring. You did this with, it sounded like DMSA renal scanning, I believe.
Yes.
But one of the things we talk about when we mention scarring on these studies is trying to differentiate between whether the photopenic areas on these scans are due to true dysmorphism and developmental problems with formation of the kidney tissue versus infection. So could you comment, and it sounded like you also pooled your UPJ and your reflux patients in that little sub discussion. So could you comment on whether you had any knowledge about how much of this scarring might be due to infection versus true developmental abnormality?
Good evening, sir. Very thank you for your question. And yes, that is definitely true that infections were a major part of the scarring in cases of vesico-ureteric reflux, because these patients, many of them were presenting to us already after they had 1 or 2 episodes of infection. So that was the presentation when we discovered that they had VUR, and then we followed them up and did the DMSA scanning. But in cases of the UPJO, most of the cases of the UPJ, except for 1 or 2 cases, did not have any previous incidents of infection. And we did it immediately after the, about 6 to 8 weeks after the pyeloplasty, we did the DMSA scan, after which they also did not have any infection at that time as well. So the UPJ cohort did not have any infections, whereas the VUR, many of them did have. So that particular, the DMSA scarring could be contributed by the infection as well.
Right. So you have to, I think it's important to sort of point that out as you put this together in your analysis. And similarly, even in the UPJ patients, if they've had any functional hit, if you want to call it that, from their physical ureteropelvic junction obstruction, that could be contributing to this sort of photopenia in some of these studies. That is that truly related then to the genetic effects you're looking at versus the physical effect of the UPJ? That's another thing I think you need to tease out. So how would you, I would ask this question of all of the genetic studies, how are you planning on using this information at this point? Granted, you need more controls, larger numbers, et cetera. Was there statistical difference here? Actually, was another question. But are you using this information in counseling, or is this opening the door to further gene pathways related here that you could focus in on? Can you elaborate on that a bit?
So at present, the numbers are too low that we could go for genetic counseling, but we are planning that once we have adequate data, especially the data on scarring, as you are saying, where if we are finding that those patients who are already affected by these congenital anomalies, we can follow them up and find out those who are at more likely risk of scarring and give them a more proactive treatment. That would be the best. But we are definitely needing to have more numbers before we can progress to maybe genetic counseling of all the patients who come to us initially. So,
thank you.
Thank you.
Can we have the comments from Dr. Devendra Yadav?
Dr. Suramya, wonderful presentation.
Thank you.
To assess the exact penetrance of these genes, are you planning to collect the sample from the siblings and the parents also?
Yes, definitely, sir, because it is very important to take the genetic sampling from the siblings as well, because they might have represent similar findings. And if they do not have these congenital anomalies, then we can make a more elaborate study of why these particular individuals are being affected by this disease. So definitely bigger numbers and more studies are needed. And especially there are more genes which have been found to be resulting in CACOT, not just these 4, but there are about 12 to 13 genes which in various studies have been found to be implicated in CACOT as well. So involving those other genes and more polymorphisms in these particular genes would be definitely useful to make a more bigger study as compared to what it is right now. Thank you, sir, for your question.
Thank you, Suramya. We'll now move on to the next presentation.
Thank you, Dr. Suramya. Next presenter is Dr. Ankur, and he will be presenting on role of renin-angiotensin system pathway gene polymorphisms in congenital uropathies in children. Over to you, sir.
Is my screen visible?
Yes.
Very good evening to all of you. Respected chairpersons, I'm going to present my study on role of renin-angiotensin gene polymorphisms in congenital uropathies. I have nothing to declare, but I must mention that this study was inspired by work of my senior who just presented her work. Congenital anomalies of kidney and urinary tract include a wide spectrum of anomalies ranging from renal agenesis, hypoplasia to pelvic ureteric junction obstruction, vesico-ureteric reflux. So many disorders have been clubbed together because they are all linked in their pathogenesis. CACUT are the most common cause of end-stage renal disease. Around 1/3 of the children with CACUT end up with end-stage renal disease at some point in life, which brings a lot of long-term morbidity. Damage in children with CACUT, damage to the kidneys start intrauterine and in a significant proportion of patients progresses postnatally despite being given the best treatment. So, early detection of renal damage and risk stratification can help in this high-risk subgroup. Around 2,900 genes are involved in nephrogenesis, but mutations in less than 10 have been detected till now. We all know renin-angiotensin system is closely linked with renal autoregulation. RAS gene's expression has been found in renal tissue of mice embryos too. Thus, they are likely to be involved in congenital uropathies also. So we planned a study to find out about the role of RAS genes polymorphisms in CACUT in children, especially in those who deteriorated despite treatment. We believe that like many other illnesses, genetic biomarkers may help in identifying high-risk groups and in implementing early surgical intervention in them. Risk stratification become more important in resource-limited health facilities. We selected 4 important genes of RAS pathway, that is angiotensin II receptor gene, angiotensinogen, angiotensin I receptor gene, and angiotensin converting enzyme. I must mention here that for AT2R gene, a different single nucleotide polymorphism site was analyzed. It was different from the previous presentation, and a same mutation in ACE gene was analyzed in this study. We first assessed the prevalence of gene polymorphisms in children with CACUT as compared to children without CACUT, and then as a secondary objective, we analyzed the gene polymorphism frequency with renal outcomes. This is our Center for CACUT Research, which was established a decade back, and a lot of research projects on CACUT have happened here. My study happened over a period of 3 years. It was a cross-sectional study. 400 children were included in study. 250 were with CACUT and 150 without CACUT. Those with CACUT were further analyzed for secondary objective. Children less than 14 years were included. And for AT2R gene polymorphism, only male patients were analyzed because it is present on X chromosome. Three common congenital uropathies, pelvic ureteric junction obstruction, vesico-ureteric reflux, and posterior urethral valves were selected for study. Clinical and imaging details from patients were taken from the pediatric urology clinic records. Glomerular filtration rate was measured by plasma sample method. Scars in kidney were seen on DMSC scan. Split renal function was assessed in LLEC, renal dynamic scan, and follow-up investigations were done at an interval of 1 year. Following outcome variables were chosen for analysis: gene polymorphism frequencies, baseline GFR at presentation, baseline scars, proportion of patients with GFR less than 60, and our special group of patients, that is progressive deteriorators, was defined as those children who witnessed a decrease in GFR of more than 10, increase in number of renal scars, and decrease in split renal function by 10%. Statistical analysis was done on STATA software. This was the study protocol. 2 ml peripheral samples were taken from children. DNA was isolated, and then primers for specific genes were designed. Predefined segments of DNA were amplified by PCR as shown in the figure, and mutations were checked by ready-made primers. PCR products were run by gel electrophoresis. Bands were seen under ultraviolet light and base pair lengths were noted. Results were analyzed with respect to clinical and imaging findings of children. Coming to the results, age and sex distribution were found to be matching in children with and without CACUT. In children with CACUT, sex did not have any influence on outcome variables like GFR and renal scars. And in CACUT children, gene polymorphism frequencies were also found to be similar in both the sexes. Almost half of the children with CACUT had pelvic ureteric junction obstruction, and 1/3 of them had posterior urethral walls. Then we compared the gene frequencies in CACUT and non-CACUT population and found significant difference was seen in frequency of 81R and 82R gene. On further comparing the genotypes, we found that AC alleles of 81R and G allele of 82R gene were found to be more prevalent in CACUT patients. Now, we compared the gene polymorphism frequencies in each disease subgroup as compared to the non-CACUT patients and found some new findings. In the children with pelvic ureteric junction obstruction, 82R gene and angiotensinogen gene polymorphism were found to be significantly different. Genotype distribution was almost similar to CACUT and non-CACUT comparison. In posterior urethral wall patients, ACE gene polymorphism was found to be significantly different, and in this genotype, DD allele dominated the genotype distribution in posterior urethral wall patients. On the contrary, in vesico-ureteric reflux patients, no gene polymorphism differences were found to be significantly different. After comparing the gene polymorphism frequency distribution, we analyzed the outcomes at follow-up in CACUT patients. Children with posterior urethral walls had least average GFR. Baseline scars were present in 1/3 of the children with PUV and vesico-ureteric reflux. Almost 1/4 of the CACUT children had deterioration in renal parameters, with maximum deterioration seen in posterior urethral wall patients. This group of progressive deteriorators was further analyzed. Gene polymorphism frequency showed that all 4 genes had significant differences in frequencies as compared to non-CACUT children. Genotype comparison showed some same pathogenic alleles which were more common in CACUT patients overall. Then we analyzed the cumulative effect of these alleles, and it showed that combination of alleles, especially with ACE-DD allele, was causing the maximum decrease in GFR. Multivariate analysis showed that ACE-DD allele and 82R genotypes increased the odds of progressive deterioration by 14 and 7 times respectively. In discussion, we found that all 4 genes overrepresented in CACUT population, but significant differences were seen in frequencies of 82R and 81R gene. Following alleles were found to be increasing the odds of getting CACUT, that is ACE-DD, G allele of 82R, AC allele of 81R, and CC allele of AGT. And we found ACE-DD allele and 82R genotypes increase the odds of progressive deterioration by 14 and 7 times respectively. Coming to the specific, some pathogenic alleles, involvement of ACE-DD allele has been shown by multiple studies. Our present study showed similar results to the study done by Bajpai et al. In 2004. New findings noted in our study were that significance was seen more in subgroup of progressive deteriorators than total prevalence overall, thus emphasizing difference in 2 processes, that is impaired nephrogenesis prenatally and progressive damage postnatally. DD allele in combination with other genotypes cause more damage than DD allele alone, thus raising the possibility of synergism or second hit between RAS genes. Regarding AT2R gene, its involvement in mice and humans has been seen by other studies. Our previous study studied polymorphism at different sites and did not find any significant difference, but results have been seen with this A1332G mutation. Narasimhan et al. Found role of ACE, ID, and AT2R gene polymorphism in Indian children. AT1R gene study has been done in adult patients. We did first time in Indian children. In AGT, a synergistic action with DD allele has been shown by Lovati et al. To conclude, CAC could lead to significant morbidity in children. Around 1/5 deteriorate despite getting treatment. RAS genes play a significant role in incidence and progression of CACUT. ACE, DD, and AT2R gene polymorphisms increase the odds significantly. So, to conclude, preventing CACUT and preventing its progression are two different aspects of treatment. Way forward in genetic research involves whole genome sequencing and next generation sequencing, which are advanced techniques. And we must realize that CACUT is an interplay of complex factors. So we must focus on environmental factors and epigenetics. Thank you.
Thank you, Dr. Ankur. You have finished just in time with a few seconds to spare. Can we have the comments from Professor Darius Bagli?
Thank you. Another very interesting study. You mentioned, this is a small point, but you mentioned these genes having a role. Can you really say that at this point? This is more of an association, correct?
Yes.
Okay, I think one needs to be careful about that. As I listen to this, something strikes me, and I don't know if this is a problem in this definition of CACUT as being anomalies of the kidney and urinary tract in the definition of the acronym. But in the case of something like reflux, where the developmental anomaly embryologically is at the level of the ureteral bud and therefore interaction with the metanephrogenic blastema and kidney development, we can sort of see how reflux relates directly to kidney development. But in the case of valves and even UPJ, the principal defect, to me, I'm speaking as a surgeon, so not apologetically, but I'm speaking as a surgeon. The principal defect is at the level of the valves at the bottom of the bladder or the ureteropelvic junction outside the kidney, which creates a significant, especially when it happens early in embryo and fetal life, abnormal physical stimulus on the development of the kidney. As opposed to in VUR, and yet we're talking about sort of the potential role of these genes in the biology of the kidney and kidney function. All of your endpoints are revolving around kidney function, and yet a lot of these functional things might be very significantly related to the physical defect rather than the gene. And so how do you start to tease this out, especially when it gets to counseling later, assuming you have large numbers of patients, et cetera? This physical effect, because the gene may be certainly involved in the formation of the valve or the formation of the ureteropelvic junction narrowing, yes, and that's the focus of intensive studies by many. So could you comment? It's a difficult question. I don't know the answer myself, and I'm just interested to hear your thoughts.
Thank you, sir, for your question. Actually, we are also searching for the answers only. What I would like to comment is that it's difficult to separate from the severity of the obstruction that can definitely lead to bad outcomes. But what we saw is that we treated patients at ours is a Apex Institute. We gave the best treatment at the correct point of time when we detected the illness, and the outcomes were different in different patients. And so it came to us like why there is a difference when all the patients which we treated are getting the best treatment at the same point of time. So maybe that's why we thought of going into this area of genetic research, that finding some answers maybe that may lead to different sorts of progression in the patients.
Mm-hmm. Well, I suppose it's obviously one is looking for answers, but another way you could look at it is could you ask some new questions based on the data you're seeing? And I think that might be the way forward. So anyway, I'll stop there. Thank you very much.
Thank you, sir.
That's a very interesting comment from Professor Darius Bagli. Can we have the comments or questions from Professor Piccoli?
Well, Professor Bagley almost asked and underlined some points that I would have liked to do. In particular, I would also stress that it's very important to distinguish between the association and the cause and effect, especially at this time point. A point on which I would like to know your ideas, and I would like to make a comment, is the progressive deterioration of a kidney function, because 10 milliliters per minute is enormous as a deterioration, especially in small children whose kidney function is already, is on another scale. So 10 milliliters per minute, in how much time? This may be a question. And then you put together probably two different causes of deterioration. One is new scars that is usually associated with new infection, and that can be linked to the type of disease, and that can be linked also to the type of treatment, because you're very enthusiastic and I appreciate it, but it's very difficult to say that all our children had, or in my case, I am an adult nephrologist, all our patients have the best treatment. We try to give the best treatment, but we can never be sure that actually we always deliver the best treatment. But having said that, scars are usually linked to infection or to high pressure reflux, while the deterioration of a kidney function may also be linked to the fact that there is already an important deterioration of the kidney function. And as you know, the worst leads to the worst, is a vicious circle. So I would like you to comment on these aspects, and I would indeed suggest trying to distinguish between new scars without further kidney function impairment, new scars with kidney function impairment, and kidney function impairment without scars. And in the last one, I would imagine that proteinuria is also a very good marker. So thank you.
Thank you, ma'am, for your comments and ideas. And regarding the progressive deterioration definition, we had the same confusion, like what criteria should we choose for GFR, and we discussed that with the faculty of Department of Nuclear Medicine. They helped us in that. And I totally agree. Over a period of 1 year follow-up, it's not very correct to say that these patients have progressively deteriorated. Some scars may be due to infections, but we are following up our patients, and we'll definitely come up with more better, reliable results. Thank you.
Thank you, Dr. Ankur. It was a nice presentation. Can we move on to the next presenter, chairpersons?
Thank you, Dr. Ankur. I would now like to invite Dr. Dhruv for his presentation on study to identify the genotype-phenotype correlation in testicular biosynthetic defects and 5-alpha reductase deficiency with respect to disorders of sex development.
Respected chairpersons, seniors, and my dear colleagues, warm greetings to all. I would start by expressing my gratitude towards the committee for just a second. Respected chairperson, seniors, and my dear colleagues, warm greetings to all. I would start by expressing my gratitude towards the committee for giving me the opportunity to present my work on this forum. I'll be presenting my study on the genotype-phenotype correlation in testicular biosynthetic defects and 5-alpha reductase deficiency with respect to disorders of sex development. Every minute of every day, a baby is born. Most babies are easily identified to be a girl or a boy. It is difficult to imagine how confusing it must be when the parents don't know the sex of the newborn. This is rare and can be upsetting for the parents. For the clinician as well, the proper evaluation and management remains a Herculean task. Besides sexuality and fertility, main problem is the sex of rearing and the psychological impact of the child. 46XY disorders of sex development, especially testicular biosynthetic defects and 5-alpha reductase deficiency, have varied clinical presentations. The enzyme defect determines the phenotypic variations. The underlying endocrine disturbances vary in each. Knowing the genetic and endocrine defects would help in planning the early gender assignment, gonadal management, and predicting the fertility potential. It will also help us in identifying the high-risk group for close monitoring for malignancy and institution of any therapy. It will also provide us with the roadmap for future genetic counseling. In a child with ambiguous genitalia, early identification prevents gender dysphoria, and early prognostication helps in alleviating parental anxiety and initiating appropriate interventions. Very few clinico-epidemiological studies have been conducted to elaborate upon our knowledge on the different phenotypic variations among patients with testicular biosynthetic defects and 5-alpha reductase deficiency. The congruence of the genotype with the consequent phenotype is unclear. Thus, a study was designed to study the genotype polymorphisms in patients with suspected 5-alpha reductase deficiency and testosterone biosynthetic deficiency disorders, along with the correlation with the phenotype. Patient history, including demography, presenting complaints, and family history were recorded. All children with proximal hypospadias or children with hypospadias associated with undescended testes and a vaginal pouch without cervical indentation in the genitogram and absence of Mullerian structures were included in the study. This was a prospective study conducted over a period of 20 months in a single center. Along with the history part, general physical and systemic examination with a focus on genital examination along with secondary sexual characteristics was done. Pivotal development was staged according to the standard staging and pedigree charting was done. Radiological investigations such as pelvic ultrasound, genitogram, magnetic resonance, urography was done according to standard protocol along with karyotyping. Endocrine profile, including serum testosterone, dihydrotestosterone, and 17-alpha-hydroxyprogesterone were done. CYP17A and SRD5A2 polymorphism analysis was done on DNA extracted from blood sample using polymerase chain reaction, followed by restriction, digestion, and electrophoresis to identify the base pair change. The statistical analysis was done using SPSS, using chi-square test or Fisher's exact test. A total of 50 patients were included in the study. Out of these, 41 were assigned male sex at the time of birth. The median age at presentation to our center was 6 years. Family history of similar illness was present in 8 out of the 50 patients, and a history of consanguinity was present in 26% of the patients. Most of the patients at our center were aged 2 to 11 years, and few patients were aged less than 2 years or greater than 11 years. Among the phenotype variations which were found, associated undescended testes were present in around 52% of the patients and was unilateral in 28% and bilateral in 24%. Micropenis was present in 54% of the participants at presentation. Scrotal fusion was present in 30, and pinoscrotal transposition was present in 39 patients. The location of the urethral meatus was predominantly proximal location, majority being pinoscrotal, then scrotal, perineal, proximal penile. A few of these patients had distal penile and mid-shaft urethral meatus. The median testosterone levels in the study population was 2.2 nanogram per ml. The levels were higher in those who were aged greater than 11 years. Among the genotype variability, SRD5A2 polymorphism, the variant L allele was present in around 44% of the patients, whereas among CYP17A polymorphism, the variant A2 allele was present in 24% of the patients. The median stretched penile length was lower in those with the variant L allele. The median SPL stretched penile length was not different amongst those with different CYP17A polymorphisms. The baseline testosterone levels after HCG stimulation test, and the testosterone to dihydrotestosterone ratio was higher in patients with the variant LL homozygous genotype vis-a-vis those with the wild type VV genotype. Median baseline testosterone levels were significantly lowered in homozygous variant A2A2 as compared to the heterozygous variant, as well as compared to the homozygous wild genotype. The difference between the two groups was exaggerated on measuring the serum testosterone levels after HCG stimulation test. The odds of presence of undescended testes was higher in patients with the presence of variant L allele in SRD5A2 gene. The family history of similar illness in the family was more commonly seen in patients with the variant L allele. The age at presentation was slightly less in patients with the A1, A2 heterozygous gene allele. The median stretched penile length among patients with the A1 genotype, A2 genotype, and A1 A2 genotype was not different. Based on the receiver operating characteristics curve, the stretched penile length greater than 3.5 centimeter predicted the absence of the variant phenotype with a sensitivity of around 71% and a specificity of 63%. A value of testosterone to dihydrotestosterone ratio above 16 was able to predict the presence of L allele with a sensitivity of 86% and a specificity of 96%. And the baseline testosterone levels above 1.3 nanogram per milliliter were able to predict the absence of A2 allele with a sensitivity of 84% and a specificity of 83%. Elevated testosterone to dihydrotestosterone ratios at baseline and after HCG stimulation test support the diagnosis of 5-alpha reductase deficiency. However, these ratios may be normal in some patients with 5-alpha reductase deficiency. Therefore, analysis of steroid 5-alpha reductase type 2 gene becomes a reliable approach to confirm this disorder in these patients. The suspicion of the diagnosis of this 5-alpha reductase deficiency has traditionally been based on the hormone analysis. The HCG stimulated testosterone to dihydrotestosterone ratio of greater than 10 is often taken as a supportive biochemical evidence for 5-alpha reductase deficiency. Latest evidence suggests that the cutoff used is not sensitive enough to exclude the diagnosis, and many expert centers nowadays opt for a genetic diagnosis. Our study predicted a ratio greater than 16 having a good sensitivity and specificity to predict the presence of the variant L allele. Lower testosterone levels were found in patients with CYP17A mutation. Significance of genetic testing and diagnosing them lies in the fact that androgen supplementation followed by masculinization surgery could result in near normal result with a normal fertility. Correct and early diagnosis is essential. As a result of pre and postnatal brain exposure to androgens, almost 70% of individuals with 5-alpha reductase type 2 deficiency and 46XY karyotype raised as girls develop a male gender identity and change the gender behavior in adolescence or early adulthood. To conclude, genetic testing is a definite part of the management of 46XY DST when supplemented by adequate clinical and hormonal evaluation. V to L polymorphism is an important cause of 5-alpha reductase deficiency. The diagnosis of 5-alpha reductase deficiency was made in 16% of the patients using this gene polymorphism, in which the hormone analysis was equivocal. Complete phenotype has a correlation with the genotype in polymorphisms. Hormonal analysis is not definitive for the diagnosis, and lower levels of baseline testosterone and dihydrosterone testosterone levels in patients with CYP17 gene mutation were observed. Early diagnosis should be followed up by early sex assignment, management, and prognostication for future fertility and gonadal malignancy risk. Further large-scale studies and studies that include exome sequencing could throw further light on the degree of phenotype-genotype correlation in these patients. Thank you.
Thank you, Dr. Dhruv, for your insightful presentation. Can we have the comments or questions from Professor Piccoli?
Well, it's a very interesting and elegant study. You would need an endocrinologist more than a poor nephrologist. Actually, I have just some perplexity, but you try to explain it in the last part of your talk. What does really add the genetic to the clinical management of these patients? And another thing in this regard that makes me a little bit perplexed is the relationship between these forms that you described as mainly linked to one copy of altered gene in the cases that have consanguinity. So it's probably it would be probably, and this is a comment and a suggestion for the presentation of your study, better to try to divide in what you consider probably dominant and probably recessive, because it's the only way to explain the role for consanguinity, or is the main way to explain the role of consanguinity. And the other thing is that it would be probably very useful to have a sort of flow chart to better address in which cases genetics is really needed. Genetic is interesting in any case, because it helps us explaining and understanding what's going on. But clinically, it looks like it's useful in some subsets of patients. And if you prepare this elegant study for publication, you should probably try to highlight in which patient genetics really adds a lot. Thank you.
Thank you, ma'am, for your comments. We'll certainly incorporate that as well.
Can we have the questions or comments from Professor Bagli?
Thank you. Another interesting study. I was struck by a couple of things. One, I think you said at the beginning, you made a quick comment about genotype and importance and helping to prophylax or predict gender dysphoria. So you mentioned this at the beginning. And then I think you said 9 patients were assigned female sex of rearing. I was curious about them. Can you comment on their follow-up? How old are they? Has there been any gender dysphoria with them? Is it too early to say? Were they analyzed in this group? It's often the little things that we sort of put to the side sometimes become the most interesting at times. So I was wondering if you could just comment on that, and then I have another question after that.
Thank you, sir, for your comment. There were 9 patients who were labeled and reared as females at the time of birth because of the completely phenotypic female presentation at the time of birth. However, 8 of those patients actually had sex reassignment and were labeled as male childs, especially in our socioeconomic status. One thing is that these patients had androgen imprinting during their prenatal and postnatal time because of the exposure of androgens, and they were more likely to be more acclimatized by their sex rearing as male. And the other aspect, which is more important in our Indian socioeconomic status, is that even an infertile male is better suited in our society as compared to an infertile female. Among those patients, 8 of those had a sex reassignment and were labeled as and were reared as males, whereas one child was continued to be reared as females.
How old are those 8 that were, or how old are these patients? Do you know roughly at this point?
Sir, the median age was between 2 to 8 years, sir.
Of these 9 patients?
Yes, sir. Yes, sir.
Okay. And was the reassignment done not for any findings, but for the other cultural, social reasons that you mentioned?
Sir, the social reasons are one aspect of it. The other was that most of these patients had palpable gonads as well as total type of hypospadias, and they were amenable to the masculinizing genitoplasty as well as orchidopexy, and the parents chose to rear the child as male only.
Yeah, makes sense. That makes sense. The other question I had around 5-alpha reductase deficiency is this issue that goes back to, I believe, how 5-alpha reductase deficiency was first discovered, in that the genitalia can be ambiguous and potentially, run along the category of female early on, yet at puberty, there's a significant change occurs, and this has to do, I think, with sort of additional post-pubertal activity of the enzyme despite its deficiency, which then speaks to the whole question of penetrance in a genetic study. So could you comment on that in the context of your findings?
Thank you, sir. Based on the history of the identification of this 5-alpha reductase deficiency, which was initially called PNESAT12 disorder, in which at birth these children are born with almost completely female type phenotype. However, during puberty, the action of the testosterone is surmountable and is able to do masculinization of these patients, and they generally also these are called as a female to male transformation, which occurs at puberty. That is why therein lies the role of early identification of these patients and to properly assign them as male childs, as they have the capability to completely develop secondary sexual characteristics that are of the male type, and thus lies the crux of our study, that if we are able to correctly label them as male sex and change the sex reassignment if they are labeled as female, then they will be better suited for further male phenotypes.
Okay, thank you.
Thank you, Dhruv. Can we have the expert comments from Professor Bajpai?
Good afternoon, everyone. Dr. Bagli, 2 of your points which were very important. One was that in the latter case, the PNESAT12, the 5-alpha reductase, definitely we see them, they go on as girls, and then suddenly at 12 years of age, the penile growth happens. And there are many other structures, increasing little bit of length, as well as the prostate size also increases. So one can only ponder that, is it the threshold which is crossed? Maybe because we all know if you put 2 and 2 together, it's puberty when the hormones increase, the Leydig cell stimulation would be there, and then suddenly the surge takes place. There is a possibility that it crosses a certain threshold, and beyond which would therapeutically bring a question that if you don't have DHT, if you give higher doses of testosterone, possibly it might have the same effect. Obviously, premature epiphyseal fusion and other consequences of testosterone early induction would be having a problem. Second thing was the gender dysphoria issue, which again calls for a little more discussion. And I think we have to ponder about it. I can upfront tell about you about a case who came, was reared as a girl, and then they came to us and we realized that she is or he is a phytolipid reticulases deficiency. And we told them that the penile growth is something where if you want, we can do masculinizing genitoplasty. So this was a case where actually one would have thought that a gender dysphoria would have prepondered, and predominantly she would have said, well, no, fine, I'm going to become a boy now because I had those feelings, etc., which happens with gender dysphoria. Surprisingly, and we give them about 6 months time to go home and come back again, because that's the time the family needs to psychologically overcome the shock, the kind of shock which they received. And yes, so they returned and said, no, I want to remain a girl. So I think there is a multifactorial contribution where environment, the schooling, the peer pressures and a lack of it, etc., they club together. So I think you are right that the cases like these, that's where we should stick up and then try to dig deeper and see, are there any inferences which could be drawn? Can we do some studies and trials later on just to taking this thread forward? That was wonderful.
Absolutely. And you open a door to an entirely other conference that one could have on this topic, because we, in pediatric urology, certainly our focus is on genital development and reconstruction and trying to do the right thing, and yet nowhere else in the body in surgery is there such a complex multifactorial set of other factors that need to be discussed and understood: cultural, brain, psychology, everything that doesn't affect liver surgery or heart surgery or orthopedic surgery, but it affects this surgery, and similarly this biology and all of these studies. So you raise a hugely important point here that I think we really need to confront as we move into the next decades of research in this area.
Thank you very much, Dr. Bagli, and also thank Georgina. Both of you, Dr. Bagli was busy with conducting that examination and he could just find time enough to chip in with us. And Georgina, I know that I was told that you are very busy, but you still found time to be with us.
Thank
you. Thank you, Dr. Dhruv. Can we move on to the next presentation?
Thank you, Dr. Dhruv. For the next presentation, I would like to call upon Dr. Tanvi to deliver a talk on outcomes of management of unilateral pelvic-ureteric junction obstruction in children, a retrospective study over a 10-year period.
So is my screen visible? And I'm audible?
Yes.
Yes, Tanvi.
Okay. Good evening, everyone. Thank you for this opportunity. I'll be discussing outcomes of management of unilateral pelvic-ureteric junction obstruction in children. This was a retrospective study conducted over a 10-year period at the All India Institute of Medical Sciences, New Delhi. So pelvic-ureteric junction obstruction, as we all know, is the most common cause of antenatal and neonatal hydronephrosis and the most common cause of urinary obstruction in children. The incidence is 1 in 1,000 and to 2,000 live births. Unilateral cases are more common, that is 1 in 5,000 to 8,000 live births. The obstruction occurs at the level of the junction of pelvis with the proximal ureter. This leads to hydronephrosis, which leads to back pressure, which leads to progressive renal damage and possible renal deterioration. So we set out to analyze outcomes of management of unilateral pelvic-ureteric junction obstruction treated over a span of 10 years. Our primary objective was to evaluate the outcome of those who were managed non-operatively, with those having a function of more than 40% on renal dynamic scan. The secondary objectives were to compare and evaluate the differences in outcomes of patients managed with upfront surgery versus those managed conservatively versus those who had to undergo surgery later, and then to evaluate the need for operative management in these patients who had to undergo surgery later. So we had a total of 312 patients, and after applying the inclusion criteria, we had a number of 165 patients who had a follow-up of more than equal to 24 months subsequent to operative intervention. The period of analysis was March 2008 to May 2018 at a single tertiary care center. We had two main groups. Group 1 was early pyeloplasty at diagnosis. That was either because the children were symptomatic or they had a function of less than 40%. Group 2 was those who were managed conservatively. That is, they were asymptomatic and had a function of more than equal to 40%. This was further subdivided into those who had to undergo surgery, that is 2A, either for development of symptoms or a fall in function of more than 5%, and 2B, who were continued on conservative or non-operative management. So out of 165 patients, we had around 65% patients who underwent early surgery or early pyeloplasty. The main indication were symptoms and function less than 40% or a combination of these. The second group of conservative management was around 35% patients. And out of these, around 24% had to undergo surgery later, that is late pyeloplasty, whereas the rest continued to be on non-operative or conservative management, that is 75% patients. So I'll be mainly discussing the results with regard to renal dynamic scan, although we compared the ultrasound parameters and other parameters of these patients as well. So mainly we had infants in our cohort, and the main differential function of the affected kidney at initial presentation was around 35% for all patients. Amongst those who underwent surgery, the renal function was less than equal to 20% in 20% patients. It was 21 to 40% in 45% patients, and it was more than equal to 40% in 35% patients who underwent early surgery, and all patients of the conservative group. And at follow-up, that is at the first, either the first renal dynamic scan or at the last renal dynamic scan, the mean differential function rose to 39% across all groups. For those who underwent early surgery, it improved from 35% patients to 54% patients in the subgroup of more than equal to 40% at the endpoint of study. And the incidence of the lesser functioning groups, that is less than or equal to 20%, it decreased from 20 to 11% patients. And it decreased from 45 to 35% patients in the 21 to 40% subgroup. This was clinically significant. And amongst those who continued to be on non-operative management, the function was preserved roughly, and there were only 9% patients who showed a deterioration. But even in these patients, the function was above 40%, and they remained asymptomatic. Whereas in those who underwent delayed surgery, there was a fall in function in 43% patients. But again, in 70% patients, this was more than 40%, whereas it had decreased to less than equal to 20% in only one patient and 21 to 40% in 3 patients. So this is a graphical representation of the same. There were 10 patients in the delayed surgery group who had a fall in function, but remained above the cutoff of 40%. So the debate regarding the best time to operate pelvic junction obstruction started in 1980s, and most studies at that time advocated early repair. In fact, at that time, pyeloplasty was the conservative mode of management. However, in 1985, Ransley et al. Were the first to stand up for conservative management of pelvic junction obstruction. And over the years, there have been several studies done on both timing and indication of surgery in this disease or pathology. The timing regarding that, there have been various studies regarding neonatal pyeloplasty or pyeloplasty done at infancy for greater relief of function and better chance for growth of the kidney. And there have been various studies exploring the indications like ultrasound parameters, renal dynamic scan, washout curve, cortical transit time, and many others who have suggested various management protocols regarding hydronephrosis and the obstructive type hydronephrosis, that is the pelvic junction obstruction. So while using standard investigative modalities like ultrasound and renal dynamic scan, the management of symptomatic patients or those with function less than 40% is not controversial, as they seem to do well with surgery or pyeloplasty. But in these, there is a subset of less than 10% in which there is some debate regarding nephrectomy or pyeloplasty. But overall, the most controversial group remains those who have a unilateral pelvic junction obstruction but are asymptomatic and the function is more than 40%. Should they be managed with pyeloplasty, or should they be conservatively observed and continued on follow-up? And when should they undergo surgery? And what should be taken as the indication of delayed pyeloplasty in this subset? What are the chances of permanent damage to those who are managed initially conservatively and later undergo pyeloplasty? What are the chances of recovery of function? To what level does the function return to baseline? And in those patients who we are managing non-operatively and are closely following up, till how long should we follow them up? So the controversy and the questions remain regarding the best management of patients with unilateral pelvic junction obstruction. However, with our management protocol, overall the patients remained or became asymptomatic and experienced a maintained or improved renal function and even washout curve across all groups. So our management protocol was not prone to any serious or irreversible loss of function. Thank you.
Thank you, Dr. Tanvi. You finished just in time. Can we have the comment from Professor Bagli?
Thank you. Interesting study, and it highlights to me sort of similar challenges that we all face in trying to understand what the optimal thing to do is with these patients. When I was reading your abstract and you made a quick comment about this, you know, various of us in this field have our sort of favorite way of dealing with these patients. I happen to be a staunch believer in ultrasound over the renal scanning modalities. Others put more emphasis on the scanning modalities. So I was interested to know, and I don't know if you can summarize because you didn't talk about it, but how you used ultrasound in these patients. In my hands anyway, and in our group particularly, we do a lot of ultrasounds because they're non-invasive. They don't involve radiation, at least, and we follow and look at trends and changes in how these studies are playing out in helping to make these decisions. So could you comment? I'll start by commenting on that.
Sure, sir. Thank you for your comment and question, sir. Sir, we used ultrasound for all our patients, but could get the data of only 107 of the 165 patients, and that is what we used for comparison. Actually, the ultrasound was used in all patients, but it was done at various centers. Some of the patients came with the ultrasound, or some of them underwent the ultrasound at our center, or some of them did not come with a follow-up later with the ultrasound. So we included patients who had a renal dynamic scan done at least once after surgery or at least once at follow-up. But for ultrasound, we couldn't use the same parameter for follow-up. However, the parameters that we used were the standard things that are done on ultrasound, that is the pelvic diameter and the renal pelvic diameter and the parenchymal thickness and the hydronephrosis of the contralateral kidney. And these were significantly observed in the surgery group. That is, they responded well to the surgery when we had compared them on follow-up.
Okay, you mentioned there were, I think it was 10 in your delayed surgery group, patients who underwent surgery but still had a function greater than 40. I know some of the delays were done for symptoms. Were any of the patients delayed surgery greater than 40 asymptomatic? And if so, why did they have surgery?
No, sir. Out of those who had had a fall in function, either we also had took a criteria of 5% fall in function. So that was also used as a delayed surgery criteria. And we, apart from that, they were mostly the 10 patients who underwent surgery. They were mostly symptomatic, and they remained the likely thing that they remained more than 40% was that they were a group of hyperfunctioning kidneys. Like their initial function was around 60-65%, and that fell to around 50-56%. So that is why they remained above the 40% cutoff that we used.
But they were symptomatic.
But they were symptomatic, yes.
Okay, so they were and if they became symptomatic, it probably wouldn't have mattered what the function was. Is that correct?
Correct.
Yeah, okay. And do you have any plan to, I think one of the big missing links here, so this is more a comment, I don't know if there's a question coming. One of the big missing links here, because you showed us a lot of other studies where people have done similar things here, is that what really goes on in adulthood with these patients after all of these different various ways that you manage them and we manage them and the rest of the world is managing them. And they're all similar, but they're all a little bit different. And we're all asking the question, are we doing the right thing? And yet these people are out there, but we don't know ultimately how they've done. And you would think that that might be one of the, you know, if you were not a nephrology, urology person listening to this conversation, you would think that that would be the obvious question. And where maybe, yes, there are limitations in data and we don't look after them anymore and all of that. That's a big issue. But you would think that would be where the money is to really go after a cohort of these people. I don't know how well you could find yours or how easily we could find ours, but maybe this could be a call for setting something up to actually once and for all at least have a way to tag these patients later into adulthood and track back to this kind of protocol and see, or these kinds of protocols, and see how they're doing. Maybe we'll find there's no difference between any of them. They all do okay. Or there's something at the very beginning that destines them to do one way regardless of what we do. So that's kind of more of a comment, but if you'd like to comment as well. Does your institution have the capacity to do that, for example?
So we usually follow up these children. We usually get them at infancy or with an antenatal diagnosis. So we usually follow them up till 7-8 years, but not generally into adulthood. So that would be a difficult thing to do, but we could. That is a very good idea for a future study plan. Or
yeah, because at our institution, pediatric care is to 18 years old, and it's roughly around there around the world, give or take. But after that, they're gone, and the linkages are then into whether they even have an adult urologist or nephrologist or not. That whole transitional thing. We're not the only ones that have this problem. Is a big deal, and we should really start to make some noise about that to find out what it is we're doing at that end of the life spectrum, right? Thank you.
Thank you, Dr. Bagli. I would chip in once we hear from Georgina.
So, I have to work with Dr. Bagli because we see the things in such a similar way. My point was also about the length of follow-up and about the fact that there might be some loss of follow-up of these patients, and probably the ones that stay in follow-up are the two opposite. On one side, those who have a better compliance and family adherence, whose family understood better. That's very important to follow them. So they are the best ones. And on the other side, those who were more touched clinically by by the disease, who are more symptomatic, who had more complications, and that get more scared, but this might be a negative selection. So my comment was, even in the short term, probably it would add to your study to be sure if everybody had been followed and to try to see the profiles of those who drop out. And indeed, the point is, for me, I'm a nephrologist of elderly people mainly, and of adults. But as we will partly discuss in my talk, the point is also for female in pregnancy, because some of these young girls are just labeled as everything has been done. There is this miracle idea of surgery. It had been corrected, and then we find them with preeclampsia, with difficult pregnancies. And actually, we're trying to do something about that where I work in France, which is not so easy because it means patient education. But I think it's something that should be remembered, even if it can be funny to tell the family of a girl 10 years old, when she will be pregnant, you will have to take care. But I think it's a message that's very important, and probably pregnancy is also a window on future health, is a challenge, and might help us understanding better what we have done. I don't know if you can comment about that.
Thank you for your comments and suggestions, ma'am. Definitely the families and the patients who understood the disease better and the pathology better were the ones who were easier to follow up and easier to manage conservatively, as has been shown in earlier studies as well, that if the patient education and the patient level awareness is enough, then conservative management is the way to go for asymptomatic and better functioning patients. Regarding the pregnancy patients, ma'am, I'll have to look up and see. But definitely following them into adulthood will give us an insight on what was or how it was the better way to go to begin with.
Right. Thank you, Georgina. Thank you, Dr. Bagli. Thank you, Tanvi. Well, the question that Dr. Bagli asked was that if, and Georgina, you also mentioned the same, that if you follow up these patients long enough, what really happened? So we did that. We did it about 20 years ago, and we followed up a group of patients who underwent pyeloplasty. And when we found that during our follow-up, that we have a clinic where we follow up our cases for as long as they can come. And we found there was a gradual decline in function despite successful pyeloplasty, despite the functional test showing drainage, no obstruction. Then we looked at the genetics of that, and we found, do some patients have a genetic propensity to injury? And we found that angiotensin converting enzyme gene insertion deletion polymorphism was present in some patients who showed decline in function. So we divided the patient into three groups: the I allele, the D allele, and the ID. Those with D allele preponderance, either as DD or ID, had a decline in function. And we had done this study not only for PUJ, there were about 30 such PUJ. We also had PUV and VUR together. So when we substratified and did a multivariate analysis, we found D factor. The D allele was responsible, despite your successful intervention, to have a propensity to cause ongoing renal injury. So as they become adults, because those who have genetic propensity are at risk for decline in function. We published this paper somewhere about 15 years ago in Journal of Urology. And that was the first paper from Asia as to the genetic influences on what happens to these kidneys even after we do surgical intervention. Now, we all know renin-angiotensin system pathway is all over now. It's from brain to the kidneys to GIT. It is creating havoc. If it goes unrecognized, it has its own issues. If you don't know, you will not know what is happening. And as a result of that, we studied it further, and we started interrupting it. So what we did in a group of patients with vesicular reflux, where we found that this system is activated after successful treatment of intervention, when it was activated, we cut the pathway. We blocked the system by giving them a captopril for that matter. And we found that once we added captopril, there was a gradual improvement in function. So the genetic influences which are detrimental to ongoing improvement in function could be cut off. So genetic studies are not going to the shelf only. They can be translated into clinical usage. And that's what we have proved. So we have done that. The second aspect of the question was, there are some patients who would escape identification during their early childhood, and they present to adults at PUJO. And I just imported that information, Dr. Bagli, from that could also be a question, that adults who present to us with for pyeloplasty, large kidneys, what has happened there? So the pelvic characteristics, each patient has got a pelvic wall characteristics. Some of them, the extrarenal pelvis will keep on blowing up, and it will buffer all the damages which may happen in the tubulo-interstitial compartment as a result of obstruction. There are others in which there will be a limit, and the pelvic dimension will not grow. And as a result of that, there'll be back pressure effect, and there'll be a very steep fall in function. That's another group. Sometimes it may plateau off. You can see a 70-year-old lady with a hydronephrosis, and somebody would say, well, it is an incidental diagnosis. Why operate? She has survived all the years. So, but as far as Puritan science is concerned, what has really happened is things have balanced out. She has escaped. Her kidney has also escaped. The body has taken over. But when you see a baby like that, you would offer intervention. You don't know what will happen to that. So that was part two of what we thought about it. And so therefore, we have a constellation of clinical scenarios. When you have a PUJO, you can have a child in which the child may continue and it may recur obstruction. See, we have also seen that all this philosophy of doing conservative management in PUJO was because they found that ultrasound was not the best investigation. And as you had mentioned in your first sentence, Dr. Bagli, that people would use a mix of investigation to find out a renin index. So we did plasma renin activity. We found that if the tubulo-interstitial compartment is under pressure, it will release renin, and it did so. We have published this also in Journal of Urology and in Journal of Pediatric Urology. So basically, there are elements of study, and I think the search is going on. More or less, we have to find an index where contributory imaging, like ultrasonography and isotope studies together, along with some biomarkers, can help us find out which is the case which would require a call for surgery. It's a big topic, and we will have you, Dr. Bagli and Dr. Giorgino, to discuss these in greater detail, because we run courses throughout the year, and we'll tell you beforehand this time so that we have your dates and you can all sort of help us understanding things. Thank you so much.
Thank you, Professor Vajpayee. We'll move on to the next presentation now.
Thank you, Tanvi ma'am. I now invite the last presenter of the session, Dr. Ruchira, for her presentation on evaluation of interstitial cells like Cajal-like cells, interstitial cells of Cajal-like cells at the pelvic-ureteric junction in children with pelvic-ureteric junction obstruction, a prospective study and review of literature.
A very good evening to all. I'll be presenting our evaluation of interstitial cell of Cajal-like cells and histopathology in children with pelvic-ureteric junction obstruction. Pelvic-ureteric junction obstruction is the most common cause of postnatal hydronephrosis. Its etiology is still debatable. Multiple theories have been proposed, including decreased ureteral caliber, defective muscle fibers, which may be deficient, disorganized, or dysmorphic. Conduction disorders of smooth muscle and increased deposition of laminin, fibronectin, and collagen have also been described. Variation in the density of interstitial cell of Cajal-like cells has also been proposed. Interstitial cell of Cajal has already been established as pacemaker cells in the gastrointestinal tract. Cells similar to them have been found in the urinary tract
and termed as interstitial cell of Cajal-like cells. The role of interstitial cell of Cajal-like cells in modulating the transmission of peristaltic waves across the pelvic junction has been emphasized by the recent researchers. And the variation in the density at pelvic junction may have a role in the development of pelvic junction obstruction. A few studies have evaluated the interstitial cell of Cajal-like cell density at pelvic junction, however, have reported variable results with like increase, decrease, and no change in the cell density. So we planned a study to evaluate the interstitial cell of Cajal-like cell density and histopathology in pelvic junction obstruction. A prospective study was done over a period of 2 years to include all PUJO patients who underwent Anderson-Hines pyeloplasty. Control were Wilms tumor patients who underwent nephroutectomy without pelvic junction involvement. Observation parameters were interstitial cell of Cajal-like cells density and histopathology at pelvic junction in the study and control group. Interstitial cell of Cajal-like cell density and histopathology at pelvic junction and resected margin in the study group were also compared. Immunohistochemistry was done using c-Kit antibodies. Evaluation of c-Kit positive cells in 10 consecutive high power fields and grading was done. 0 to 1 cells per high power field was taken as grade 0, 2 to 5 cells per high power field was taken as grade 1, 6 to 10 cells per high power field was taken as grade 2, more than 10 cells was taken as grade 3. Histopathological examination was done using hematoxylin and eosin stain, and muscle hypertrophy and fibrosis was seen, and grading was done for them. Coming to the results, the study group included 37 pelvic junction obstruction patients, and the control group included 13 Wilms tumor patients. There was a male preponderance in a study. More left-sided kidneys were affected. On comparing the interstitial cell of Cajal-like cell density at pelvic junction in the study and control group, significantly less density of cells was seen in the study group. And comparing the interstitial cell of Cajal-like cell density at PUJ and the resected margin of the study group, significantly less density of cells was seen at the pelvic junction. And comparing the muscle hypertrophy and fibrosis at between study group and control group, significantly more muscle hypertrophy and fibrosis was seen at pelvic junction in the study group. On comparing the muscle hypertrophy and fibrosis at pelvic junction and resected margin of the study group, significantly more muscle hypertrophy and fibrosis was seen at the pelvic junction. Various studies have been done to study the interstitial cell of Cajal-like cell density, which have reported increase, decrease, and no change in the cell density. However, most studies, including our study, reported a significant decrease in the cell density. Similarly, in the histopathology also, variable results were noted in different studies, while most studies, including our study, supported the increase in muscular hypertrophy and fibrosis at pelvic junction. The difference in the results of the studies may be due to difference in the controls taken and slight difference in the methodologies adopted. The strength of a study is that in most of the studies, approximately 10 patients and 5 controls were taken. However, our study has included more number of patients, that is 37 and 13 controls. Comparison was done not only between the study group and control group, but we also compared in the study group the interstitial cell of Cajal-like cell density at pelvic junction with the resected margin. The limitation of a study was the lack of ideal control, which could have been a pelvic junction of the individual with no pathology. To conclude, our study adds to the current knowledge of the etiopathogenesis of the pelvic junction obstruction. A significant decrease in the density of interstitial cell of Cajal-like cells increased muscle hypertrophy and fibrosis at pelvic-rhotic junction in children with pelvic-rhotic junction obstruction may have a role in the etiopathogenesis of the disease. Thank you.
Thank you, Ruchira, for an interesting talk. Can we have the comments from Professor Piccoli?
Well, this is a very urologic paper, so I just have two very short comments to understand from the point of view of a nephrologist. First one, is there any relationship between your findings and the severity of your obstruction? And the other point is, you mentioned, and indeed is the selection of controls is probably a point that should be better explained. But I was wondering, are there standard data on healthy children, for example, from autopsy series that can be used as an indirect control, or is something that has not been extensively studied in different settings?
Ma'am, first of all, we had planned to study the severity with to compare the function of on renal dynamic scan with that of the interstitial cell of Cajal-like cells, but that would have required more number of the patients. So we did not categorize the patient based on the interstitial cell of Cajal-like cell density and grouping, and we did not group the renal function also. Like lower function would have may have had more or less number of interstitial cell of Cajal-like cells, but that would have required more number of patients. And we would need to plan another study for that. And coming to the control, like other studies, some studies had taken Wilms tumor patient only as control. Some had taken postmortem specimens. Some had taken the patients who had undergone some trauma surgery for their controls. But in our setting, we found Wilms tumor patient as the most convenient group of patients for from whom the sample would can be easily taken.
Can we have the comments from Professor Bagli?
Thanks. Another very interesting study. I was curious, have you thought about, you mentioned a little bit about the role of these cells, at least what's known perhaps in other contexts. So how does the role of these interstitial-like cells of Cajal relate to your results and UPJ obstruction? Can you comment on that first?
So,
does it fit?
Yes, so the density of these cells were significantly less at pelvic-rhotic junction compared to both control as well as the resected margin which had normal ureter.
So can you explain what, based on at least what you're looking at, the data you're looking at, what do you think is going on? Does this fit?
Yes, sir. Because of decreased peristalsis across that region, decreased motility can be there and leading to significant dilatation of the pelvis.
Okay.
Can lead to functional obstruction.
So that seems to fit at one level, but then how do you account in trying to put this together for the increased muscle hypertrophy in the same area that you have
in decreased
density of cells?
We compared that also, but there was no correlation between the two. Like if there was increased we correlated both the fibrosis as well as muscle hypertrophy, but we found no correlation
No correlation between what?
between muscle hypertrophy and interstitial cell of Cajal-like cell density, as well as interstitial cell of Cajal-like density and fibrosis.
Okay, so do you think these are two separate things? Could they still be related?
They can be related. They can be related, but we did not find any correlation between.
So how would you test this? Do you have any idea methodologically, biologically, at the cell biology level, the kinds of questions you might, assuming the tools are there, the kinds of questions you might ask?
We can ask if increased muscle hypertrophy, in patients with increased muscle hypertrophy, is there always a decrease in interstitial cell of Cajal-like cell density?
Right, but you're still going after sort of an associative question. Is there a way to manipulate the function of these cells that you're aware of?
So I did not get your question properly.
Can you turn these cells on and off, for example?
Yes.
Is there a way to do that?
There are the cells which can block c-KIT positive cells. We can use some antibodies or something like that, which can stimulate or block the pathway of these cells.
Okay, so maybe I'll stop you there. But what I was trying to get you to go is sort of understanding what the pathways underlying the function of these cells are, and can those be stimulated? Can those be inhibited? And are you aware of any animal models of UPJ? Because working with patient samples is obviously very important, but also very limiting at the same time.
Yes, so studies have been done on murine models, rat and mice.
What kind of models do you know?
Peristalsis has been studied, where increased at different levels in pelvis as well as pelvic junction and ureter also. Density of cells have been studied.
I believe I don't know the details, but I heard about this many years ago, that there is a mouse model.
Yes,
of UPJ obstruction, where the mice spontaneously develop UPJ, and that could be a way to start manipulating some of these findings.
Yes, sir.
Okay, thank you.
Thank you, sir.
Thank you, Ruchira, for your talk. Thank you to the chairpersons, Professor Bagli and Professor Piccoli. Now we'll be moving on to an insightful talk by Professor Darius Bagli regarding publishing a research article on pediatric urology topics, expectations of an editor.
Thank you. I don't know how insightful it'll be, but I just wanted to make a few remarks about that. Thanks again for the invitation. As a disclosure, I should probably point out, I think it was a few months ago, I became the editor-in-chief of Frontiers in Urology, the new urology journal that some of you might be familiar with. So we've had sort of opportunity to think about some of these things. And when you actually ask the question, what is the sort of expectation of an editor, that's actually a rather simple question, because the expectation of any editor of a medical journal is to publish good research. So really the question is, what makes good research, right? And that's the thing one should be thinking about. And the thing I say to people over the years, sure, as you're starting out, you're going to be looking around for research opportunities and project opportunities, and sometimes there are things ongoing that you can jump into, and that's a very common thing. But I would say that if this is something one wants to pursue, that the most important thing would be to choose a topic that really interests you, that you really find fascinating, just even at the simplest level. the question and the phenomenon seem to really grab you, and you can't kind of get it out of your head, and you think about it in the morning and you think about it when you go to sleep, that's the thing you should be studying. So if you ever come across anything in your travels in urology as you develop your careers, that would be the thing I would think you should really think about. The other thing is to ask yourself whether the area or the question I'm going to ask is going to have significant impact. Does it have potential for impact? Now, granted, we can't all be doing things that have explosive impact, but if you can set that as your sight and then plan to do research questions that are connected to a bigger question that has large impact, that'll really help drive how you publish and how you approach your research topics as you move along, because you're really trying to look for what is the real big question here in this area. And we've talked about a number of areas here today: EPJ, valves, reflux, but that would be one of the things that, like, what would a reader really want to know about? What would a reader really grab them to keep reading rather than just publishing for the sake of publishing? So that would be another point. That's another point I make commonly. Another is the phrase I use is, don't measure something just because you can measure it. And this happens a lot. The tools are there, the numbers are there, we can measure this, so we measure it. But one frequently sees when one is reading manuscripts and studies is it's not clear why the data is there. Why was this measured in the first place? And often, unfortunately, it's because it's easy to do. And what one really needs to be thinking about is, do I have to find a different way to measure the thing that's actually potentially more important than the thing that's just easily in front of me? So that's another thing to sort of keep in mind as you move forward and develop a research question. And similar to that is studying things because there's some data lying around. And that is also a common issue. And therefore that leads to incomplete information. Sometimes the most important information that you might want to use to address the study is actually not there because it wasn't collected in the first place. And that sort of raises the issue of, and this is a more complex thing, it's not an easy answer, but the idea of thinking more about sort of programmatic patient registries and how to participate in them or how to set them up. And even to do that, one then also needs to have an underlying sort of set of questions to follow a particular disease group, almost observationally and prospectively. Another point that is surprisingly missing in a lot of publications that are submitted is the lack of a hypothesis. What is the question in the study? What is being tested? What are you trying to show and prove or disprove with your design and with your data? And one will often read an entire manuscript and it won't be clear actually what was being tested. What were the objectives? What were the goals? So it's important I think, to try and make it easy for the person reading to really understand what the motivation was for a particular research question, and what question you're trying to answer. Now, sometimes there may not be a hypothesis in a particular question, and we call those descriptive studies. And there's nothing wrong with those, especially if they haven't been, if the thing you're describing hasn't really been described well before in a particular series or something. And that can be very important because, as we've seen today, a lot of new, interesting, and important questions can come out of that. We call that hypothesis generating. So that's the difference between the two. But if possible, it's always worthwhile to ground a study to have a clear hypothesis. And I made comments about surgeons and surgery earlier, and so that brings me to another point, and that is to remember that surgery itself is not a disease endpoint. Surgery is not part of the natural history of a medical problem. Surgery is a thing that happens because a surgeon or a team took information and integrated something in their head and made a decision to operate on a patient. But that doesn't make surgery an endpoint unless you've specifically defined your question that way. And that's often a trap that studies fall into, and make conclusions based on sets of data and said this resulted in surgery and this did not, therefore. But that's there's a fallacy in that logic, because the surgery was actually decided for a different set of reasons. So what I think one needs to be very clear about that. And finally, I think I would sort of, from a publication point of view, purely practically, it seems like a logical thing and an easy thing to do, but it's surprising the number of times this doesn't happen, is just follow the instructions of the publication you're submitting manuscripts to. Everybody has, it's a bit annoying sometimes, but all different publications have different requirements, and they want you to follow those. Otherwise, that impacts on your ability to move the manuscript through the process. The other thing I would suggest, and probably very few people do this, is communicate with the editors, communicate with the journal. If you have an idea for a research topic or a potential manuscript, there's nothing wrong with communicating with them ahead of time and seeing if this would be of interest to that particular publication, rather than writing the paper and then looking around for where you might want to send it. So the real, I suppose, last point I would make is, as any kind of writing one does, try and tell a story when you are explaining and displaying the research you've done in a particular publication. You want to engage a reader. You want them to understand the beginning, the middle, where you went, and the end, and how you arrived there, and why you were doing this. And at the very fundamental level, it's telling a story, and that's what'll keep reviewers interested and editors interested, and ultimately the readers you wish to read your work interested. And the last little point I'd make, and particularly in the field of urology, and this is something we've been thinking about, is to see if it's possible to show collaboration outside of urology. I don't think any field in medicine and surgery is going to solve their problems by themselves. And the more collaboration and interdisciplinary work we can show to get each other interested in our areas, we'll be able to leverage all kinds of other expertise we don't have, and that will make for a more powerful research contribution and publication. So with that, I think I would end my comments. Thanks very much.
Thank you, Professor Bagli, for really stimulating and insightful talk. I would now ask the comments of Professor Bajpai.
Thank you, Professor Bagli. I think you have given us insights into, from your point of view as an editor, as to what are the expectations, the galore distribution of ideas people want to publish for. You have enumerated them gently, but they were harsh facts. People want to sometimes publish for the sake of it. Sometimes they publish data because there's a marker available. Sometimes they want to do it and they find they are nowhere actually. So therefore, this particular signal that you have given is for the youngsters and those who want to publish should be that what impact is it likely to make? It could still be translational value. It could still be something basic science, but it may have a spiraling effect. It might spiral a cascade of events, multiple studies, which will build up into a monument, and it would then come back to us as clinicians. And then a very important point that you mentioned, the collaboration between interdisciplinary departments, because everybody comes with a bag. They come with some ideas, and sometimes they see a point of view from their window, which we have not seen. Therefore, it immensely helps. And let me tell you that when we started looking into biomarkers and genetic aspects, we suddenly found that we were able to treat our patients better. And we were more enthusiastic in talking to our parents. We were able to tell them what long-term prognosis would be. And therefore, it's important. But just to share something with you, rather your views on it, is that Frontiers is a very renowned journal with publications which we look forward to, because people who write in that, they have considerable thought gone into it, which it speaks a lot about what you all have been at different stages. Now you're editor-in-chief, but you must be involved with it for a long time. Now, there is a lot of literature and clinical information available in different conditions. Would you like to set out a kind of a directive or some sort of a collaboration, asking institution that if you have a set of data on these lines, let us put together into a kind of systemic or a meta-analysis, so that let us pool together. You can actually spearhead that. As an editor-in-chief, your mandate is there. You can ask certain institutions which are meeting certain eligibility criteria which you would set in, to ask, we need data on this. These are our criteria. Please chip in with this data. We will see if it goes through the filters, we would have it published. That will give you a kind of a collective information across the globe from departments which you have decided to choose, and a set of conditions where some answers are still hovering around, and maybe we can get some way out of it. So this is my humble suggestion, and I'm sure you would have more insights. And obviously, Professor Piccoli, she would have also some insights on this. We will have her views also soon. Thank you very much.
Thank you, sir, for sharing your valuable thoughts. Next talk is on publishing a research article on pediatric nephrology topics, Expectations of an Editor, by Professor Joseph Flynn. He is a professor of pediatrics in the University of Washington School of Medicine and chief of division of nephrology at Seattle Children's Hospital in Washington. He also holds the Dr. Robert O. Hickman Endowed Chair in Pediatric Nephrology. He has developed specialized expertise in the treatment of childhood hypertension and has published extensively in this area. He is a past president of the American Society of Pediatric Nephrology and is the co-chair of an American Academy of Pediatrics committee charged with developing new guidelines for childhood hypertension. Over to you, sir.
Hello, everyone, and thank you for the opportunity to present this talk at your meeting. I wish that I could participate more than just with this recording, but it is my pleasure to talk about a subject which I am quite passionate about: how to get your study published. So, brief overview of what we'll discuss, including planning the paper, constructing the paper, the publication process, review and revision, and then authorship and ethics. And I'll be showing you examples from successful papers as we go through the talk. So first of all, where do you start with publishing your work? Well, you have to actually think about it as the publication process starting as you design your study. You have to have a clearly defined research question to have a good paper. that includes a strong specific aim and a testable hypothesis. You have to have a study design that's appropriate to your primary outcome. And you need to use the correct methods to test your hypothesis. You need to know what the standards are in your field. You need to estimate sample size. And you need to have a statistical analysis plan. All of this needs to be in place before you do your study, and obviously before you write your paper, because you won't have a good paper unless these things are all in order. Now, the other thing to take into account as you are getting ready to construct your study and write your paper is that there are some standard reporting guidelines that are applicable to certain types of studies. For example, clinical trials are to follow the consort guidelines, and systematic reviews, for example, follow PRISMA guidelines. And many journals, including pediatric nephrology, require submission of the appropriate reporting guideline checklist as supplemental material with your paper. And these are available at this website, and you should consult these even as you're getting ready to do your study. And then the next step, of course, after you've done your study and you're ready to submit your paper, is to pick the right journal. And it's usually a question of who's the audience, who do you actually want to see your work in front of. Many people actually go by impact factor, but I think the audience of the journal is actually more important. You should familiarize yourself with the journals you're considering. You can use these different online tools to help select a journal. And some of these you put in your abstract and they'll give you a list of suggested journals that you might be appropriate for your paper. And pre-submission inquiries to the editor are another method. We get them frequently and we'll tell people whether or not we believe that their paper is actually appropriate for our journal. And then, of course, very important, read the author instructions. Every journal, unfortunately, has different article types and submission guidelines. They may have specific requirements for the cover page, the length of the paper, the artwork, supplemental material. And if you have a question while you're getting your paper ready to submit, ask. At our journal, when you look at the submission guidelines, there's a little spot that says, contact the journal. And that will put you in touch with one of our managing editors who can answer questions about how to put your manuscript together for submission. Now, what about cover letters? So cover letters can be useful. They can help the editor decide if your paper is actually of interest to the journal. If you're going to write one, they should be short and to the point. A long cover letter will not get read. And make sure you have the correct editor and journal name in your cover letter. I never used to think this was a problem, but just last month, I got this letter. And in this letter, they were submitting it as an original pediatric article in Kidney International Reports to our journal, Pediatric Nephrology. Guess what happened to that paper? Did not get reviewed. And then you have to put your paper together, and every paper has a structure starting from the title through the supplemental material, and I'm going to break this down into little chunks. So what about the title? The title should reflect the content of your paper. I think most editors would prefer you to avoid jargon and puns. It might sound funny to you, but the editor probably won't like it. You should mention the study design if it's appropriate, like if it's a clinical trial, say so. Don't make assertions or draw conclusions in your title. Make sure you follow instructions regarding the length of the title, and some journals will want you to have a short running title for the journal for the top of the page in the printed version. Abstract. Now the abstract is often the only part that I, as the editor, am going to read. So you have to make sure you have a good abstract. You should summarize why the study was done, how it was conducted, what was found, and what it means. If you studied something and you have data, include data in your abstract. And then follow instructions regarding format and length. Many our journals require a structured abstract, and if your abstract is more than 250 words, PubMed may not print it in its entirety, and that could be a problem. And don't put too many abbreviations in the abstract. They are distracting. And here, excuse me, here's an example of an abstract from a paper I was a co-author on, where we stated that what was the need for the study, what kind of study it was an observational study, what were the exposures, what were the primary outcomes, how many people were in the study, and then what were the conclusions. So those are the kinds of things you need to include in the abstract. How about the introduction? Well, this also, especially in the biomedical literature, should be short, usually only 2 to 3 paragraphs long. There should be a clear statement of the problem. You do not need a lot of references, and you need to say what you set out to do. What is your specific aim? And if you had a hypothesis you were testing, tell the reader what it was. And here's a cartoon that illustrates these principles. You want to give context to your study. You want to identify the knowledge gap that you are addressing, and then you want to preview for them how you're going to address that gap. And here is a abstract or an introduction from a paper that one of my faculty published a few years ago, and 3 paragraphs long. End of the second paragraph sets out what the problem was. Factors contributing to blood pressure control are not well understood. And then final paragraph says the goals of this study were to, and we also conducted a sub-analysis. So very well constructed introduction. The methods. So the methods are important. You need to make it clear what you did and how you did it. And they're important because they should allow somebody else to replicate your work. Usually there are different sections: subject recruitment, procedures, definitions, statistical analysis. You need to mention the ethics committee review if that involved human subjects, and then if it's a clinical trial or a systematic review, you need to state whether it was registered and where. The results. So in the results, you're going to describe your participants, then describe the data pertaining to the primary and secondary outcomes. The tables and figures should be clear and not excessive. And please do not repeat data in the text that's available in the tables and figures. It just makes your paper longer and less likely that people will read it. And don't add something in the results section that you didn't describe doing in the methods. The paper will get sent back to you, either rejected or for revisions. There's always a table 1 in a paper involving human subjects that describes the study population. Here's an example from a paper we published years ago on antihypertensive medication. Clearly compares different groups of participants in the study. Few more things about tables. The purpose of them is to summarize data to make it more understandable. They are not necessary if you can say it in a single sentence in the text. Make sure all the numbers add up. The reviewers are going to add the numbers in your table and make sure that everything adds up. Make sure you use the right version. People tend to make multiple revisions to their papers, and perhaps by the time of submission, they get confused about which version of the table is included in the manuscript. And then when you get your proofs, if your paper is accepted, you need to double check the tables to, again, make sure everything adds up and they're the correct version. Figures. So figures highlight important findings in a visual way to make the point more clearly, perhaps, than numbers in a table. So, for example, here from our blood pressure study, this figure shows how much the blood pressure was reduced by the medication, and it's a nice visual representation of the data. The discussion. So discussion section, the point of that is to summarize your main findings and then put your study in the context of the existing literature. Very important, don't make mild claims, be modest, limit it to things that you study, avoid speculation. Make sure you talk about the limitations and strengths of your study. Every study has limitations. You can talk about what is coming next. And then again, just like I've said a few times, if you didn't study it, don't mention it. Again, in this cartoon, summarizes what the discussion should do. Summarize the findings, put your findings into context, recognize and admit your limitations. And then what are the implications? How does the field move forward based on your results? Why is it important that your study should be published? And I think a very short, punchy opening paragraph is the key to a good discussion section. So here again, from that, from a study we published on blood pressure in patients with chronic kidney disease, one short paragraph. This study showed that blood pressure elevation was common, that many patients had under-controlled hypertension, and those were the main findings, and that's what's in the first paragraph of the discussion section. Now, a little bit about references. You don't need to reference every single phrase in your paper. Try not to overdo the number of references. You're just going to be asked to cut them by the journal if your paper gets accepted. It's best to always cite primary literature and not textbook chapters, for example. Try to focus on recent literature, unless it's some paper that is so classic you have to include it. And make sure you format them correctly for the journal, because it'll save you work later. All right, so what happens after you submit your paper? So paper will first undergo internal review. Sometimes that's done by associate or assistant editors. In pediatric nephrology, that's done by Dr. Leslie Reese and myself, because we don't have that type of structure. Then a decision is made as to whether it's suitable to be in the journal or not. If it's unsuitable, it will get rejected. If it seems like it might be suitable for the journal, it'll get sent for review, and the reviewers will make recommendations regarding revisions or even rejection. Why are papers desk rejected? Well, usually it's because the editor decides the paper is out of scope. For example, in our journal, we're a clinical journal, and if I get a study of rats that has no clinical implications, I'm going to reject it because it's not in scope for our journal. We might reject because we just published 3 papers on the same thing. Or we can tell that the study quality was poor, or if there's plagiarism, salami science, like you are publishing one little part of a bigger study that should have all been reported together, or you've already published this in another journal and we detected that this is a duplicate publication. You can try to appeal a desk rejection, but they're rarely successful, and it's best to just move on to another journal. Now, suppose your paper comes back, it has reviewer comments, and you've been asked to submit a revision. So ideally, the peer review process will help you improve your manuscript. You do need to address every point that was raised by the reviewers. You don't have to make every change. If you're not going to make a specific change, you have to give a good reason. You have to back up your responses with data and be sure that you're polite and respectful in your response to the reviewer comments. And then when you send your paper back, your revised paper back, it again will get looked at by the editors before anything else. If we decide it still needs more work, it goes back to the reviewers. If we think that the paper is perfect, it'll get accepted. If we think that your revision is non-responsive, it might get rejected at that stage by the editor. All right, now, what happens if your paper gets rejected? Well, first of all, calm down. Close the email and come back to it in a day or two. And at that point, identify another journal to send it to. Look at the comments. Make the changes that are suggested. You know why? Because it's likely, especially if you're working in a narrow area, that the same reviewers that saw it the first time are going to get asked to review it by the second journal. And they're going to tell me, I've seen this paper. It had X, Y, and Z things wrong with it, and the authors didn't make any changes. It's just going to get rejected again. If your paper was desk rejected, you're going to have to resubmit it in the same form. And again, after a rejection, you can appeal to the editor, but it's very unlikely that the editor is going to change his or her mind. All right, a few things about authorship. The International Committee of Journal Medical Editors has some requirements for authorship that are listed here. You have to have contributed to putting the study together or collecting the data or analyzing the data. You have to have contributed to writing or revising the paper. You need to give approval of the version that's submitted. And you have to agree to be held accountable for all aspects of the work. So these are very important. And if somebody doesn't fulfill these criteria, then they don't meet authorship requirements and should not be listed. Now, there are some common pitfalls with authorship. If you have a big multi-author paper, you should discuss at the beginning of the writing process like what the author order is going to be, who's going to be included, and things of that nature. Make sure that you send your paper to your co-authors and give them time to look at it. Don't add honorary authors like your division head who had no role in the paper at all, but they may expect to get added. They shouldn't get added, and don't add them. Few comments about ethical issues. So difference between fabrication and falsification. Fabrication is making up data or results and then reporting them as your own results. Falsification is manipulating the equipment that was used to do the study or omitting important parts of the data. These things obviously are bad and you should not do them. Plagiarism. So plagiarism is something you just shouldn't do. And that's using previously published material and claiming it as your own. You're not going to get away with it. Every journal now uses Authenticate or some other plagiarism detection software, and it's going to get picked up. So just put everything in your own words from the beginning and avoid this whole issue. Okay, a few final thoughts about getting your work published. So first of all, focus on an answerable question. It should be a question that addresses an important area in your field. Clarity and brevity are valued. You're not going to fool anybody by making something 3 times as long in hopes of confusing them. People will see right through it, or they're not going to read it and just recommend rejection. It's important to consult with your mentor or with other senior colleagues as you are doing your study and writing your paper. If you're submitting to an English language journal, for example, and English isn't your first language, either find someone who English is their first language, or have the paper professionally edited before submission. All the major publishers, Elsevier, Springer, Author, and others offer editing services to authors, and you should take advantage of them. And then it can be hard work to do a study and get it published, but it's also rewarding, and hopefully it's fun, and hopefully you've learned a couple of tidbits today that will help you as your careers advance. Thank you again for the opportunity to speak with you. And if you have specific questions, I'm not available as part of the Q&A, but my email address has been on every slide. You can certainly send me an email, and I'll be happy to answer your questions.
Thank you, sir, for guiding the young researchers. We would now like to invite Professor Georgina Piccoli for the last presentation of the day on chronic kidney disease, preeclampsia, and pregnancy, what pediatric urologists and nephrologists should know. Over to you, ma'am.
So let me just see, how can I share the here? Do you see everything?
Yes, we can see.
Okay, so great. So thank you very much for having invited me in this very nice meeting and for giving me the possibility, the opportunity to listen to young people passionate of research and meet at the distance some fantastic colleagues. As Professor Balji said, passion is very important in what we do. And actually, for me, kidney and pregnancy has been a passion this last 25 years, since the birth of my 2 kids, in both cases after quite a risky pregnancy. When I've been invited to talk to you, the first thing I thought about, say, wow, it's something very, very far from what a pediatric urologist thinks it's part of his task or of her tasks. Pregnancy is for adults, not for children. But I will try to convince you in these 20 minutes that there are things that can be very important to know and to reflect about for pediatric urologists and nephrologists. I will start saying something on the effect of a complicated pregnancy on kidney health of the baby, go to teen pregnancies and their risks, and give you some highlights of the effect of kidney diseases in infancy or childhood on pregnancy outcomes. What is a high-risk pregnancy? It's broadly defined as one that threatens the life or the health of a mother or her fetus. And pediatricians are here, young or old maternal age. Pregnancy in teens is per se a high-risk pregnancy. And which are the risks for the mother? Death, of course, high blood pressure, preeclampsia, eclampsia, gestational diabetes, etc., but also the development of CKD over time. and for the baby, death preterm birth, being born small or small for gestational age, besides malformations and other effects that are often linked either to prematurity or to being born small. But are all small babies alike? Probably not. This is the growth curve of a little girl who was one of my first patients, who was born at 28 weeks. She was very small, but she was adequate for gestational age. The mother had complicated diabetes. She is developing very well. This other small girl, 1.5 kilograms, whose mother was, by the way, from India. She fell in love for an Italian and came here. And she had vesicoureteral reflux in her childhood. And she had chronic kidney disease. This little girl, she's very tiny. This little girl was very tiny, but she was harmonically growing and was little for gestational age, less premature, and she's also developing well. Things may be different for a baby like this one, almost 1.7 kg, so big baby, 35 weeks, but he was growing on a rather good growth curve, and then it flattened down. This means that something in the uterine life did not go as it should. And if we look at this beautiful recent study on GKD, we see that small babies, small for gestational age babies, and probably even more small for gestational age babies have a higher risk, for example, of developing end-stage kidney disease in adulthood. So small babies, high risk, low birth weight, low nephron number, and kidney disease. One of the masters in nephrology, Professor Brenner, wrote this fantastic paper 15 years ago, showing and saying, since the maturation of the kidney is very, very slow, kids that are born small and early have a lower quantity of nephrons and, as a consequence, are more prone to develop kidney disease, even without an overt disease. So why should this matter for the pediatric urologist? Because of these. Because of nephrotoxin, because of renal volume, because of the fact that very often, as we will see, these children have further problems, and among them, I will stress it further, urinary tract infections are very important. So we have to be aware of the fact that when a baby is born, for example, 28 to 40 weeks, may have a very reduced nephron number. He's a very high risk baby, also for what concerns our disciplines. And there are some fantastic studies. Those of you who like histopathology will enjoy looking at the slow development of nephrons through gestational ages. But we have also to be aware of the fact that there is a huge variability. These are two images taken from two babies who died in utero at 37 weeks. And you see here, this sort of snail means that the nephron is still developing, while this other baby had very nice and developed glomeruli. So there is not one size that fits all, but what is very important is that when a baby is preterm, the risk for infection and sepsis is very high, and there is a vicious circle for which the sensibility of these immature kidneys is higher and the susceptibility to all kinds of noxe is higher. In this very nice study that was published on pediatric nephrology last year, speaking about perinatal factors contributing to CKD in a cohort of Japanese children born very little, this is very important for us all. The stress in the neonatal period, we can do less here, but we can do a lot to try to identify soon kidney dysfunction and to be very wise in using drugs. In any case, independently from the immediate outcome, let's say, having been born small or small for gestational age has probably a very important effect on the progression of the eventual kidney disease. It's more studied in the case of glomerulonephritis, like IgA nephropathy in this case, but is probably the case also for malformations or CACUT. And we have to remember that the birth weight of a woman induces a vicious circle, because women that are born less than 2.5 kilograms have a much higher risk of having preeclampsia and having a small baby in turn. So what can we practically do? First of all, systematically ask about birth weight in all medical interviews. All children with low birth weight and small for gestational age are at high risk for AKI or CKD, and organize, as we said in the previous session, renal follow-up for children that are at risk, knowing also that small children may have a higher risk of urinary tract infection. This is just one of among many series done on this issue. So as urologists, please take particular care to avoid the nephrotoxic medication of these children in case of urinary tract infection. Choose whenever possible nephron-sparing surgery. Consider being born small as a risk factor for future kidney donation, pregnancy, and so on. Urinary tract infections are often identified as associated cause with preterm delivery. Some, but not all, scientific societies suggest controlling for urinary tract infections in pregnancy and in high-risk pregnancies. However, we do not know if in the population this changes, but we do know that in patients, for example, with previous acute pyelonephritis or malformation, control for UTI during pregnancy may reduce the risk of preterm delivery and probably also of preeclampsia. And this is what the Italian Society of Nephrology advises for patients at risk for urinary tract infection. See them at least every month and half, but perform urinary cultures even if they are asymptomatic every week to 2 weeks, and ultrasounds because dilatation may be more common, and as we said previously, kidney pregnancy may be a challenging test for chronic kidney disease. And of course, be careful with drugs. So what to do? Take care of UTI in pregnancy, consider their link with preterm delivery, future kidney health of mother and baby, take care of UTI in small babies, even in the presence of normal kidney function, avoid nephrotoxic drugs, control kidney function and urinary culture in children and during pregnancy. What about teenagers? Teenage pregnancies are at high risk of morbidity by themselves, and even more if these teenagers come from a deprived milieu, which is in turn associated with a higher risk both of chronic kidney disease and of teen pregnancy. So please be careful, and especially try to see your patients that you have operated as children during their pregnancies, during their teenage. And be careful of several things. Kidneys in pregnancy increase in volume. So a normal kidney may be a small one. EGFR increases, and this may be preserved in CKD, even in last stages. So normal kidney function may not be normal in pregnancy. Normal creatinine should be less than 80% of a normal age-adjusted value. So normal means high. Pelvic size increases, and I'm not saying this to you, size matters, and dilatation on the right side is more commonly physiological. Is it a challenge test? Do we have a limit? Only the future will know. And as in this very nice paper that is now 10 years old, more than 10 years old, was pointed out in the research agenda, there is a lot to be discovered still on this issue. So please, when you see as pediatric urologist a little girl, a teenager who is pregnant, be careful about kidney size. Small kidneys may appear normal. Normal creatinine may be high. Dilatation, especially on the left side, should dress your antennas, and be careful in patients with frequent UTI. And ask for kidney function assessment pre-pregnancy to all your patients, but also your friends and your family. This is not routinely done, and it's a pity because pregnancy is an occasion to diagnose chronic kidney disease. And what about presence of chronic kidney disease? Well, CKD is not synonymous of reduction of a kidney function. One kidney scar, one only kidney scar, defines the patients as with CKD, and even a kidney stone in a little girl or in a young woman defines this as CKD. And CKD is associated with high-risk pregnancies in all its stages. Just a few papers, maternal and fetal outcomes on urolithiasis, a systematic review on the same issue. It's trivial, but having had a kidney stone increases the risk for hypertensive disorders of pregnancy and preeclampsia. And the same holds true even more, also because these diseases are often more important in women with urinary tract reconstruction, the matter of your Congress. And it's easy to think it's just the mechanic. Well, focus also on the kidney function, and focus also on kidney health and on kidney scars. How big is the problem? Is huge, because 3% of women in childbearing age have some kind of chronic kidney disease, and even if those that have a severe kidney disease are less common. And throughout pregnancy, there is a crosstalk between the kidney and the placenta. And this is probably why, if on one side, a poorly implanted placenta may damage the kidney via preeclampsia, even a small kidney disease may affect the development of preeclampsia and lead to adverse pregnancy outcomes that are of different types, both for the mother and for the child. And once more, it's circular. You find small babies, very small babies, intrauterine growth restriction. Of course, the severest diseases have the worst prognosis. But And this is clear, this is intuitive. If a woman has 20% of kidney function, well, probably she will have problems in her pregnancy. But the most important thing is that these starts early. Even a woman with stage 1 CKD, that is normal kidney function, no hypertension, and low-grade proteinuria, has a risk which is 3 times higher to have an early preterm delivery. And the risk goes up in the presence of hypertension and proteinuria, even with normal kidney function or with reduced kidney function without hypertension and proteinuria. Almost 20% of the babies are preterm. There is a turning, a circle between having CKD, having preeclampsia, and having small babies. But what I wanted to show you is not only the risk, which is increased, of developing end-stage kidney disease, even when you have a silent clinical story and just one preeclampsia episode. But the fact that if we look at these women with preeclampsia, we find kidney disease in roughly 20% of the cases. These are my last slides. I'm almost done. So this is a nice study from the Mayo Clinic, and this was a similar study from our unit. 14% of the patients that we assessed had CKD, and actually, when we did a larger study and we saw more patients, up to 20% of them had some kind of CKD. And interestingly, at least in our setting, in most of the cases, it was the case of small kidney malformations and kidney scars. And this is why our scientific society suggests studying all women after a PA episode. So which are the take-home messages of this brainstorming? CKD is a risk factor for adverse pregnancy outcomes. The risk is increased since the first CKD stages. The reduction of the kidney tissue is associated with higher risk, even in the absence of active kidney disease, even when you have corrected everything. Adverse pregnancy outcomes are a marker and or a risk factor for CKD progression in all patients with known CKD. Please take care of UTI in children and pregnant women. Avoid nephrotoxic drugs in small and preterm babies. Consider that all alterations of a kidney and urinary tract are a risk factor for future kidney health of girls and their offspring. So please tell them early, because taking care of children is caring for the future. And with this, I thank you for your attention. And more than that, I thank you for all what you do for our patients. Thank you.
Professor Piccoli. We don't have words of thank. In such a short time, you were able to give us a wonderful talk. In fact, when we realized we can have your audience and we can have you with us at a short notice, we were very excited. Being an editor-in-chief for general nephrology is a huge responsibility, and it also talks about huge about your capabilities. Now, the topic that I decided to choose of the several papers that you have published recently, this topic you have actually definitely modified to an extent that it is hugely helpful for pediatric urologists. That's what you wanted to do. And let me tell you, reading from the descriptions that you have made in the slides, you have talked about pregnant ladies which carry a risk and they have renal injury. I'm talking about this pregnant lady when she was a girl, and that's when she comes to us. We treat these as pediatric surgeons and pediatric urologists, a very common condition called vesico-ureteric reflux. Now it is being offered medical treatment historically for many years. And people say the renal outcomes are same, whether you do medical treatment or surgical intervention. And the whole idea was that of the great Gene Smelly. Obviously, those were different times. Now, one of the indications of offering treatment for reflux by surgical intervention, that is to cure reflux by stopping it, by surgical intervention, by endoscopic injection, or by robotic or laparoscopy, is you treat the child with VUR, the girl child, with antibiotics and prophylaxis till a scar happens. When the scar takes place, then you can go for surgical intervention. Imagine, we have pushed the poor girl to a situation where she now carries the risk in her pregnancy years of repeated abortions, small for dead babies, and preeclampsia, which is precisely what you're talking about. So basically, your recent paper of 2021, which has talked about the risk during pregnancy, I'm talking about this girl, this pregnant lady who was a girl once upon a time, and girls like her who had VUR for that matter. There are many examples, in fact. And she had VUR and she was treated medically, and the nephrologist, pediatric nephrologist, decided to send it to pediatric surgeons for surgical intervention only when they said a scar would happen. Now, when the scar happens, it is irreversible. And that's what I think the core message for us as pediatric surgeons is that we should not take our treatment protocols so lightly. We should be far more proactive in preventing injuries of this kind, because the whole story unfolds when you, as an adult nephrologist, has seen these girls in their pregnancy scenario.
So thank you very much for your comment. And actually, what I have to say that what kills me is when I see a young lady who has a severe preeclampsia. I discovered that she had underwent surgery as a child for VUR, and no one ever told her that she will have to be just controlled more frequently during her pregnancy. So I really think that what you said is absolutely right. I remember when I was young, there was a very well-known urologist who sort of chanted, "Who cares about scars?" But we care about scars. And actually, the more we see the importance of kidney tissue and kidney function, the more we think that probably prevention of preeclampsia should start from the patients you see.
Very right. And in our institute here, for the last almost 30 years, we run a pediatric urology clinic. And in that clinic, we had taken a very stated position. We intervene early on. And we have our own set of indications because we believe strongly that the injury is perpetuated. Once the scar forms, there is a consequence of periglomerular fibrosis. And these glomeruli becomes independent seats of production of renin, which is a damaging factor for the kidney. And therefore, if you push it that hard, obviously you can't reverse. And therefore, we have a slew of material, and we have published it, and still there is a lot of material to be published. We will take your views on this, as we were told by the previous editor, that we should get in touch with the editors and we tell them this is the material we have, this is how we are eligible to actually cross that threshold. And we seek your views as to, especially related to a condition like VUR, which is rampant and which is being treated in a very questionable manner.
I wait for your data.
Thank you very much, Georgina, Professor Piccoli. It was such a pleasure joining you. We knew that you would give us something of food for thought and some more work for the next decade. Thank you so much.
Thank you.
Thank you all for joining us. I would now like to invite Professor Bajpai to the podium for concluding the first day of the conference.
Thank you, Priyanjali. Thank you all the guys and gals who helped us today, and all the people across the globe who not only joined, there were stalwarts like Professor Georgina Piccoli and Dr. Bagli and so many people
who joined at short notice. Let me tell you, the pandemic was just seen to be disappeared. The tail of it is still visible. We don't know what mutation will take place, and everybody had gone through hell. And obviously, we have a job to do. Despite this pandemic, we have been carrying out our academic activities throughout these 3 years also. So it never stopped, and digital platform has helped that immensely. And all of you have come in with short notices, and so thank you all. And we run these courses. We have a day tomorrow also, but we run these courses throughout the year. We have periodic meetings. Just a matter of chance that this year happens to be the Silver Jubilee year, which peaks up into 2023 in February. And so we would love to have you again, Professor Piccoli, in some of the courses so that we can all benefit out of it. Thank you so much.